டீட்டெயில்ஸ்ல ஜாயின் பண்ணிட்டா
எத்தனை பேர் நீங்க கேட்பாங்க போல வெயிட் பண்ணாங்க.
ஆமாம்மா
வேலை செய்ய சாப்பிட்டேன்.
நான் பார்த்தேன்.
ஸ்கிரீன் ஆஃப் ஆகி வருது.
நான் வர லேட் ஆகிடும். மதியானம் நீங்கள் எதாவது செஞ்சுக்கணும். தெரியல மன்னார் வருவேன்.
என்ன செஞ்சு வைக்கிறது?
ஏதோ ஒன்று செய்வீங்க. இன்னைக்கு மேடம் வராங்க. நான் லேட்டாக தான் வருவேன்.
போட்டு போன அப்புறம்
எங்கம்மா வேலை செய்யற அம்மா வரானாங்க. நேற்று இன்னைக்கு வராங்க.
இன்னைக்கு கூட்டிட்டு தான் இருக்கு. அங்க வரணும். அக்கா
நான் மட்ட ஒரு போன இந்த தடவை அலசி போட்டேன் தேன் மதுமா வணங்க விட்டு பாக் போட்டு போட்டி பண்ணாரு மூர்த்தி முக்கிய மனமா
இன்னைக்கு அவ்வளவுதான் உன் வருமானம். அப்படியே ஒரு இப்படி வெறி பிடிச்ச மாதிரி நான் கான்சியஸா உட்கார்ந்தாதான் வேலை நடக்கும். லாங் ஒரு வீக் இருக்காங்க. சரி பாப்பா, நான் பூவோட எடுத்துட்டாலும் சாமி கும்பிடுற போல எடுத்து
போடணுமா? மாத்தி போடுங்க இடையில. ஹலோ, கேப் புக் பண்ணுங்க. கிளம்பிட்டேன்.
ஒரு நிமிஷம் வந்துட்டு போறியாடா? எனக்கு தெரியாதுடா, நீங்க வந்துட்டு போட ஒரு நிமிஷம்.
இந்த சிஎம்இ
எங்க இருக்க?
என்ன சிஎம்இயா? கத்திச்சு காலையில சம சவுண்டு. அதுக்கு ஃபுட் இருக்குல்லம்மா? அது ஃபுட் இருக்கா? பசியில தான் கத்துதோன்னு நினைச்சேன். பசிக்குதான் அப்படி கத்துதான்.
பயங்கர குழந்தை இருக்குது, கை கொண்டு போனா கம்பெனிக்கு பயங்கரமா
மைக்கா மைக் எடுத்து மட்டும் பாங்க சொல்லலாமா? இருங்க மைக் எப்போ வரைக்கும் இன்னொரு மைக் இருக்குல்ல, ரெண்டு மைக் ஜஸ்ட் இருங்க, அதை எடுத்துடலாம். ஆடியோ அங்கே போங்க, ஆடியோ வந்துச்சான்னு பாருங்க. இல்லை ஃபோன் எடுங்க. இல்லையா, இதை எடுத்துடலாம். இதை எடுத்துட்டு நம்ம ஆடியோ செக் பண்ணுவோம். ஆடியோ ஆடியோ ready தானே? Live stream ready? Ready? Sushma, the link ready? Live streaming வரும் பாரு. Just post the link.
Good morning and a warm welcome to everyone who gathered here. MGM Healthcare, in association with IMA, AMS, Chennai Vilivakam, and Ainavaram branch of DNSP and Southeast Asian Academy of Sleep Medicine, cordially invites all the delegates and faculty to the Sleep Masterclass 2024. A small announcement: preliminary quiz will be conducted pre-lunch. Now I would like to welcome the dignitaries on the dais. Dr. Shivani Swami ma'am, Director and Senior Consultant, Narayana Health Hospital, Jaipur. Dr. Jayaraman sir, Senior Consultant, MGM Healthcare. Dr. Meenakshi Sundari ma'am, Secretary of IMA Chennai Vilivakam and Ainavaram branch. Dr. sir, Director of Medical Services, MGM Healthcare. I request Dr. Anand sir to honor our dignitaries with bouquets. Dr. Shivani ma'am. Dr. Meenakshi Sundari ma'am. Dr. Jayaraman sir. Next would be prayer song done by Dr. Meenakshi Sundari ma'am and Dr. Mangala Gauri ma'am. Christian's prayer. Dear Lord, a great physician, I kneel before thee, since every good and perfect gift come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that's mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I rely on. Next is this I am a prayer. I am a prayer. May everybody be happy. May everybody be healthy. Thank you, ma'am. I would like to call upon Dr. Shivani ma'am, Dr. Jayaraman sir, Dr. Meenakshi ma'am, Dr. Sridevi ma'am, and Dr. Tilakavati ma'am for ceremonial lighting of Buddha. Next would be the unveiling of our sleep lab by Dr. Shivani ma'am and Dr. Jayaraman sir. Thank you, ma'am. Thank you, sir. I would like to invite Dr. Jayaraman sir to deliver the welcome note.
Very good morning. Warm greetings from MGM Healthcare. Welcome to this sleep masterclass. Respected my teachers, professors, and the faculties and the delegates, and the chief guest of the day, host director Dr. Sivan Swami, and other delegates. They are going to participate. They are going to join very soon. I welcome everyone for this sleep masterclass. This is the first activity of this World Sleep Day 2024. You all know very well, sleep is a very extensive subject. So nowadays, for the past 10 years, a lot of research in the sleep medicine and sleep surgery, and a lot of targeted AI involved diagnosis and treatment modalities and all. So today, we have lucky enough to have the post director, one of the authority in sleep medicine, one of the passionate academician in sleep medicine, Dr. Swami Swami here. So to teach and update all about the sleep medicine and the sleep surgeries, all about mainly as a respective perspective, EAP perspective, so and the psychiatric perspective, we are going to discuss about the sleep medicine and sleep surgery with the sessions as well as the panel discussion and workshop, and we have a quiz program also. So I request everyone enjoy this program. A few housekeeping announcement. So I request everyone keep your mobile phone on the silent mode, and there is no official tea or coffee break. Coffee tea always available in the counter. You can have a coffee and come back. So we have official lunch break between the 1 to 1:30, half an hour. I request everyone kindly coordinate. And any questions you want, you come to the mic and you can ask the questions. This is a live streaming program, panel program. So throughout India, we are people are watching. I request everyone kindly follow all the this basic things and all. I request kindly coordinate, and we will do the wonderful sleep masterclass today. Thank you very much.
Thank you, sir. Next, I would like to invite Dr. Meenakshi Sundari ma'am to deliver the IMA welcome note.
Morning, everyone. A warm welcome. My speech will be very short. I think it is a combo of a welcome and a thank you speech. Warm welcome to all the dignitaries on the dais and off the dais. IMA, as you all know, it's one of the biggest organization of doctors in our country, almost 4 lakh plus members. In Tamil Nadu alone, we have 1,800 plus branches. So this is a great association, and also the Academy of Medical Specialties. So we had our inauguration just last Sunday. The Academy of Medical Specialties having its statewide secretary as Dr. Jayaraman sir here. Our specialty was launched just last week Sunday, and I'm very honored to have this very first of a massive program in the very next Sunday itself. So this IMA Medical Specialties, like it's an organization, as you all know, within the IMA, like it's going to nurture, cultivate, cherish all its specialty members, including all specialties, medical, surgical, etc., etc. So one of its first kind of this masterclass is inaugurated, and is going well with a very good start from MGM and IMA, Chennai, Villivaka, Mainavaram. It's a very proud moment for me as a secretary. Unfortunately, our president is not here, as he's tied up with some other exclusive program. For IMA, this Academy of Medical Specialties is one of its branch, and we are going to take it to a very next level. We are going to combine it with our Gao Chalandars, go to our villages, and we are going to extend the women doctors wing is going to actively participate, and we have planned more activities in this AMS. So if members are here who are willing to join for this AMS specialties, or not yet joined, please come and join the forum. The more the merrier. And thanks for MGM. I have some other time in the government sector. Like we have some other program today, so I'll be rushing out there. So I may not be there the vote of thanks. So it's a very good, very heartfelt thanks from IMA Chennai Villivaka Mainavaram branch for MGM Healthcare. MGM Healthcare is not the first venture, sir. It's like they are doing almost a 2 years journey with MGM Healthcare. There are so many programs organized and sponsored by MGM Healthcare. A heartfelt thank as a secretary IMA Chennai Villivaka Mainavaram branch to MGM. And as for the presentees here, I've heard that 25 PGs are eager to wait, who's going to be the winner of 10,000 and who's going to be the runner-up for 5,000. Those 25 PGs, I wish them well, because opportunities which pat on our back is very, very less in PG period. Right? Everyone will want us to study, to do our work, to be, carrying out the mundane activities of all those institutions which we are attached to. But who's going to, give us some appreciation of our academic talents? So I'll be very much eager to know who's these two people, and also wishing all the 25 plus members here best of luck in their quiz programs and all the classes. So benefit out of this will be we'll be knowing who the people are, and also we are going to announce Chennai IMA Villivakam branch is going to celebrate its Women Physicians Day. Remember, we celebrated the Women's Physicians Day. There is also the March Women's Day is coming. So we'll be having cultural competitions, academic competitions, talent competitions, sport competition, etc. in our branch. So you are all welcome to participate and compete also. So thank you, and I wish this Master's League class to go on well, and let us learn something. Maybe this is an eye-opener in so many issues. So thank you all for this opportunity.
I would like to call upon Dr. Anand sir to welcome the gathering.
Check. Good morning, one and all. I was just on the second cup of my coffee with Dr. Jayaraman. He actually gave me a wake-up call from my sleep. So, well, on behalf of MGM Healthcare, I wish to welcome the first and foremost all the delegates, because you've taken your Sunday off to attend an academic program on a Sunday. I wish to place on record our heartfelt gratitude and welcome to the course director, Dr. Shivani Swami, who's come all the way from Jaipur. And I'm certain that under Ma'am's leadership and stewardship, we'll have a lovely sleep masterclass through the day. I recognize quite a few stellar faculty, our own, our own mentors and guides, Dr. Sanjeev Mohanty, Dr. Swami Kannan here. So I'm certain this is going to be a good learning program for all of us. So let's keep the masterclass and not fall asleep. Have a great day. And please do enjoy the MGM hospitality.
Thank you, sir. I would like to invite Dr. Shivani ma'am to deliver the welcome note.
Good morning, everybody. And first of all, I would really like to thank all of you to come here on a Sunday early morning. Not really the time for people to get out of home, but I'm sure Dr. Jayaraman has motivated everybody so much that I see such a huge crowd. With that, I would like to extend a warm compliment to the MGM team for having a wonderful and beautiful premises and also maintaining it very well. And on top of that, also being so encouraging to their faculty to arrange academic events, which is definitely going to be worth it. I'm sure you would all find it very, very encouraging to know that Dr. Jayaraman, as we see here, I think he is a force. He is somebody who drives everybody. Sir tirelessly worked for almost a month every day to make this happen. And my sincere compliments, because this really already seems like a success, sir. So thank you for inviting me to this wonderful event. And with that, I hope that all of you have been sleeping well and would not be falling asleep here. Thank you.
Thank you, ma'am. I would like to hand over the proceedings of the scientific session to Dr. Jayaraman, sir. Good morning, everybody. So happy to see everyone here on a Sunday morning. That was so bright and curious. So without making any delay, let's dive into our first sessions. The first session will be chaired by our very own Dr. N. Swami Karu, Senior Consultant and Director, Department of Internal Medicine and Life Science. And I would request Dr. N. Meenakshi ma'am, Professor HOD, Department of Respiratory Medicine, Chettinad Medical Hospital, Chennai. Welcome, ma'am. So our first session will be by our very own Dr. S. Jayaraman, who will talk about overview of sleep-related breathing disorders.
Very good morning. First of all, thank you, MGM and the IMA for this opportunity to start this sleep masterclass. Respected chairperson, Professor Dr. Meenakshi ma'am, and our telemedicine director, Dr. Swami Karu sir, and all the faculties and delegates. So warm welcome. So I will brief you about the overview of sleep-related breathing disorder. So you all know very well sleep generally is an underrecognized condition, underdiagnosed, undertreated condition. So the awareness is a very, very important thing. We are going to discuss in detail about the sleep-related breathing. There are a lot of sleep disorders. I will brief about this. This is Dr. William Charles Dement, father of sleep medicine. He started the first sleep lab, so in the USA. He is the father of polysomnography also. To start with some clinical case scenarios. So this is the 63-year-old male, known hypertensive on 2 drugs, presented to the emergency department with slurring of speech and weakness, one half of the body for the 2 hours duration. So in the emergency room, neurologist evaluated clinically as well as the CT scan and MRI brain, which shows a normal, there is no abnormal diagnosis. Patient was observed in neuro ICU. Past history of sleep apnea test done 2 years before, which was positive, but he advised to use the CPAP and weight reduction program and all, so it will follow anything. So this patient, we advised to undergo the sleep study in view of a previous sleep test and override and history of snoring, from the spouse. We asked the history. So we did a repeat sleep test, which shows a very severe obstructive sleep apnea. And we are advised to use the CPAP after the CPAP titration and weight reduction program and all. Now he's doing very well after the BP control, everything. He's doing well. BP also very well controlled. The sleep apnea snoring, everything under control. He's on regular follow-up with our department. This is another patient who had a stroke. This is a 49 years old male patient. He had a stroke in 2021. The 2 times stroke, 21 and 22 also. So patient is having clinical examining wise, has some atrial fibrillation and all, and the history of snoring and daytime sleepiness, all the classical presentation of sleep apnea. We are advised to undergo the sleep study. level 1 study, which shows a very severe obstructive sleep apnea based on the AXI and the respiratory disturbance index and all. So we did a CPAP titration and we are going to use the CPAP. It's already very good. So CPAP is giving very good to this patient. Atrial fibrillation also is almost is normalizing. Initially, patient took some medications for atrial fibrillation, cardon and all. Now it's almost is stabilized without drugs, only the CPAP. So giving a lot of beneficial to this patient. And this is other patient, same kind of recurrent stroke due to the embolic stroke because of atrial fibrillation, for which we provide the pacemaker insertion. And retrospectively, we asked the history and all. The patient is obese and having a lot of snoring and daytime sleepiness, etc. So this patient evaluated for sleep apnea, which was positive. Again, CPAP titration of that we prescribed the CPAP device. So you can see here there is obstructive sleep apnea which leads to atrial fibrillation in there are several ways. One is the OSA, which causes inflammation and will cause the atrial remodeling and produces atrial fibrillation. And the hypoxia itself is the main triggering factor for the arrhythmias, hypertension arrhythmias, and the autonomic imbalance because of the obstructive sleep apnea, which leads to hypertension and heart failure, which eventually leads to atrial fibrillation. And other mechanism behind is the intrathoracic pressure changes, which leads to heart failure and atrial fibrillation. There are several mechanisms because of the OSA which leads to AF. So other patient, which is 60 years male, complaints of frequency of intubation mainly at night time, nocturnal polyuria, and evaluated by general physician initially the diagnosis of benign prostate hypertrophy and diabetes mellitus and urinary tract infections. So this patient did all the investigations. It's not a diabetic and there is no UT at all. Finally, this patient evaluated by the urologist. The urologist examined everything clinically as well as ultrasound wise. Everything is normal. There is no major decrease at all. So he referred to me for the sleep apnea evaluation. He knows one of the causes of nocturnal polyuria is the sleep apnea. So we did a history and all. Patient had a habitual snorer and BMI is 32. There is obesity and sleep shows AHI of 38 per hour. So we advised to undergo the CPAP titration. After that, patient is using CPAP. Now the symptoms drastically has come down. Follow up after 2 months, no nocturnal symptoms. This is the what is the rationale behind what is the OSA crossing nocturia? There are 3 mechanisms. One is the increase in intra-abdominal pressure, and increase in the atrial natriuretic peptide secretions, and increase arousal, which leads to nocturia. Last case, this is a 55-year-old female, known diabetes and obesity. Patient underwent lap cholecystectomy for calculus cholecystitis. Post-operatively, patient developed a respiratory distress in the form of dyspnea, tachypnea, and desaturated. So in the post-op ward itself, patient received an NIV to maintain the oxygen and other support. Patient requires a high insulin support to control the diabetes. So I was called to see this patient. We evaluated, seeing the patient itself for suspecting the sleep apnea. History is very classical about snoring, extended sleepiness, and weakness apnea by the spouse. So which clinches the clinical diagnosis of OSA. We did a sleep study which showed severe obstructive sleep apnea. CPAP started and discharged in a good condition. So my pre-presentation, another 10-15 minutes, I'm going to talk about that. So as per the American Academy of Sleep Medicine, the international classification of sleep disorder, there are 7 types of sleep disorders. The commonest one is the insomnia. We have a psychiatrist here, Dr. Ramya Ma'am, from our own consultant. She will be joining panel discussion, madam is here only. So insomnia is a very common presentation. Insomnia also one of the common causes of sleep apnea manifestation. One of the phenotype is the insomnia type of OSA. So I will discuss in detail about that. So sleep-related breathing disorder is a very common disorder, and the other one is the central disorders of hypersomnolence, commonly narcolepsy and other syndromes, idiopathic hypersomnia and all. And circadian rhythm sleep-wake disorders mainly is in sick workers, parasomnias, somnambulism, somnolurgy, etc. And sleep-related movement disorders, we have a PLMS, periodic movement syndrome, and there are a lot of syndromes in a neuro perspective. And sleep, other sleep disorders, we come around. There are 7 classifications under the sleep disorders. So sleep disorder breathing or sleep breathing disorder is a spectrum of disease ranging from snoring. Snoring is the first spectrum, and we have upper airway resistance syndrome and sleep apnea hypopnea syndrome and obesity hyperventilation syndrome. Snoring is an abnormal respiratory sound during sleep because of turbulence of airflow in a narrow airway. vibrations from the upper ear wall which causes the snoring, predominantly it's input sound. And there are two kinds of snoring we come across in the clinical practice. All the snorer is not a OSA, like all that is not asthma. Simple snoring due to cold allergy or some sinus infection of cold at all. And different nasal symptom also sometimes cause snoring. Other one is the habitual snorer, sleep apnea snoring. So breathing passage mainly lead to glossal areas narrows, which causes the upper ear narrowing while sleeping produces partial or complete blockage of the upper ear. Obstructive sleep apnea, also called obstructive sleep apnea syndrome, is the most common type of sleep apnea. It occurs when there are repeated episodes of complete or partial blockage of the upper airway during sleep. This is the pictorial diagram. You can see very clearly there is a narrowed airway, and because of the OSA. Prevalence of OSA, India is a high sleep apnea burden country throughout the world. You can see globally 1 billion, and India has the 52 million people suffering from the obstructive sleep apnea. So this is all the symptomatology, day symptom and night symptom. You can start with daytime symptoms, mainly the excessive daytime sleepiness, feeling tired, lack of energy, fatigue, early morning headache, diabetes, concentration, memory problems, IBP, depression, anxiety, irritability, and learning difficulties. All the day symptoms. Night symptoms mainly the snoring and increased frequency of urination. There's nocturnal polyuria, already we have a case here. Irregular breathing during sleep and partner witness stoppage of breathing, night sweats, increased cough. This is one of the reactive airway disease which causes the cough. Any cough, one of the etiology behind is the sleep apnea and sexual dysfunction and palpitations, urinary fibrillation and all. So this slide is very important for the postgraduate and all the practicing doctors. This is the endo phenotype. The last past 10 years, we have a lot of research on the obstructive sleep apnea. Sleep apnea is generally a very complex and heterogeneous problem. So based on the, sorry for the poor quality of this number and all. So based on the pathophysiology, we call it the endotype. It's a form classification. So upper airway obstruction, arousability, and the drive, that is mainly the respiratory drive and loop gain, muscle function. This one we can measure. As of now, research purposes, we can, based on this, we can divide them into the targeted therapy. Based on this, we can give a lot of targeted therapy. So pathophysiology is very, very important. This is the main trace which involves the lot of endotypes. So others mainly for the clinical expression type, we call it as phenotype. Based on the symptomatology, we have three symptomatology: sleepiness, minimal, and insomnia group. Insomnia is one of the common presentation of the obstructive sleep apnea. Insomnia group predominantly occurs in female populations, and the sleepiness group commonly occurs in the male pattern with a obese habitual snorer. And minimal symptomatic group, there is not much history of any snoring or daytime sleepiness, tiredness at all. But they have a lot of comorbid conditions like uncontrolled diabetes, uncontrolled hypertension. We are evaluating for sleep apnea. This is the one important group. And the comorbid groups, metabolic disease, you all know very well: diabetes, hypertension, dyslipidemia, obesity. We call it as syndrome X. Associated with the sleep apnea, we call it as the syndrome Z. This is one of the common comorbid phenotype. Other one is COPD and OSA. This is one of the common overlap syndrome we come across in our practice. And the third type in the comorbid condition is the cardiovascular disease, mainly hypertension, atrial fibrillation, and congestive heart failure. Along with OSA, this is one of the phenotype. And based on the anthropometric measurements, we have the age, gender, and body weight. Age, once age advances, the sleep apnea incidence will be high. And gender-wise, the male preponderance till the menopausal age group, because of the reasons with the hormonal influence in the female patient. And usually, male has the longer, lengthier the upper trachea, which causes the more plastophilia. That's why the OSA actually is a male predominant disease. So till the menopausal time. And body weight, this is that relationship with the body weight. Any increase in body weight which causes overburden in the upper airway, narrowing plastophilia and all. And based on the biomarkers, we have the EXI from the PSG, the fitness testing, and the hypoxic burden, microRNA, the blood level. This is all the we can monitor using the biomarker. We can pinpoint the diagnosis, what kind of OSA it is. Now, based on the mortality, mobility, and the PROMs, and based on the polysomnography, we can divide into two kinds of OSA. One is the rapid OSA, rapid angle OSA. This needs CPAP treatment at the later part also. So we advise use the patient, use the CPAP throughout the sleeping time. Because of the late half, if you use only the first half, 2 p.m., 2 a.m., 3 a.m., you remove the mask. So 3 a.m., 4 a.m. patient develop a lot of REM OSA, which causes a lot of problems. So we advise the patient to use this throughout the sleep from 11 p.m. to 5 a.m., 6 hours. And this is the only thing called the positional OSA we can clearly read from the level 1 study. So treatment is only position treatment, lateral lipid spots. We believe all the symptomatology. Based on the PSG, we see the supine iliac size very high means this is more in favor of the positional OSA. So these are the brief classifications based on the clinical methodology and pathophysiology. This is very important for the target therapy individual treatment. Nowadays, we are all practicing in a era of precision medicine. So we have to have the pinpoint diagnosis and treat accordingly. Not one size does not fit for all. This is the basis we have to follow and see all the patients. So CPAP is not working everybody. Surgery is also not working everybody. So we have to pinpoint and see all the phenotype. This is very, very important for the diagnosis and treatment purpose. So form classification, P stands for peak, that is endopharyngeal pressure associated with the upper airway collapse. A stands for the arousal threshold. Arousal threshold defined as the level of inspiratory effort measured by the esophageal epiglottic pressure at which obstructive event terminates with an arousal of sleep. L for loop gain, that's a ventilatory control system, and M for muscle recovery. There are 20 muscles take part in the upper airway, mainly like glasses, hyoglossus, etc. So these classify patients according to their pathophysiological traits in 3 different groups, subgroups. So form 1, this group involves about 23% of OSA patients and is characterized by a high anatomical collapsibility. That is a bit higher than plus 2.5 centimeter of button. Weight, these patients, treatment modality mostly the weight loss, positional therapy, oral appliances, and CPAP and upper airway surgery are the first line treatment, as these treatment focus on the anatomic factors, these anatomic treatments. Form 2, this is the largest subgroup and involves about 57% of patients with the OSA. It is characterized by an intermediate collapsibility, peak rate between plus 2.5 and minus 2.5 centimeter water, associated with the abnormal non-anatomical pathophysiological traits. These patients are potential candidates for the anatomical treatments. There is no major non-anatomic impairment. This is subgroup 2A. For a combination of anatomical and non-anatomical treatments, more than one non-anatomical impairment. This is subgroup 2B. Form 3, that is this scale. This subgroup involves approximately 90% of the OSA patients with low collapsibility, period less than minus 2.5 centimeter. Associated with the abnormal non-anatomical pathophysiological traits. These patients are potential candidates for the non-CPAP treatment options such as weight loss, oral appliances, oxygen, drugs which target the loop gain or the arousal threshold like acetazolamide, modafinil, solriamfetol, and tonabinol. This is the already mentioned. This is the clusters wise sleep apnea divides into the symptomatic division into 3 groups: disturbed sleep group, minimally symptomatic group, and excessive daytime sleepiness group. So this slide shows the pathophysiological mechanisms and consequences of the obstructive sleep apnea. The main events OSA is the apnea-hypopnea, which eventually leads to sleep fragmentation, hypoxemia, and negative intrathoracic pressure. It leads to sympathetic surge, which causes release of catecholamines, and it affects over the hemodynamic effect on the cardiovascular system, oxidative stress, inflammation, endothelial dysfunction, hypercoagulability, endocrine dysfunction, which eventually leads to the hypertension, cardiovascular disease like hypertension, CAD, congestive heart failure, arrhythmias, and CVA, and pulmonary hypertension. The directly leads to endocrinopathy, mainly diabetes and insulin resistance. The sleep fragmentation directly leads to the sleepiness, which leads to accident and poor quality of life and poor cognitive function and poor activity function. This is called the consequences of the OSA. We have a lot of clinical questionnaire to diagnose whether the patient has a high probability of OSA or the low probability based on the scale. Epworth sleepiness scale versus the daytime sleepiness, Stanford sleepiness scale, Pittsburgh sleepiness quality index, and stop and questionnaire. This is a very important questionnaire we do it in our regular clinical practice. Short questionnaire based on the acute screen patients for OSA. And the other thing is a Berlin questionnaire. So stop and questionnaire is nothing but S stands for snoring, and T for tired, O for observed, and the P for pressure. Band, BMI, age, and next factors. So we would ask the questions to the patients, give the pamphlet to the office secretary to the patients. We would ask the questions like, do you snore loudly, louder than talking, or loud enough to be heard through the closed doors, yes or no? Do you often feel tired, fatigued, and sleepy during the daytime, yes or no? Has anyone observed you stop breathing during sleep, yes or no? Do you have or are you being treated for high BP? Band, BMI more than 35, kilogram per meter square, age more than 50, neck circumference more than 16 inches, and gender difference. So a score of 2 or less is considered a low risk, and a score of 5 or more high risk for having either moderate or severe obstructive sleep apnea. So this is other scale to assess the excessive daytime sleepiness assessment by the sleepiness scale. So this is all the situations we can chance of dosing based on 0 means would never dose, 1 means slight chance of dosing, 2 means moderate chance of dosing, and 3 means high chance of dosing. Based on this, we have classified into 1 if the score is 0 to 6, and 2 if the score is 7 to 10, and 3 if the score is 11 to 13, and 4 if the score is more than 14. The higher the score, which leads to more probability of the OSA based on this scale. And these are the common conditions related to practice, dental medicine, or whichever the practice anesthesia surgery. These are common conditions you have to keep in mind that the common association between the sleep disorder, breathing, and other diseases, the drug-resistant hypertension and severe obesity, congestive heart failure, pacemakers, atrial fibrillation, type 2 diabetes. India, we are the diabetic capital in the world. So a lot of diabetic patients, very uncontrolled, we have to evaluate thoroughly, and all hypertensive and cardiac disease patients. Once clinically, such cases of sleep-related breathing disorder, OSA, the diagnosis based on the sleep study, polysomnography. Level 1 study is a gold standard, and level 1 study usually does it with 7 channels. Sivan ma'am will present it about the PSC polysomnography. It's a level 1 study, and alternatively, we can do the home sleep test with a low. There's a high probability without any major comorbid conditions, without any associated other sleep disorders, sleep apnea, OSA, there is a insomnia, other related ailments and all. So we go for level 1 only. There are 3 levels of home sleep test: type 2, unattended study; type 3 is polygraphy, not polysomnography, polygraphy; and type 4 is 3-channel test, mainly for screening purposes. A lot of technology is coming in for the one sleep test, and a lot of things are coming in, so we can update periodically. And the once you diagnose thoroughly about the OSA, the treatment is multidisciplinary. We involve the ENT surgeon, maxillofacial surgeon, and the bariatric surgeon, psychiatrist, endocrinologist involved. What kind of treatment we're going to offer, whether it's a PAP therapy or non-PAP therapy, like any surgical treatment or oral devices, so we can divide them very clearly into other things. Conservative, this dental measures for everyone: weight loss, primordial prevention, alcohol cessation. Position therapy for the POSA, there is a position associated with sleep apnea. Nasal decongestion help in adherence of the sleep apnea very nicely. PAP therapy, even though it's considered first line of treatment, nowadays we have a lot of innovative therapies, PAP and non-PAP therapies, oral appliances, and various bariatric surgery. Plenty of capabilities to pinpoint the diagnosis. Across the globe, with India being one of the top countries in the OSA prevalence. Timely diagnosis and management of OSA is imperative to avoid further complications in these patients. The level 1 sleep study being the gold standard, home sleep apnea test has been seen to be cost effective and convenient option for high pretest score. No other major, if there is no other major comorbid conditions or no other associated other sleep disorders, so we can do the level polygraphy and all. Treatment is a multidisciplinary PAP therapy, first line, and non-PAP therapy, which includes the oral devices, maxillomandibular advancement devices, clips and osteotomies, and surgeries like kidney surgery, and maxillomandibular advancement osteotomy and bariatric surgery. There are plenty of treatment available now based on the endocrine phenotypes. So AI coming in a very rapid way in the diagnosis and treatment aspect in all the not only our field, every field. So artificial intelligence, AI, precision medicine, you precisely diagnose, tailor-made to individualized treatment. This is very important. Precision medicine is a very, very important thing. And sleep medicine, both the diagnosis and therapeutic aspect will help in a lot. So this is a World Sleep Day commemorative action. They are starting from well advanced. So I request everyone create awareness. I request all the sleep medicine people kindly spread the knowledge across and attend all the annual meetings and other meetings. So whenever you have any meetings, topics, include one topic of sleep and sleep disorders in your presentation. So this way we can create awareness. Ultimately, we are helping the patient. Excellent. So thank you very much for the patient listening. Any questions, I will take them. Okay.
thank Dr. Jairam and truly masterclass in his overview of sleep disorders. Now, as an internal medicine specialist, we always look at what is the implications of the brought up the mechanism of hypertension and the atrial fibrillation, which leads to stroke, and which is very, very important. As we all know, sleep disorders, patients with sleep disorders, they are more prone for developing stroke. The reason is very rightly pointed out. Thank you very much for the wonderful overview of sleep medicine. Madam.
Thank you so much for the excellent inauguration as always, Jairam. And I wish to congratulate you for actually starting this sleep masterclass and for your inauguration of sleep lab also. As usual, I was receiving so much of messages that shows the involvement you are. Thank you so much. This is a very yeah, that shows the involvement which you are. That's why even in the Sunday, I can see so many PGs have come. Maybe because of your motivation. Jairam is my student actually. I'm very happy and proud to say that he is my student. Actually, sleep disorders, as I was also saying, almost 11%, Indian statistics, you see, almost 11% are suffering, 13% out of which males are more. Even in children, we don't, because of all these changes in lifestyle. Even BMI is increasing, and this is a risk factor for so many cardiovascular. Actually, these sleep patients, OSA patients, they land up somewhere. Actually, with a stroke or with a myocardial infarction, then we finally see that it is a treatable disorder. So, early diagnosis and management is very important. Recently, we are having something like a cardiac pacemaker. They are trying to develop some pacemakers to stimulate all these muscles, hypoglossal nerve stimulation, all those things. But CPAP is a best. Thank you so much.
Any questions? Answer. Firstly, I must congratulate Dr. Jairam. He is a driving force. I came here just because every forum has put up this masterclass. I'm very happy, sir. You are doing a very good job. Your colleague and but the point I want to tell you is about snoring. Snoring is always considered as a villain, but I don't think snoring is something. No, snoring is every snorer is not. I made a passing mention about that. Just like all the diseases is not asthma, all those who snore, they don't have sleep. They always snoring is indication of deep sleep. As a spiritual person, there are three kinds of sleep. One is the superficial sleep, the deep sleep, dream. The deepest sleep is the best for us. If anybody has read Ramana Maharishi or any other spiritual book, the deepest sleep is always quoted. Supposed to be near the Atma. So not always that sinister actually. So not at all that supposed to be you straight away subject to sleep studies. No. Go to that. More important to me is the daytime sleepiness. Person who falls asleep very fast. That is the one indication for asking for sleep study. Of course, the question which you told. The other point recently I had it opened me up for the sleep study of sleep medicine was my own first cousin. He had a stroke. What is sleep? Stroke is one of the complications of the vice versa also is true. Post-stroke sleep apnea. Post-stroke sleep apnea. Surprised. He had a stroke, sudden stroke. Then happened for 2 months back in Madurai. Then he developed this obstructive sleep apnea. Why is it calling a stroke? So it is both ways. Sleep apnea can produce stroke. At the same time, post-stroke sleep apnea also. Please remember that. After that, he was on CPAP. That is a problem. One more question is whether once you are labeled as an obstructive sleep apnea, is it lifelong? CPAP, or can it be reversible, or is it lifelong? Because he was told that he must take it to lifelong post-stroke sleep apnea. That's why this is my doubt actually. Whether post-stroke sleep apnea, he said you have to have sleep through to your life.
Pharyngeal muscles are important. They tend to fall back, so they might need a maximum.
I was told by him that lifelong sleep apnea. I was a little rather, my first cousin actually happened. That's why that woke me up actually, and then made me come to this class. Thank you, sir. Thanks a lot. Yeah, madam.
To all cases of insomnia, they have to undergo sleep test.
Yeah, this is one of the clusters called
Chronic
sleep apnea due to insomnia. The female populations are this is different phenotype. So we will evaluate for the whether the patient has OSA or not. Insomnia means insomnia is one of the
sedatives and lifelong.
yeah, we have panel discussion on that. We have psychiatrist that Rania is here. So we have to evaluate whether the patient requires only sedation and sleep hygiene or cognitive behavior therapy, or we have to evaluate for the OSA. Definitely, insomnia is one parcel of sleep apnea only. We have to evaluate for the sleep apnea. But we want to see.
That's so mostly like sir said, that's a different phenotype of sleep apnea which presents as insomnia, which is more common in women. So females, when they suffer from sleep apnea, they may not have loud snoring. They probably may not even have a very high AHI. They majorly have airflow limitation, and sometimes, so that's when we do a level 3 study, we might actually miss the sleep apnea or the airflow limitation component. So for women, they might actually present as insomnia. So for insomnia, sleep study is only indicated when you think that this is actually the phenotype which is presenting as insomnia. Otherwise, for insomnia per se, sleep study is not indicated. Excessive daytime sleepiness may be a symptom of underlying sleep apnea.
Thank you, sir, for the amazing session. May I request Dr. Swamigaru, sir, to hand over the podium to Dr. Jayaraman, sir, please. May I request Dr. Shivani Swamigaru to hand over the podium to Dr. Swamigaru, sir, please. May I request Dr. Shivani Swamigaru to hand over the podium to Dr. Meenakshi, please.
நம்பிக்கை இல்லை எனக்கு தெரியாது போய் பாரு இங்க எனக்கு தெரிஞ்சு தொடையில இருந்து தோல் எடுத்து வச்சு ஆபரேஷன் பண்ணாதான் புண்ணு ஆரம்பம் அதான் எனக்கு தெரிஞ்சது
Thank you, sir. For our next session,
அது எனக்கு
may
தெரியாது
I request
அது என்கிட்ட தெரியாது அது
to
நீதான்
chair the session, Dr. M. Manimaran, Senior Consultant
50 ரூபா
Pulmonologist in your hospital, Chennai, please. And Dr. P.
3 நாள்
Shivraj,
விட்டு
a
வரணும்
very own Senior Consultant General Medicine and
அதான் நான்
Diagnostic.
சொன்னது சேலமோ தரும்பு நான் சொல்ற டாக்டர் போய் தோல் எடுத்து வச்சு ஆபரேஷன் பண்ணணுன்றது நீ இங்க வரேன்னா நான் என்ன
Dr.
சொல்ல
K.
முடியும்
Sridevi, Senior Consultant Pulmonologist, JNK Hospital, Chennai, to chair the
ரைட்
session.
அப்ப அங்க போயிடுங்க
May I
ஓகேப்பா
request Dr. Shivani Swamigaru, Senior Consultant
அங்க
Director
போனா அங்க போய்
of Pulmonology and
இங்க ஒண்ணும் பண்ண முடியாது
Specialty Hospital, Jaipur, for the next session,
ஓகே
please.
வாப்பா வாப்பா வா என்ன பண்ண 50 வருஷம் மருந்து குடிச்சாலா ஐநூறு எப்படி வர சொன்னா வரவே இல்லை இல்லப்பா 30ஆம் தேதி வர சொன்னா வரவே இல்லையப்பா
Sleep apnea routinely for health maintenance evaluations, which questionnaires that Dr. Jayaraman has talked about, and evaluation for risk factors such as obesity, retrogambia, and treatment refractory hypertension, along with diabetes, cardiac failure, or stroke. Then there are positive findings, which should then trigger a comprehensive sleep evaluation. The National Institute for Health and Care Excellence also states that moderate to severe OSA or hypopnea will be diagnosed from patient history and in-home sleep study using oximetry and other monitoring devices. The ASM also recommends that high-risk patients with nocturnal symptoms of sleep apnea should undergo sleep testing, which should include patients who are obese, those who have systolic or diastolic heart failure, have coronary artery disease, significant arrhythmias, or stroke. Patients with congestive heart failure who continue to have nocturnal symptoms of sleep-related breathing disorders, despite optimal management, should also be screened for sleep apnea. Because in these patients, like sir was saying, it forms a vicious cycle that the sleep apnea would worsen their heart failure, the heart failure symptoms would lead to worsening of the sleep apnea, and this cycle can only actually be interrupted when we diagnose and treat the sleep apnea. In patients with hypertension who are maybe on 2 to 3 antihypertensives, still not well controlled, so even the GNC7 actually recommends that resistant hypertension, those are the patients, that is the subset wherein we must actually look for sleep apnea. Type of sleep study sir has already talked about. There is level 1, level 2, level 3, level 4, and when we look at all these, of course, it is scary. Everybody thinks, how does somebody sleep with all these, wires and leads on? So usually it is not a very difficult task. So the patients that we are actually targeting in the subset, those are chronically sleep deprived patients. Those are patients who are practically sleeping on the week. They're sleeping during important meetings. They're sleeping everywhere and everywhere. So for those patients, it's really, they're so chronically sleep deprived that they sleep anywhere and they don't find it difficult to sleep with all these leads on. Talking about the level 1, sir has already said it measures at least a minimum of 8 channels, which would include the EEG, the EOG, the EMG, the ECG, the airflow, respiratory effort, oxygen saturation, and body position. It is usually done in a hospital or a lab setting, and it's completely overnight monitored by a trained technician. However, of course, it is not easy for anybody to have that anxiety wherein they would find it difficult to sleep in a new environment, have somebody touching them while they are sleeping, and all those obviously don't add to the comfort of doing a level 1 sleep study. However, sleep study of level 1, which is also referred to as the polysomnography, still remains the gold standard of diagnosis, and it not only diagnoses sleep-related breathing disorders, but even all the other forms of sleep issues that the person is having, because it is a whole lot of detailed data that is being collected. However, having said that, when we are doing polysomnography, it is also important that we just don't do the study and forget about it. Unless a trained technician or a trained physician is manually storing this data that has been collected, the raw data itself has no value unless it has been manually stored. However, all of this comes at a cost and makes it more expensive for the patient, which I think in the Indian subcontinent is a major challenge for anything that we are targeting cost, because certainly it is not covered by the insurance, and not everybody can, afford a test which is between thousands. Of course, there is the travel inconvenience that the patient would have to come to the hospital, would have to sleep there, may actually get late to work the next day, and all of those things are there. There is, of course, a new environment. It may or may not be completely soundproof, although I think it should be completely soundproof. But, the thought itself of going to the hospital and going to sleep there or having a medical test can lead to an anxiety thought. Of course, there is also the first night effect that, when you are sleeping in a new environment for the first night, it is not the same level of sleep, sound sleep that you can attain. That definitely needs a skilled technician, because in the middle of the night, you should be able to assess if there is any intervention that needs to be done in terms of switching towards sleep lifestyle. Then there is a level 2, which is almost as good as the level 1 in terms of technology. However, it is not completely overnight monitored. Now, level 2 is something that the newer equipment, you can actually do it at the patient's house, but then, of course, the only drawback is that since nobody is watching it, if there is a lead that comes off at night, nobody has actually noticed, the patient will not be able to hook it back themselves. And the other point definitely remains that it needs to be manually scored the next day. The various PFG channels that we have talked about, the EOG, the EEG, EMG, ECG, EFO, the nasal pressure transducer, chest movement, abdominal movement, the pulse oximetry, the snore microphone, body position, and of course, you could also do additional EEG and the ETC, not completely done in Indian settings at least. However, overseas and for research purposes, CO2 is also something that will be moving. Now, all these channels are mandatory, at least in a level 1, are also there in a level 2. And when we talk about looking up these, this is usually, the order that we put them up in, the pulse oximeter being the last to be hooked up right before the patient is about to sleep. When we are talking about all this data, it is compiled and presented in what is called as the hypnogram. It is a convenient graphic representation of the entire night of the patient. Where each sleep stage is actually marked by a vertical axis, wherein REM is actually a darker, broader vertical axis that is. We look at all this data, especially the EEG, which can be very confusing when it comes to, assessing for a respiratory physician and not a neurologist, because we're not. So we definitely need to train our minds to be able to pick up EEGs, and that is where there is a lot of ways again which come into play. I will not be going into the details of today. However, broadly speaking, when a patient is awake, they actually have high frequency EEG rates going up to 113 Hz. When they're relaxed, wakefulness, it is 15 Hz. And one is a lot of theta wave, which is around 3 to 7 Hz. And 2 is characterized by sleep spindles in K complexes. K complexes is a sharp negative deflection followed by a slow positive deflection, and then there are sleep spindles. And there is the N3, which is wave sleep, which has a lot of delta waves, very low frequency around 4 Hz, and then there is the REM sleep characterized sir has also briefly talked about the cardiac events, that not only are arrhythmias important, but also one must be very cautious about picking up asystoles, because that can be life-threatening. Those are patients when we hear that the patient actually slept when he was absolutely stable and did not wake up. Those are patients that we have to be really careful about picking up asystoles and putting these patients in treatment. So this is about level 1 and 2. More or less the same. The only difference being, of course, it is attended. A lot of level 1 studies these days also have audiovisual recording, which is not present in the level 2. Definitely cost of level 1 is higher. When you're doing the level 1, if you have a trained technician, you can easily switch over to a split night if needed, provided the patient has been counseled that you can be switched over to a split night, provided that there has been an appropriate mask fitting done while the patient is being counseled. Manual tap titration is possible with a level 1. If you are subjecting the patient to a level 2 study or titration, he would then be subjected to an auto tap titration, which is definitely not the recommendation, but is a shortcut and sometimes even an effective way. The waiting period may be longer, at least in the government setups. The waiting period, whichever labs have level 1s, the waiting period is much longer compared to the level 2, wherein somebody is probably going home and doing it. And of course, at least in the Western scenario, the waiting period is really, really long. Now, the home sleep apnea testing that sir was talking about, the level 3, level 4. Of course, everything, like I said, has its own position under the umbrella. And even the American Academy actually recommends apnea test studies, provided that the stop back questionnaire that Dr. Jayaraman talked about is qualified. That is, the patient has high probability of sleep apnea as the absence of a significant, whether that is stroke, whether it is cardiovascular comorbidity, whether it is another sleep related. The patient must not have any of these. Of course, they said that the high pretest probability of moderate high OSA, which is like with the stop back greater than 5, is definitely has to be used. And then coming to the level 3 devices. Now these, like Dr. Jayaraman said, have at least a minimum of 4 channels and must at least monitor 2 channels of the respiratory movement and airflow to define an event. And generally, the only thing that is not there is the EEG. So you cannot actually differentiate whether the patient has had any REM sleep or not had any REM sleep. So this is something that we must really be cautious about. This is the limitation with level 3, and hence it is not recommended for people who have any coexisting comorbidity. It usually also because nasal flow, respiratory effort, the saturation pulse, and snoring, which is actually a surrogate marker from the flow. This is how on a level 3 an obstructive apnea so looks, an absence of flow and a reduction effort. However, the effort is present, whereas when you look at the central event, the effort also is missing. Then there can be mixed events wherein there can be, initially there would be no effort as well, and then eventually the patient may have some effort. However, the apneic episode continues. Then there is the hyperapnea that sir has talked about, over 30% reduction in inner flow for lasting at least a minimum duration of 10 seconds and leading to minimum desaturation of 3%. The AHI is again something which is the apnea hypopnea index, is the average of the number of apneas or hypopneas that the patient has had during an hour in the entire sleep. So we grade this. So an apnea of AHI of less than 5 is normal, 6 to 15 is mild apnea, 16 to 15 is moderate apnea, and more than 30 is severe apnea. That's how we grade sleep apnea. However, the new index that we often talk about is the respiratory disturbance index, which is actually also looking at the respiratory arousals, which is definitely also very important because, like I said, that women do not have a lot of apneas, they have airflow limitations. So this is also something that has a lot of bearing on the comorbid conditions and hence definitely should be looked at. And it is very important to say that RDI is also an index which must be looked at when we are looking at the sleep study. If we miss looking at the RDI or the ODI, I think we will not be doing justice to our patient. Of course, after all of this, when we got to know this, COVID came, and then nobody wanted to come to the hospital, and nobody wanted anybody coming home for doing the sleep studies, and that definitely affected the way sleep medicine was practiced. And then we had this beautiful small equipment which came into the market, which was disposable, a newer diagnostic modality. It is disposable, it is doing multiple lines at the same time for each patient, and it actually uses the PAD technology or the photography technology that to assess. It is a multiple line can be done at home, is smaller than a pulse oximetry, hooked up through a well with a Velcro tape to the patient's fingertip, has to be connected to the patient's phone. Only thing they have to keep in mind that the connectivity with the phone is not lost during the day while they're sleeping. We get a failed test. However, the test continues for at least a minimum.
ஆனா சாம்பார்லாம் உள்ள எடுத்து வச்சுட்டு
Nights are done, and it is validated with in-lab polysomnography. But in terms of levels, if you want to place it, it is placed maybe somewhere between a level 3 and a level 4. It does not again give you any EEG. All it gives you is AHI and the oxygen levels, but a good screening tool for sure. It is extended on the analysis of the photophotogrametry. There is a light source, there is a light detector, and as we all know that urethral tissues definitely
போட்டு போறாங்க பாப்பா சீக்கிரம் போட்டு
light is absorbed by the blood, resulting in a lower signal detected by the light detector. And in short, the higher the volume of the blood in the tissue, the lower the signal, and vice versa. And that is the principle that it uses. However, to make matters more complicated, I am sure all of us have heard about the split night sleep study. So what exactly is that? So we are subjecting a patient to a level 1 sleep study in the lab. Assume we pick up a moderate to severe obstructive sleep apnea. Now these patients will be subjected to a PAP titration, wherein we assess that what is the pressure needed for the patient to have no apnea, maintain his oxygen levels, also go have adequate REM sleep with no apnea or hypopnea, and has a good quality sleep. So what is the pressure needed? Now this study is called the PAP titration. In sleep apnea patients, like Dr. Jaraman said, that the therapy is definitely tailor-made. It is not one size fits all. Hence, that titration is important. So when we do a diagnostic night and the second night we subject the patient to that calibration, that is actually definitely adequate. So we were introduced with the concept of doing a split night, wherein in the first half of the night the patient is subjected to the diagnostic part, and in the second half of the night a PAP titration is attempted. However, we always tell the patient that if during the second half of the night we are not able to achieve adequate titration, if the patient does not have any REM sleep, then this titration is incomplete and may still be subjected to a second night of titration. So when exactly can we do a split night study? So the AHI should at least be 40 during a minimum of at least 2 hours of the diagnostic polysomnography. And if the patient AHI is between 20 to 40, however, the apneas are long and repetitive, and there is no saturation happening, or the patient has repetitive dysrhythmia or have asystoles. Those are patients who can actually be subjected to a split night study. So how and when and why to do sleep studies? Ma'am, I think this will answer your question of whether we need to do a sleep study in all insomnia patients. So of course, the first indication is to diagnose sleep-related are having sleep apnea and need to be titrated. So titration studies are also polysomnographies. Evaluation of response to tap therapy, oral appliance, and position therapy. Evaluation before upper airway surgery for snoring or OSA. Evaluation prior to pediatric surgeries, and evaluating response after surgery for OSA. Also follow up if the patient has lost some weight. So either 10% change in weight, whether gain or lose. Those are patients wherein you might have to repeat a polysomnography to see what is their response to the weight gain. Patients with congestive heart failure and symptoms like discussed who are on adequate medical therapy but still have symptoms. And then of course to diagnose other disorders such as narcolepsy, wherein if the patient has a normal polysomnography, the next day he will be subject to multiple sleep latency tests. Diagnosis of nocturnal epilepsy is usually done by the neurologist, and here they would want to look up other EEG channels, also sometimes even to identify the focus. Diagnosis of REM sleep behavior disorder, diagnosis of periodic limb movements, but not for restless leg syndrome, and insomnia only if there is a suspected comorbid sleep condition or there is a failure of response on adequate therapy. However, where is it not indicated? I have something on my screen popping up here. Patients adequately treated with tap therapy, there is no indication to repeat a polysomnography. Parasomnias, excluding nocturnal seizures, seizure disorders that are prominent during the day, no need of polysomnography. Restless leg syndrome, no role of polysomnography. Insomnia, where it is a clear-cut insomnia, where there is no other comorbid sleep disorder expected. Circadian rhythm disorders, other common events of sleep such as bruxism, nightmares, sleep study is not indicated. Of course, there could be interfering factors. We discussed the first 9 effects. The usual question that we are asked when we advise the patient that the regular medication that they're taking are supposed to continue taking it. Yes, they are supposed to continue taking it. Even if the patient has been on a sedative narcotic for a very long time, even that they have to continue. What we are trying to monitor is the patient's routine sleep. If we abruptly stop his benzodiazepines or any hypnotics that he has been taking, that is also going to have an effect on sleep. So definitely has to be continued. Equipment issues that we contribute to polysomnographic inaccuracies, like the electrodes coming off, the technician falling asleep, not assessing whether it has come off. The polysomnography may have to repeat. Tap titration and split night. If you haven't reached adequate therapy pressures, then of course it will have to be repeated. And definitely there has to be an adequate sleep. The patient has not been able to sleep, and definitely they will have to repeat the polysomnography. Excuse me, I have something popping up. Now, I think like every medical procedure, there is a lot of time that we will have to need to spend with the patient, explain to them what all to expect. We must really counsel them that they would have to sleep with all these leads on. We would have to address basic, simple questions like they will be able to use the washroom, and the technician is going to be there to monitor them if we are doing a level 1. All these things have to be answered to alleviate the patient's apprehensiveness. Of course, the patient's regular sleep schedule has to be mind. We have to keep in mind that clean up an entire level 1 lab would take at least 45 minutes, even for a trained technician. So if the patient usually sleeps at 10:30, we cannot expect them to come at 10:50 and then go off to sleep. They would have to be awake for at least 45 minutes while they're being put up. So we always ask the patient to come by 9:30, have their routine meals, have their routine regular medication, come in comfortable rooms. For male patients, we also tell them to preferably shave off their facial hair. For all patients, we also say to shampoo before coming, do not apply any hair oil, because even that would have electrical interference. Routine medications have to be taken, like we discussed. Alcohol. Again, you would have a subset of patients who would probably be consuming alcohol every day. So what to do about that? So we usually do not advise these patients for a level 1 study because I'm sure it can be a challenge for them to, walk into the hospital having afternoon drinks. So maybe advise them a level 2. However, they can have their daily whatever drinks that they are used to. Otherwise, even that is going to interfere. And patients who are evaluated for narcolepsy or are on any medication, that of course has to be kept in mind. In fact, any medication that the patient is on has to be made a note of because a lot of them can actually interfere with not just the amount of sleep but also the pattern of sleep that you get. And that is something that we must always keep in mind. Now, the ASM recommendations, we've discussed that definitely sleep apnea. Today, if we talk about the prevalence, like Sir said, it is huge. There is a very recent paper which says that actually in 23, the prevalence is going to be in India alone not 52 million but 104 million. A very recent paper which came out in 2023 by Tejas et al. And it is a beautiful paper. It says 104 million. So that is the magnitude of the problem. And like Dr. Jayaraman has highlighted that it is not just a problem in itself. It is a problem which is actually leading to a lot of comorbidities. It has a bearing on a lot of diseases. And other than that, of course, leading to impairment of quality of life, not just professionally, but even socially. A major cause of divorce overseas, so even snoring. Of course, when it comes to home sleep apnea testing, it is an alternative and not the alternative to polysomnography. Polysomnography still remains the gold standard of treatment. However, wherever there is not a severe comorbid condition expected, those are patients who need screening. They can actually have it at home. A patient who is not willing to come to the hospital and wanting to sleep with all that equipment on, probably subject them to a level 3 so that they are convinced that they have a problem. And if they have comorbidities, then subject them to level 1. Of course, all of this will come at a cost. However, when we recognize sleep-related breathing disorders early on and it would actually save the patient a lot of healthcare costs and comorbidities. And hence, we must really keep our eyes open when we are evaluating these patients in the OPD and be very watchful for sleep-related breathing. Thank you.
Oh, mic is mic only.
Thank you so much, Dr. Shivani ma'am. It's been wonderful having you with us here in Chennai today. And when I had a short chat with you in the morning, I think like she's not traveled from Jaipur straight away. I think you had to be in the NATCON session as well, and then you're here. So it's been real pleasure having you with us. And you have really simplified the topic, I think, for everyone to easily understand. And thank you so much once again. Just a small question, like how much investment we have to think, like if you have to set up a level 1 sleep lab in our hospital?
Yeah, so I think a level 1 sleep lab would cost you around somewhere between 10 to 17 lakhs, depending on what equipment you choose. And definitely, I don't really just go into that cost. It would also involve training a good technician because the moment they get trained, I think they do. So that's definitely always a challenge, at least on our side of the country. And you obviously have to spend a lot more to increase awareness amongst the doctors in general.
Thank you so much.
So in diagnostic, like I said, sir, a minimum of 2 hours, and in therapeutic, at least a minimum of 3 hours with definite REM sleep. If there is no sleep in those 3 hours, then we don't consider it an adequate titration.
Shivani. See, as an internal medicine guy, we just where do we ask for the sleep study or the PS? Usually, we see a lot of hypertensive patients. We handle a lot of hypertensive urgencies and emergencies, and these patients are on multiple drugs. They present with resistant hypertension. So this is one of the major indications with other risk factors they have for OSA, and OSA is one of the secondary causes of hypertension. So that's one of the main indications. And as Madam was mentioning, when you interpret a BSG, like a polysomnography, there's a lot of data. Like nowadays labs, like they have that, they give a lot of data points. We should make sure like what we are looking at. And she has clearly emphasized that we have to look at AHI and RDI. And the third thing you were mentioning about the one sleep study, that OST. Can you just much more clarity?
Sure. So, it is like I said, it is a very small equipment. It is smaller than a pulse oximetry, which actually comes with a Velcro tapes. So the patient actually has to just slip it on their fingers, attach it with the Velcro tape, and attach it on Wi-Fi or Bluetooth with their phones. It gets connected, and the data is actually stored in the cloud. So what it does is, A, it is disposable. It can only be used for one patient at a time. And it does multiple nights, because also there are studies which show that if you are only doing sleep study for a single night, you might actually be undermining the level of the problem, or maybe actually just missing it altogether. So when you do it for multiple times, that is actually a much better marker of the patient problem that he is having. The only limitation is, of course, that it is giving you only AHI and oxygen saturation. So it is a good screening tool if the patient has multiple problems, because sometimes they don't want to sleep. There are certain subsets of patients who will be very irritable to sleep with them. So in those patients, you can actually do it for somebody who's not wanting to come, or somebody who has a mild problem or has a moderate to severe problem with no comorbidities. For those patients, you can actually do it at home. The data gets stored in the cloud. You put an email ID while you're registering the device. So the report actually at the end of 3 successful nights, the report goes onto that email ID, which can be yours, which can also be the patient's, and they can come back to you with it. So it gives you an AHI, it gives you the lowest saturation, the minimum saturation, the average saturation, and all. So you know at least to rule in or rule out sleep apnea. And once you rule in, even if the patient needs a level 1 polysomnography, it is very easy to convince them that this is what your AHI is, this is what your level of oxygen is going down to. I think one thing the patients have become very, very receptive about after COVID is the level of oxygen levels. Everybody understands that. So I think that has definitely added knowledge to them, and it works in our favor because they have become very receptive to that. So I think it's a really good.
So, Shivani, just a basic question about the home sleep study and the hospital-based sleep study. Outcome and quality-wise, any difference or other things in a corporate hospital setup, such as home study will be face any difficulties?
Quality-wise, sir, I think, like I said, that even if you have a level 1 or a level 2 study, I think it is mandatory that at least a trained person is assessing the data, integrating the data manually. The automated reports are usually not sufficient. So if you're doing a level 1 or a level 2 sleep study and then just handing over the automated report to the patient, I think we are not doing justice. That is a quality issue that I always feel that there is, and which must be addressed. So if we say a level 1 study, although we only actually talk about the channels and be monitored, but I also think that it should always be manually scored as well. However, if we are not doing the manual scoring and we are doing a level 3 study, the challenge is that it is not giving us any EEG data. So if we are doing a level 3 study, we will not know if the patient has gone into REM sleep or if the patient has had any supine sleep. So these are two things that we know that the active spells are going to be much worse in REM sleep or in supine sleep. That is also the thing that we might miss. We also might miss patients who have only REM OSA supine OSA, the positional OSA, or females who have only airflow limitation. Because in all these cases, we could get a false low AHI, and we would look at the AHI and maybe feel that the patient is working. So those are definite limitations, and we must remove.
20% variability between manual scoring and
I just want to say there is a 20% variability with the manual scoring and automated scoring. So always, even with the automated scoring, if you manually score it, your AHA tends to be a little higher, and all the data tend to be a little higher. The variability is somewhere at 20%. It's very significant.
Also, the automated scoring may always not underestimate the airflow limitation. So that's also one thing that we might end up missing.
So even if you're trying to do a level 3 with the basic 3 leads at a home, then it is good to have a manual titration tool. Sorry, manual scoring tool.
Good morning, ma'am. Very, very wonderful presentation you have given, and as ma'am said, it was really simplified. I'm Dr. Swapna from ESIC Medical College. Usually, we get our insured persons from various industries, which are also shift workers. So we found the need of having sleep consultation clinic in our own hospital, which we actually to go with some other test that can help. Thank you.
Thank you, ma'am. Very valid inputs in terms of one sleep test. So I actually used it for my father also. I'll be very honest about it. And I think we also have to tell the patients not to have red liquid. Even that actually interferes. So the red liquid also might actually interfere with the weight. So that's one thing. The inner order mehendi that I think we apply in the Indian would also interfere. So those are things that the patient also has to be told. The second thing in terms of connectivity, like I said, we have to make sure that it is closer, the patient is closer to the phone at all times. If they get up and go to the washroom, by the time they come back, it is actually disconnected from the phone, and where you might get a failed test for that particular night. The second point that you raised, that they give the name of a particular consultant, I think that's a company issue. You tell the representative. Yes, I think that's a company issue, because initially, because when it came out, they had to have somebody who was, trained this thing to have on the panel. I think they had some ethical and problems. So I think that's something that we discussed with the company representative. The third point that you made was about the REM sleep apnea. So they don't even actually claim to give you the REM sleep apnea, and no level 3 test would also anyways give you. And when I said that how we place this, so we actually place it between a level 3 and a level 4. So we don't even actually call it a level 3. So however, by the AASM, it is actually recommended because it uses the patent of PPG technology. So it is validated by the American Academy of Sleep Medicine. However, not for diagnostic REM sleep apnea. For that, you will need a level 2 or a level 3 test for sure. Sorry, ma'am, what was the fourth comment?
It was the sharing, but I came across like one more issue. It's the ethical issue. Like whatever data we are is coming to us is also going to the company, right? So suppose if it is our hospital, and I'm not ready to share my data of home sleep test with the company, so I need to have that thing in between, the kind of the agreement between the company and the hospital or the tertiary care hospital. So to share the data with anybody.
So actually, I think at least as far as I know, I'm sure the company representative would know better. But I don't think it is actually a cloud stored data. They do not have access to the data. The report only goes to, is Premaji here? I am not sure. Anybody from ResMed here? Premaji, where is Prema?
The answers you get, otherwise we'll association will clarify our doubts.
So at least as far as I know, that it is not accessible to the company.
You send patients to lab, various labs. Your data is safe. Not safe.
It is not safe.
It is there everywhere.
This is actually
You're raising a question where there is no answer.
they have to accept, and there is a teething trouble, madam. AC is your AC. And I think already I have attended at the AC. Already got through. These are the minor practical points, and there are certain limitations. We have to rely and depend upon the sharing of data, and limitations are always there. They also there as well.
Yeah, I know it's getting wrong. You should have a separate. I'm also VS hospital taken just retired. I just wanted to know. We have a separate session on the interpretation.
Yeah.
All those curves. That only that will sort of, because this is for GP also. For example, this IMA also related. If you have a session. Okay, because people have acknowledged they send these reports and ask to give a report. We got an artificial intelligence.
Can I just make one quick comment? So ma'am, since you came from ESIC and you were talking about shift work disorders, I think we also have to be aware that all of these major disasters that have happened, whether it was the Bhopal gas tragedy, whether it was the recent traffic accident which happened in Vidarbha, wherein everybody was, in the bus driver had actually fallen asleep, whether it was the plane crash, the Mangalore plane crash. So all of these actually sleep-related breathing disorder was in the health form of it. So I think that is how aware, especially in a setting like yours, we have to pick up these patients, treat them, because we can actually be saving multiple lives. In fact, we are trying to drive a point to the government wherein all people who deal with commercial vehicles or any transport mode in terms of dealing with multiple lives, passengers, whether it's railways or pilots, they should be screened for sleep apnea at least. And what you were talking about, stop and questionnaire, I think that was your last point. So it is a questionnaire to ascertain the probability of a patient having sleep apnea, and the sensitivity of a person having moderate to severe apnea with a score of over 5 in the stop and questionnaire is around 80%. It is not the gold standard, and the gold standard for diagnosis still remains the polysomnography.
It's wonderful talk, and we summarize most of it. We have a very robust multidisciplinary team here. I hear from this place, Indian, heading the Indian, and we have close association with the pulmonology and everybody else. Now, off late, we've been practicing for the last 5 years, but off late, I'm getting a lot of patients who have never actually slept in the night. So they are on the US timings, working 5 days a week. When they ask me, can I do a PhD in the morning? I have no answer. Overnight sleep schedule, no, there's nothing called overday or whatever terminology you want to put it. So that cluster of patients between 40-50 age group who are the so-called upwardly mobile program, they've been working with the US timings. What is your experience? And that is the first one. How do we test them? We didn't dwell with radiology much because that's the area where I'm more concerned about the upper respiratory tract. That's okay over a period of the next few hours, probably we'll get into that. I would like to just focus on the level 1 to 3 that we spoke about, the ones who are probably addicted to social alcoholism or the drugs. When the REM sleep is not continuous, and we need the repeated attacks there, repeated events there. How do you test, or is there a titration mode? Is there some kind of a calibration that you do?
So in terms of people who have shift work, who are working in shift work, and we want to do a polysomnography, so we usually try and stick to the time schedule that they sleep, because their body is habituated. Having said that, for them, like you pointed out, sir, that the REM sleep is definitely going to be of lesser quantity and poorer quality, even during the day, even during their free working hours, and that is because of the light queue. We are not, light queue is not aligned to the US or free time. So definitely that difference exists. However, we advise them a sleep test at timings that they usually are used to sleeping at. For alcoholics or drug addicts, like you said, for somebody who is doing socially and not consuming it every day, we tell them not to have it on the day of the study. However, when it comes to titration, those are patients wherein we would want to maybe titrate on an auto CPAP, do a titration study for 1 night, or maybe give them an extended trial for 7 to 10 days of auto PAP, and then assess that data, rather than just handing them over to
That
Thank you so much, ma'am. Dr. Jayaraman sir to hand over the motto to Dr. Shivani Swami. May I request Dr. Shivani Swami to hand over the motto to Dr. M. Manimaran, please. I request Dr. Shivani Swami to hand over the momentum to Dr. Peesh Baraj, please. I request Dr. Shivani Swami to hand over the momentum to Dr. Sridevi, please. Thank you so much, ma'am. A quick announcement. The post-graduation quiz preliminary round will be conducted pre-lunch session. For now, we'll be having a lucky draw session. Dr. Shivani Swami will announce the first lucky draw winner.
I'm not responsible for what I'm picking up.
It's Dr. G.S. Chandra.
Is our AMA leader, is former vice president. So 2027, so we become the state president of our AMA. We're all Chennai AMA or so please.
So, okay, Dr. Jayaraman will pick up the next lucky draw winner, please. It's Dr. Anisha. I think this from our hospital, MGM Health.
Oh yeah, please.
Thank you, sir. Thank you, ma'am. For our next session, may I request Dr. Sanjay Mohanty, Senior Consultant HOD, Department of ENT, Head and Neck Surgery, MGM Healthcare, to start the session, please. And Dr. C. Chandrasekhar, Professor HOD, ACS Medical College and Hospital, President Association of Pulmonologists, Tamil Nadu. And Dr. Haripriya, Senior Consultant, ENT, Head and Neck Surgery, MGM Healthcare, to start the session, please. For our next session, may I request Dr. Vijay Krishnan, the speaker. He'll be talking about ENT perspective of obstructive sleep apnea. May I request you on the dais?
Small announcement. Those who want any coffee, tea, and all, always there in the ATM, please go and come. So we have a registration desk. There is one attendance seat. Those who want any CME credit points from DNMC, please write down your name, then the registration number, and the email ID and mobile number. In the registration, there is attendance seat is there. So kindly make note of that. Any newcomers joining, please put your name in the small piece of paper in the lucky draw board. So every hour we'll keep and give you the lucky draw prize. So that you 1 hour, 2 hours, we take it.
Good morning, friends, colleagues.
outset, I would like to thank Dr. Jayaraman, Dr. Sanjeev Mohanty, and the entire team for inviting me for this sleep masterclass. After 2 great lectures and discussion, I'd like to discuss on our perspective, that is ENT's perspective of OSAS. Myself, Dr. Vijay Krishnan, ENT surgeon from Madras ENT Research Foundation, Chennai. And I would like to place my sincere regards to my mentor, Professor Mohan Kameshwaran, and also Professor Colin Sullivan and Professor Christine Blumen, from whom we have learned a lot. So we all know obstructive sleep apnea is a common disease of both adults and pediatric age with myriad of presentation. It is a spectrum of disorder. It could be a mild snoring, what we call it as primary snorer, or it could be severe OSAs. As the name implies, it is a syndrome. It is not just an upper airway disease alone. So that you have to keep in mind when you are treating these patients. So just to have an overview, we have to understand the concept of airway obstruction. Here you can see this is a normal person's airway and the bony compartment. When the bony compartment becomes smaller, that is in facial asymmetry or retrognathia, hypoplastic maxilla, the airway is getting compressed. At the same time, if the thickened soft tissues, the soft tissue surrounding the airway is more in obesity, then that also can compress the airway and cause airway narrowing. In obese retrognathics, that is, it is much more severe, where the box is also smaller and the soft tissue is also more, and it causes very severe OSA. So, diagnosing on ENT's perspective is mainly to understand where it is getting obstructed. So, simple X-ray of lateral view of nasopharynx cephalometry will give you the static obstruction. So, we broadly classify the obstruction of the upper airway as dynamic and static obstruction. So, static obstruction means the obstruction is there throughout the day, whether the patient is awake or asleep. For example, a tonsillar hypertrophy, or gross septal deviation, or turbinate hypertrophy, or a nasal polyp, nasal pharyngeal mass. So these are all static obstructions which is present throughout the day, but still it gets aggravated when the patient goes to sleep because of the dynamic component. So the dynamic component is mainly because of hypoplastic, hypotonic muscles of the palate and the tongue, and that can be diagnosed with dynamic MRI, what we call it a sleep MRI, and also fiber optic nasal endoscopy, maybe an awake or drug-induced sleep endoscopy. And we had a great discussion on identifying the physiological aspect of OSA with level 1, level 2, level 3, etc. So these mainly for as a surgeon's perspective, we would like to know how much severe the OSA, and also mainly we want to know the component of central sleep apnea. If the age is 30 and 25 AHA is on central sleep apnea, we may not like to take the patient for surgery. So the component of central sleep apnea is very important to take up the patient for surgery. So simple X-rays of nasopharynx can diagnose different grades of adenoids, especially in pediatric age group, but also in adults, adenoids is much more common. So we all know these gradings, and I'm going to go in detail. And this lateral cephalometry, we get a lot of details about the soft tissue and also the bony landmarks. Here you can see the steep mandibular plane, narrow posterior space, and increased length and width of the soft palate, 80 meters thick soft palate, and very narrow posterior space, and the mandibular plane, etc. But this is mainly concerned when you are dealing a patient with hypoplastic and retrographic maxilla. There are a lot of values. So if we grossly see, as an ENT surgeon, if we grossly see a patient with retro mandibular or maxilla, we discuss with our facial maxillary colleagues and proceed further. This is about the soft palate length, with tongue length, with all these data will help. And also very important to understand the increase in cranial base length and which influence the position of the maxilla in relation to the posterior airway space and also the mandible in relation to posterior airway space. So all these are discussions when we are dealing patients with, as I told you, hypoglossal maxillar mandible. There are a lot of prior imaging techniques available like optical coherence tomography, dynamic MRI. Each has its own pros and cons. The ideal technique should provide safe, accurate, and definitive measurements in the supine position and also in various positions. And it should allow for three-dimensional volumetric reconstruction of the upper airway and its surrounding tissue and cranial pressure structures, which is mainly can be understandable by dynamic MRI or a CT, not with a intrathecal sleep endoscopy or fiber optic endoscopy. And it should allow for measurement during wakefulness and sleep. So when we do a diagnostic sleep endoscopy, we introduce the endoscope just before the patient goes into sleep so that we will know the anatomy of the airway before inducing the patient into sleep. So in dynamic MRI, we ask the patient to have a natural sleep in an MRI gantry. Usually, as Dr. Shivani said, these patients can sleep anywhere, even in a heavy 90 decibel, 100 decibel sounds in the railway station, they can sleep. So these patients can sleep in an MRI gantry, and very few patients may not be able to sleep. In that situations, we have other options. So the MRI study, we can get both axial and sagittal view of the neck. And it is basically a balanced phosphate echo sequence of lakhs of images which will be made into a cine mode to create a video. And collapse of 50% of upper airway space or posterior airway space is considered significant. So this gives a volumetric data analysis, including three-dimensional reconstructive images can be made. There is no radiation and allows repeated measurement, though it is not much easily available overseas. And in this palatal phenotype and the airway can be assessed. So this is for comparison of a normal patients in the MRI and a sleep apnea patients. You can see how thickened edematous of palate and narrow posterior airway space, and you can see a lot of fat deposition in the nape of neck and in the chin area. This is a dynamic MRI where we can, in the software, if you put in, you can measure the length of the soft palate and the width of the posterior airway space at the level of posterior nasal spine to the posterior pharyngeal wall, and also the posterior airway space between the tongue base and the posterior pharyngeal wall, and also you can measure the tongue, length of the tongue. So this is basically a dynamic MRI which we put into the software and you can analyze. It's a video mode where you can see thickened soft palate which is causing obstruction. And here there is adequate space, and here also there is no obstruction. You can even see the epiglottis, which is not blocking the airway. This is a syndrome in children where you can see a huge adenoid which is blocking the airway, and the soft palate is being pushed forward. This we call it as, according to Fujita's classification, type 1 collapse. That is, obstruction is mainly in the retropalatal region, and you can see the epiglottis, tongue base, posterior space at the level of tongue. Everything is normal. There's a type 2 collapse. What we say it's both retropalatal and retrolingual. You can see, if you remember the previous video, you can see the tongue base is almost touching the posterior pharyngeal wall, and in this, more than 50% narrowing of the posterior space is considered significant. Here you can see the epiglottis, which is almost touching the posterior pharyngeal wall and causing obstruction. And this is the palate, is also causing obstruction in the lower. So by knowing this sagittal view, you can assess how much you want to resect. In this situation, even you can resect up to this level is sufficient enough. You don't have to go up to this level of nearer to the posterior or attachment of the soft palate. So by this view is not available with the sleep endoscopy. So this is a type 3 collapse, that is only the tongue base is getting obstructed. You can obviously see there is a retrognathia. So the box is smaller and the tongue is huge enough, not able to accommodate. So it is causing obstruction, and you can see the palate is very thick. Though you can see there is narrowing at the level of palate, the palate is actually being pushed by the tongue, not the palate itself is the reason for the obstruction. So there are various patterns by which you have to assess and decide which surgery will be better for that patient. So according to Fujita, we have retropalatal and retrolingual or exclusive retrolingual obstruction. But that alone is not sufficient when we plan what type of surgery we would like to do. So in tongue base itself, we have a Moose classification where we see we broadly divide the tongue base into upper tongue base and lower tongue base. And you can see here there is an upper tongue base obstruction. And here there is upper tongue base along with the epiglottic obstruction. And here this entire tongue base upper and lower along with the epiglottis. And here it is only epiglottic obstruction. So different pattern of obstruction has different surgical options. So when you come on to another aspect of evaluation, which is drug-induced sleep endoscopy, there is the sleep endoscopy which was introduced by Prof. Prindle in 1991. So we have almost crossed 30 years in this, but still we are not able to do it as we were discussing during REM because it is a drug-induced sleep endoscopy. If we can do drug-induced sleep endoscopy in natural sleep, that would be an ideal technique, but still it is very difficult without stimulating the patient from sleep doing an endoscopy through the nose. So it is later modified by Professor Desirian and Wong, and we use pharmacological agents for sedation, for inducing sedation, and the target depth of sedation is very important when you do this endoscopy. If you give more drug, sometimes the patient go into deeper or depth of sedation where every muscles will start collapsing and causing obstruction. And we evaluate through an endoscopy. So preoperative anesthetics other than the sedative agent should not be used or should be avoided. Informed consent is very important, and sometimes even tracheostomy may be needed in severe OSA patient because suddenly the airway may collapse, and it is usually these airway will be very hyperactive. It is very important to have a tracheostomy consent and even sometimes a tracheostomy table by the side. And nil parole for at least 4 to 6 hours, and anticholinergics like glycolic or atropine can be given if the patient has hypersecretion. And topical vasoconstrictors with minimal local anesthetics can be used, though in a gel form, not in a liquid form, so that it won't anesthetize the upper airways. Preferably in OT with the anesthetist by the side, or in a high dependency unit. Dim light with reduced room noise so that we create an environment for the patient to get into sleep. As I told you, this dexmedetomidine, which we commonly use, give sleeper, which is which can be monitored with bispectral index score, that is BIS score, where we keep it between 70 to 80 or 65 to 80, so that we maintain that superficial depth of anesthesia, so that the patient will not get into central apnea. Target control infusion or infusion pump is being used instead of bolus infusion. Should have undergone a sleep study before diet so that we will know what will be the patient's lowest saturation, how his lungs and the oxygen saturation level will be displayed. So AHI, lowest saturation, ODI, BP, and heart rate, all you should be knowing before doing diet. Whether the patient is on beta blockers, and what is the heart rate, everything is important when we use dexmedetomidine, which can cause bradycardia and hypotension. So, patient is in supine position, and usually surgeon will be on the head end or the right side of the patient. So depth of sedation, as I told you, has to be monitored, and more depth, greater loss of muscle tone, which can induce more collapsibility and cause central apnea. Propofol, midazolam, the previously used drugs effects can cause central apnea, respiratory depression. Dexmedetomidine usually not. And we use 3.7 mm or 4 mm pediatric bronchoscope or nasopharyngeoscope to analyze the airway. So we score the different shapes of the airway we'll be able to see. Though we are comfortable with the dynamic MRI, which is almost a non-invasive procedure, just patient, you send the patient for an MRI scan and get the report. But here we are looking actually into the upper airway and see where the obstruction is happening by yourself. And you know what is happening around, whether the patient really slept or not. Then all will be a question when we get a report from a dynamic MRI. Here you see what you are going to operate. And this is not being done for all the patients with OSA. So this procedure is mainly done for the patients whom you consider or think that surgery will help, or if the patient is not able to use CPAP or not able to tolerate CPAP, or if the pressure is very high, you can see why the obstruction is happening and where it is happening, and whether there is any alternative surgical option to improve the CPAP compliance. So this is the old classification. Accordingly, we score 0 if there is no obstruction. When there is partial obstruction, we mark it as 1, and 2 is complete obstruction. So V stands for velum, and O for oropharynx, and T for tongue base, and E for epiglottis. If we say V2, O2, TE, EE, E2, that means complete obstruction is happening from velum to epiglottis. So this is a video of drug-induced sleep endoscopy. You can see this is at the level of velum, where you can see the obstruction is happening. You can't see. We don't want to see we are not going to diagnose this patient whether the patient is having OSA or not. So here, what we want to know is what is the pattern of obstruction, whether it is circumferential or lateral or AP, like that. And similar patients, other patients at dynamic MRI, you can see this. So previously we all saw the cases of the sagittal view. Here we are seeing axial view, where you can see the palate is collapsing from anteroposterior direction. So in this patient, if you are going to pull the palate or the airway laterally, it's going to further obstruct. So here you have to pull the palate anteriorly, so that you create more space and prevent this anteroposterior collapse. You can see the shape of the posterior space at the level of the same patients drug-induced sleep endoscopy. You might now understand the difference between the previous drug-induced sleep endoscopy, how the airway is circumferential. Here you can see this anteroposterior. And here you can see in a dynamic MRI, you can see how the airway is getting obstructed in a lateral right to left, or from lateral wall is causing the collapse. And diaries of the patient, you can see the lateral wall is coming into the midline and causing the obstruction. See, this is anteroposterior and this is lateral collapse. And circular collapse is component of both anteroposterior and lateral. And we saw the drug-induced sleep endoscopy of the patient, which is causing circular collapse. In this patient, we have to pull the palate anteriorly, and also we have to widen it laterally. This is a primary epiglottic collapse, where you can see the epiglottis is almost touching the posterior wall. Of this patient's drug-induced sleep endoscopy, where you can see the epiglottis is sucked in and causing obstruction. It's like a trap door, it's being obstructed. So these are the patients whom you can expect poor CPAP compliance, where the blast of air from the CPAP can further push down the epiglottis and cause obstruction, and they may feel like choking when they use CPAP. Not throughout the night, few times. So that can also be assessed by drug-induced sleep endoscopy, where you can do surgeries in this area to create more space, and if obstruction persists, or if it is not completely clear, we can give them CPAP, the post-operative. Sometimes it can be very severe lower down. This is obstruction at the level of velum, and lower down, if you see the entire supraglottis, that is arterioglottic fold, arytenoids, epiglottis, everything is collapsing. I'll just drag down, you can appreciate that. These are all very poor patients for CPAP. You can see how everything is redundant and collapsing and causing obstruction. The tongue-based collapse, where the posterior space is being narrowed by the, just when you cross the velum, you are able to see only the tongue base, nothing. There is no, you can't see the larynx at all because the tongue is almost touching the posterior wall and causing obstruction. Sometimes incomplete collapse can also happen. So here you will be able to see only the arytenoids level and not a complete collapse. These patients will slowly get down into complete collapse in few years. So which we can tell them to do a myofunction therapy to improve the muscle tone of the tongue base. So there are various
ஒரு வாரம் மறந்துறேன். ஒரு வாரம் கழிச்சு திருப்பி நான் பாக்குறேன். ஒரு வாரம் கழிச்சு வரும்போது
discuss about the surgical management.
7:30 மணிக்கு சாப்பிடாம ஒரு டெஸ்ட், சாப்பிட்டுட்டு 2 மணி நேரம் விட்டு டெஸ்ட். இங்க வந்து செஞ்ச முடிஞ்சா நைட்டு, முடியலன்னா அங்கேயே ஏதாவது வசதி இருக்கா, அங்க செய்யறதுக்கு ஏதாவது வசதி இருக்கா, ஏதாவது லேப் இருக்கா?
So as I told you, we all know this is an upper airway and BAT surgeons have a major role, but still it's not a one-man show. And it needs various specialists from many disciplines to get involved to treat this patient. So we have to have a sleep board to discuss about each and every patient who is complicated, to have a treatment plan for that particular patient. It just has to be tailor-made. It is not.
இது வரைக்கும் இங்கே நான் வந்தது ரைட்டு. ஏன்னா அவங்க 200 சொன்னாங்க, 102 இருக்கு. பார்த்து நல்லது. இங்கே வந்து பார்த்தா நல்லது. காலையில 7:30 மணிக்கு சாப்பிடாம வந்துட்டோம், டெஸ்ட் பண்ணிட்டோம். இங்கே சாப்பிட்டு கையோட மாத்திரை கொண்டு வந்து சாப்பிட்டு மாத்திரை டெஸ்ட் பண்ணிட்டு போயிருந்தோம். பார்த்துக்கிறது நல்லது.
So the goal is to improve the quality of life and enhance the longevity.
அவங்க சொல்றது நீங்க சொல்றது நிறைய வித்தியாசம் இருக்கு. இல்ல அவங்களுக்கு நம்ம எதுவும் குழப்பம் தான் வரும். இதுதான் ரைட்டா தான் ஒரே இடத்துல பார்க்கணும்.
These are all various. As I told you, we can't treat as per the numbers. We have to treat as per the patient's problem and the need. First, we are treating for the poor surgical cases like obesity, lack of physical activity, those who are severely non-alcoholic or poorly motivated patients, or poor candidates for surgery. So there are various contraindications like severe pulmonary disease or cardiovascular disease, which are commonly associated with OSA, and morbid obesity, where we say BMI more than 40, psychotic instability, and patients with unrealistic expectations. So success rate of surgery is not just 50%. When we treat the patient
ஒரு வாரம் மறந்துறேன்.
properly selected patients, you can get up to 80-90%. This is a patient with post-LAP that is not being properly diagnosed. With that, you can see there is a tongue-based obstruction, and this patient had just
இதெல்லாம் இல்ல, இங்கே பார்க்கலாம். முதல்ல ஒரு வாரம் முன்னேற்றம் எப்படி இருக்கு பார்த்துட்டு சொல்றேன்.
like cutting off the palate alone, snoring will stop, but the patient will be still choking. So this is not the ideal situation where the success rate will drop down to 50 or even down to 20. So recognizing that multiple level of airway obstruction is essential to achieve cure. So must treat all levels of obstruction in an organized and safe manner. For which, as I told you, we have to understand the concept of static and dynamic obstruction per component and severity of OSAs with PLC and the level of obstruction and the pattern of obstruction with WHD endoscopy or dynamic MRI. So in pediatric OSAs, they enlarge adenoids and tonsils, which are the commonest reason which can treat with and primary palliative treatment for pediatric OSAs if the patient is having adenotonsil hypertrophy, and cooperation is wonderful. At the same time, microdefibrillator can also be used.
பார்த்துட்டு முடிப்போம்.
And copulation has really changed the way we do our upper airway surgery. Painless and pain, I would say, is painless surgery. It causes pain, but it will take little time for the surgeon and also to understand what the level of dissection, and without exposing the plain muscular plane, will make the pain less.
2 நேரமே ட்ராப்ஸ் போடுங்க. இப்போ போய் எடுக்கணும். இந்த பக்கம் 3 செட்டு, இந்த பக்கம் 3 செட்டு. ஆவி பிடிக்கிறது 2 நேரம். ஃப்ரூட்ஸ் வேணுமா? ஃப்ரூட்ஸ் வந்துச்சுன்னா
severe OSAs with where you can't do any major surgery or who is not comfortable with CPAP. The various techniques where we can do a permanent tracheostomy, thereby the patient can sleep with the tracheostomy side open and they can do their routine work during daytime with the tracheostomy tube closed. Neurostimulation, which is the latest one where the implantable device is stimulating electrically the hypoglossal nerve, thereby contracting the genioglossus muscle to get more airway space. Inspire, so many models are coming up where these nerve stimulators are in role, which is not still in India. So we have from our association certified training course for surgeons who are interested in OSA. So scientific evaluation of both anatomical and physiological correlation is very important, as we have seen sleep MRI and drug-induced sleep endoscopy has obviated the need for the previously done cumbersome lab supplementing, though it has major role when we plan about skeletal framework surgery. The choice of surgical procedure is not just limited to UWP, and it depends on various preoperative anatomical staging and PSC. CPAP practice and proper assessment helps to improve CPAP compliance by simple nasal surgery or palate surgery. And multi-level surgery and recognition of multiple level of obstruction is important to increase the success rate. Sometimes multi-modality treatment like weight reduction, surgery along with CPAP will help the patient to have a good quality of life. Surgery procedures are safe and effective in properly selected cases. Thank you.
Nice deliberation, and you just, it's a very extensive one, and you can't finish it. Just response me. I take home certain points which I want you to clarify because we do a lot. I also do here with my team and the team that we have. You mentioned in the slides a couple of things that I noticed. It's mandatory to do a PSG before it dies. That's what you mentioned, which practically is not possible in most of the setups that we are working in today in clinical practice and the balance of day-to-day, profession. That's one. Secondly, suppose a patient has gone for an MRI dynamics of complete propagator of dynamic extension that one of the first papers in the country was done by our team. But if suppose by any chance they do not comply with the dynamic when the gantry is not always open up and most of them are obese, so they are not willing to go through and the immediate come out. What do you do next? What is the next mode of medical imaging according to your experience? Nice is that endoscopically we can find out at different levels. The last one. And in your experience, how many retrohide you have the word classification? So upper airway is understood non-compliant CPAPs and the upper airway obstruction anatomically no candidates for CPAP, but or rather poor candidates for CPAP. What about the retrohide collapse? Pharyngeal collapse is very rare, but 8 points.
From the last, I would say epiglottic collapse has a major role. I would say 25% to 30% patients will have an epiglottic collapse. We recently have a published topic in an international book, the role of epiglottis in OSA. So we broadly classified as primary epiglottic collapse and secondary epiglottic collapse, and it can be diagnosed with dynamic MRI or sleep endoscopy. So the basic difference is primary epiglottic collapse, you have a floppy epiglottis and it collapses just like that when it's like a trapdoor. In secondary epiglottic collapse, so the tongue base is actually pushing the epiglottis and blocking the airway. So in primary epiglottic collapse, where we can chop off the higher portion of epiglottis, or we can pull the epiglottis towards the tongue with the dorsal-epiglottic C by suturing, or you can do a higher suspension. So these are the, but hired suspension alone is not a standalone procedure. Usually it is combined with the genioglottal advancement or a genioplasty, where when we pull the tongue base, we pull the epiglottis along with that to have a more space and prevent the collapse of epiglottis. So that's about the return. And about the dice without PSG, see the dice is being commonly done to see whether the patient needs surgery and what kind of surgery. So without diagnosing the patient whether the patient has OSA or not, usually the even American Academy or International Surgical Society is not recommending. The DICE is not a diagnostic procedure. It is the procedure which helps you to plan the surgical option. So without diagnosing the patient with the PSG, doing a DICE is not being done. Other thing is the most important parameters. When you do a DICE, the patient will go for an apnea, and there will be desaturations happening. So we have to know what is the lowest level of saturation and what is the average saturation the patient used to have during sleep study, so that we can be comfortable to see the saturation. Sometimes in the sleep study, if you see the average saturation is around 70 and lowest saturation goes up to 50, then you can comfortably you can do your DICE when you see saturations being around 70 or 60. Otherwise, you will be intense whether the patient is really going for hypoxia or hypoxia issues. So thereby the PSG helps. But it as I told you, it has its own difficulty in setting setup. But sometimes even in US, DICE is not actually being covered under insurance also. So they don't do DICE in an insurance covered basis. It has to be done just before surgery as a part of surgical package, and they get it done. So DICE has its own limitations. And the first one which you elicited is most important, where few percentage of people may not be able to sleep in the MRI gantry, or they will be morbidly obese, where they will not be able to sleep or get into the gantry. Those patients, open MRI sometimes may be helpful, or CT evaluation of upper airway space is also possible, where even cone beam CT is nicely helpful. But these are all static, and it's not a static. I would say it's not during sleep. Usually these procedures are awake procedure. In few patients, we can do CT evaluation of the upper airway space with very low radiation just to see the airway space. There are a lot of protocols are there for them, where they can analyze the upper airway space when the patient is snoring. Only thing is the question is little bit of radiation exposure. So that also is very limited when it is compared to other CT modality. And usually in morbid obese patients, our assessment of upper airway may not be required, as most likely these are not the candidates for surgery. So usually we do dynamic MRI or a sleep endoscopy is being done just before planning for surgery. So that also questionable.
The one slide that you measured the base of tongue with the posternasal wall and left people across
Dynamic MRI.
Dynamic MRI. At what position? Whether it's beginning or
yes. So the length posterior airway space assessment is we can do it as it is a software and it's a video. In various position of the palate, we can assess and compare. It's not one single image.
Yeah, Kaushik, you wanted to.
Yeah, Kaushik. When you're doing your DICE, you're actually simulating a sleep environment. So my question is, can you try using a CPAP with a NAV mask and then do a DICE to find if there is an actual collapse during a DICE, and then select patients for surgery who's not having a patent airway?
Yes, it is being done, and we have also done to see how the CPAP works. We make a small hole or use a vent which is in the mask to pass the fiber optic endoscope.
There is a mask called broncho mask, which actually comes with a hole. So
that we were not aware of. So we have made a small hole to pass
ask the endoscope to see how, when, at what pressure, how much gaseous space is being created, and whether the mask is causing any epiglottic collapse or not. So that all can be assessed.
So if the mask, if the patient on CPAP has a good outcome and you're experiencing and like there is no significant collapse, you avoid surgeries in those patients.
See, we don't do surgery unless the patient is not comfortable with CPAP. So we first give them the option of CPAP, and the patient are comfortable with, unless the patient has a gross static obstruction. That's what the clinical evaluation, bony or huge tonsil or adenoid obstruction. So with that we decide.
Thank you. Yeah. Thank you. Sorry, we are running behind 40 minutes against the schedule. So any questions you can discuss during the panel discussion or the lunch time. So thank you, sir.
Thank you, sir. Thank you so much for the amazing session. May I request Dr. Jayaraman to hand over the motto to Dr. Vijaykrishnan, sir. May I request Dr. Shivani Swami ma'am to hand over the motto to Dr. Sanjeev Mehta, please. Thank you, sir. May I request Dr. Shivani Swami ma'am to hand over the motto to Dr. Hari Priya, please.
Hi, good afternoon to all the faculties, delegates, and the PGs. A quick update, shout out to the PGs. We'll be having the prelims of the quiz simultaneously during the panel discussion, which is after the next two blocks. So assemble in the auditorium after the second block. Thank you.
Thank you. May I request Dr. Tilapati ma'am to take the lucky draw for the next.
Dr. Shanmuga Priya.
Thank you, ma'am. For the next section, may I request Dr. Tilapati ma'am and to chair the session. And to chair the session, may I request Dr. Anupamari, Assistant Professor, Savitha Medical College Hospital, Chennai. Dr. B. Gangadharan, Professor and HOD, Savitha Medical College Hospital, Chennai, please. Over to you, ma'am.
Playback.
Thank you. I think we should stick to the time and we are already late. I think we need to address this. Okay. Good morning and thank you for the wonderful opportunity, Dr. Jayaraman, Dr. Shivani, the entire team of MGM. Thank you for having me here for this talk here. Without much delay, I think we'll get into the topic. So my topic is positive airway pressure therapy. So, so there is a stunning evolutionary failure here, I would say. Nature has endowed us with upper airways that tend to collapse during sleep and block the airflow. But we don't have a mechanism where our sleeping brains have the ability to start breathing without waking up. If this was okay, then I don't think we need to read anything about sleep at all. So there is a manufacturing defect and God slept due to this during this process, I think. That's why we have a huge chapter and we have to read entire specialty on sleep medicine. So why sleep apnea is not going So this is the normal breathing. So the negative pressure ventilation is a normal breathing where you can see your intra-alveolar pressure becomes negative along with your negative pleural pressure, and then air comes in, inspiration happens, and then when the pressure equalizes, then we go into expiration. The next now our topic is positive airway pressure. What are you doing here? You are going against the nature. You are not, this is not negative pressure. This is positive pressure. What happens here? You are pushing air under pressure into the alveoli. It turns positive. So this is a different, entirely different from your negative pressure pathway. So what happens if you push a positive airway pressure into your alveoli? The first thing, the alveoli distance, and then it becomes thinner. There is increased surface area. It helps you in ventilation. It helps you in good oxygenation. When you increase the surface area of the alveoli, okay, it's the sound. Okay, so if you increase the surface.
Okay. Okay, fine. If you are able to hear, right? You are hearing double voices.
for you. This is the lesson. Don't use your laptop next.
After the workshop also, so there's theoretical aspects of medical all the things. We discuss detail about each and every patient, bypass, everything, any question we discuss in the workshop and
minute, please. Yeah, sorry. Okay, my audible this fine now? Yeah. Okay, so finally, sorry for the interruption. Yeah. So technology always overtakes us. So this is it. So you're increasing the alveolar surface area and you're reducing the thickness of the alveolar capillary membrane. So what happens? There is a lot of potential for the oxygen to get inside. So this is mainly related to oxygenation of the patient. It doesn't do anything to your ventilation. Remember that. I will talk about it a little later. So this is what is the physiological change which happens during your positive airway pressure. So if you compare it to the normal, here you can have, it has a cardiovascular effect also because you're creating a positive pressure. It will increase the preload, increase the afterload. It's like giving a AC receptor for a cardiac failure. So that's the effect it has. So the concept number 2, you need to understand that there are 2 different processes which the lung is involved with. One is the oxygenation, the other is the ventilation. So the oxygenation is primarily for picking up the oxygen, helping diffusion and other things, and the ventilation is primarily related to your CO2 clearance. Get this clear because every time I'm going to use this. So So what is oxygen dependent on? See, as I told you, when all the surface area increases, here you can see the mean alveolar pressure and the PaO2. It's directly related. If you have a mean alveolar pressure which is high, your PaO2 will increase. So that is what we are doing in positive airway pressure. You are pushing the air under pressure, improving all this dynamics so that your oxygenation improves, and also in sleep you are trying to prevent the airway from collapsing. That is, it's like a stent. It's like a stent to the upper airway. So these two actions you should remember. Whereas the respiratory pump is involved with the ventilation of the patient, which is related to the CO2. And here any pathway from the CNS to the nerves, to the neuromuscular junction, to the rib cage, to the pleura, anything which is involved in this cycle, in this sequence, will affect the ventilation of the lung. I think all postgraduates, you should get this clear. Otherwise, using a PAP therapy, choosing the ideal machine, everything will not be possible at all. So again, so what do I mean by CO ventilation? So we saw oxygenation, now ventilation. What is ventilation? Every time I'll be using this word minute ventilation, alveolar ventilation. So what is your minute ventilation? It is actually the respirator rate into tidal volume. So get this here. So anything, see, you have a patient who's sleeping, who's not breathing well, who has decreased respiratory rate. Indirectly, what it will affect? The PCO2. So anything which is related to respiratory rate, anything which is related to tidal volume, anything which affects this minute ventilation is going to interfere with your CO2 removal. So remember this. Again, this is a graph which again shows the you're having the PaCO2 on this side and the minute ventilation, how it's directly related. And so improving your minute ventilation will improve your CO2 removal. Remember this. So the next, so these are two different processes, oxygenation and ventilation. All the time, remember this formula, I'm going to use it. So minute ventilation is equal to tidal volume into respiratory rate. So this is any disease which affects the respiratory system, pump, as I told you, from the CNS to the neuromuscular junction, anything which is involved in the ventilator failure, hypoventilation, all these are indications for PAP therapy, which you can go and read up. I'm not going to go into the details of this. So positive pressure, positive airway pressure ventilation therapy can be divided into two. It can be invasive, it can be non-invasive. Invasive, we will leave that part for today because that is mainly the intensive care. This being a sleep masterclass, let's concentrate on the non-invasive part. So the next thing, I cannot stress the correct diagnosis of any disease. If you diagnose correctly, I think 60 to 70% of your treatment is over. So please go and read up, as Dr. Shivani clearly explained. Looking at AHI is not at all enough, and we have moved away from that. AHI can be normal in a lot of sleep disorders. You have POSA, you have ROSA, you have position independent OSA, you have so many terms, you have loop gain, arousal threshold. You need to know all these indexes and don't take the face value of AHI. I think all of you should get this properly, and you should know the definitions by what is an arousal index, what is a desaturation index, what is RDI, what is rare, everything you should be thorough with. So I would suggest all of you to go and download this article and read. Everything is there in this article. You can take a screenshot, you can go home and read this article entirely. So what we are doing in CPAP? We'll start with CPAP. So continuous positive airway pressure. You are delivering airway, you are delivering a pressurized air at the desired centimeters of water. They say 5, 10, 15 like that. So what you're trying to do is you're pushing airway, pushing positive airway into your breathing tube. What it does is it splits the upper airway. So your upper airway, which was earlier collapsed, will now stay open because it is like stenting the stent. Put a stent or something, acts as a stent, allows the pressure air to be delivered into the alveoli. So so what happens in CPAP is when you push the air, you're breathing above your FRC, that is your functional residual capacity. It pushes air during inspiration and during expiration at a desired level. It can be anywhere between 4 to 15 centimeters, however it is. During inspiration it pushes, and during expiration also it. Okay, so this is how it works. So it is like if you set +5, yeah, +5 +5, it is above the FRC. You're breathing above the FRC. The tidal volume occurs above the FRC, and it is 5 centimeters. That is what is the sweat CPAP. So you think of it like, it's a collapsed tube. You push some air into it, the apnea gets solved. Then you remember, you also should know the difference between apnea and obstructive apnea. Don't forget, as postgraduates, apnea is not same as obstructive apnea. So first thing, the apnea will get relieved. Then you increase some more pressure, then your hyperapnea gets relieved. Then you apply some more pressure, your upper airway resistance gets solved. Then you normalize the airway. This is how you should titrate a CPAP. You should achieve this, and then we'll get into that a little bit. So this is how it works. So imagine, like, if you push some air, partially the apnea will be solved and partially will be relieved, and then you push some more air. Finally, the result should be the abolition of all the unwanted effects. So the next, this I will not go. I think ENT doctor has shown live videos which show how the upper airway is kept open. We should understand that there are 3 potential mechanisms that it resists the collapse. So it keeps the upper airway open, and it also stimulates the J receptors or the mechanical receptors, which again stimulate breathing. So what is the compliance? You need to take it at least for 4 hours per night, at least for 5 to 6 hours per night for cardiovascular protection, and at least 70% of the days you should use. This is the minimum which you require. So see this. So here you can see your apneas here. You can see apneas here clearly, the violet shaded portion. And after applying CPAP, see this. The entire thing is corrected. So the pressure needed was somewhere between 4 to 6. So this is again and again I'll be stressing on this guidelines from American Academy of Sleep Medicine. Please download this and read it up. They have given recommendations and good statement practices. So it is always, so this is what they say: treatment of OSA with PAP therapy should be based on OSA diagnosed through sleep apnea testing, and whenever there is a troubleshooting or you have some problem with the adherence, you go back, revise your diagnosis, look at the sleep study multiple times. Each time you look at the sleep study, you will have one more factor which you have not corrected, and you will go back. So if a patient comes back not tolerating CPAP, there will be so many things. It's just not what the eye needs. The sleep study has so much. They made it very simple, looking like as though it is very easy, but it's such a tough. It's got a CNS part, it's got a respiratory part, it has got a ENT part, and it's quite difficult. So go through all the sleep studies. This is the recommendation. So once you've decided that this patient needs CPAP, either you can titrate them with auto CPAP in the house for 2 or 3 days, take that recording, and then find out the ideal pressure at which this patient has a complete abolition of acceptable abolition of apneas and hyperapneas. Or you can also do it in the sleep lab. I think she stressed on all those things. You can go and read about all this. There are some recommendations. If patient is not tolerating, go from mask fitting to humidification to all those things. This and all can never be stressed. So important compared to instituting a therapy. The most failures due to CPAP or your sleep apnea treatment is not because you have not chosen the right machine or not because you have understood the pathology. It is only because the patient is not using it or not compliant with it, or you have not communicated with the patient enough to get him to use it. So this, I'm not going to get into details of this because this titration, I think in the workshop it will happen, but I would want to stress why this is important. You can download this and read, because earlier there was no set standard to say, okay, I have instituted CPAP, my patient is totally all right, this is what I need to achieve. There were no standards like this, but this guidelines clearly says there is some how much of abolition of apnea, hypopnea, RARAs are indicated for you to say, okay, I've done a good titration. So I would encourage all the postgraduates to go and read this. So it is done in a stepwise manner, and you should always remember that titrating according to the guidelines is not always possible, and it is not a cookbook recipe. You see the cookbook, you add the correct amount and then you will get the result. It doesn't work like this. Sleep is entirely different. You need the confidence of the patient and the technician who is doing the titration. Unless you find the correct pressures and the correct machine, you are going to fail in your CPAP. So now, after CPAP titration and you have abolished all the hypopnea, apnea, RARA, and if still patient is symptomatic, what next? Any postgraduates? Any thoughts? So don't forget addition of supplemental oxygenation. So I told you 2 different processes. One is oxygenation, the other is ventilation. Whenever you go with oxygenation, you you institute a CPAP, the patient will definitely improve symptom-wise. Your hypoapneas, apneas will abolish. But if your patient's saturation is less than 88, please don't forget to give supplemental oxygen. This is one pathway. So oxygenation is either EPAP, that is you are giving the CPAP pressure plus oxygen if necessary. This is what you should remember. And there are guidelines for this. You can go and read it up. So the next is the side effects. As I told you, you cannot stress why CPAP fails is because of compliance. It can be related to the interface, it can be related to the pressure, it can be related to other things. This is a fantastic article. If you want, you can take a screenshot, go and read about it. They have given solutions for everything. For the interest of time, I am not going into those details. So the next thing is, this is another update where for everything they have solutions. If humidification is a problem, go for a humidifier. If there are frequent awakenings, you are doing something with the ramp. I'll tell you about the ramp later. So if the mask is leaking, then you have to change the mask, which the patient will get used to it. So you are giving CPAP at a particular stage. You have reached up to say 15 centimeters. Don't keep on pushing the next, go to 20 centimeters, whatever it is. You have AHI like this, you have to take the CPAP. It doesn't work like that. So remember, you are in NIV, you are pushing air. So CPAP, you just remember, in inspiration, it is so good. You can have a good inspiration, you have good oxygenation. But what happens during expiration? The same amount of pressure is being delivered. Whereas your patient is trying to expirate, and then you are trying to push air at that level. In some group of patients, this is not possible, especially in COPD patients. It is more harmful in some group of patients because it will not help you to wash off the CO2. You'll be creating worse problems than where you started. So remember all these. So it is very, very important in what? In which process? Oxygenation. It doesn't do anything to the ventilation. Minute ventilation, time, volume, into respiratory rate, it is not useful at all. So you need to select the patient, confirm the diagnosis properly, select the patient, choose the ideal device, then you are never going to fail. So moving on to BiPAP. So BiPAP, see, this is how the breathing happens in normal breathing. Now you're breathing above the FRC, that is the CPAP. Now you're giving an augmented breath in BiPAP. So BiPAP has two pressures. All BiPAPs are NIVs. NIV BiPAP have two levels. They are IPAP and EPAP. So EPAP is the same. So here you can see EPAP is the same as your CPAP, which is also same as your PEEP in your ventilator, which prevents the alveoli from collapsing and helps in improving your oxygenation. So EPAP is same as PEEP, same as CPAP. Okay. Then there is another pressure called the IPAP, which is called the inspiratory positive airway pressure. So this inspiratory positive airway pressure is the one which you are going to deal with ventilation. So ventilation is again tidal volume into respiratory rate. So you are going to set two pressures. BiPAP has two functions and two pressures. It's IPAP and EPAP, and it has two functions. It improves alveolar, it improves your oxygenation, and it improves your ventilation also. So remember this. So when you CPAP versus all other NIVs, you have fancy machines. BiPAP, yes, BiPAP, ST, volume, wax, ASP. I will tell you a point about all those things. But CPAP is one which delivers pressure at constant pressure during inspiration and expiration. So see this. So there is no ventilatory benefit. There is only improved in oxygenation benefit. But as you move to this side, you can say that there is a lot of ventilatory benefit. But with that ventilatory benefit, you can have some amount of oxygenation, which is becoming better also. So this is how. So again, so here the patient work is less in CPAP, in NIV or all other bilevels. The device work is more. Here there is no ventilation, no breath augmentation. It just splits the upper airway and gives the pressure delivered pressure air. So what's the opposite of this? Here you have improvement in oxygenation, decreasing of CO2, and it has a ventilatory benefit. So ventilatory benefit, and it augments the breath. So this is what is the primary difference. So now you have to choose your patient. Which patient is fit for CPAP? Which patient is better for BiPAP? So your patient who has OSA with COPD overlap, don't go for CPAP. So you need to do an ABG. You need to find out the CO2 status and then decide on the mission. Choosing the wrong mission will sometimes dissuade the patient from using any PAP therapy in the future. So be careful of that. So before we go into really what is the BiPAP, I need you to see CPAP is so simple that I told you, but you need to know this graph and you need to know the building blocks of positive airway pressure. Otherwise, you will not, you will not, if you don't know the science behind this, you will not understand how the machine works. So EPAP, this is the minimal pressure which is equal to the CPAP, which is equal to the PEEP. So this is the minimal pressure at the end of expiration. So what happens then? There is an inspiration which is happening, and then there is another expiration. So IPAP inspiratory, expiratory is expiratory, EPAP is expiratory, and the difference between these two is what is important. That is called the pressure support. Why am I stressing on this building blocks? You have so many different machines. You go to ResMed, they will tell you one thing. You go to Respironics, there will be another. Philips will be another. Some machines will say we are using EPAP and IPAP. Some machine will say we are using pressure support. So if you don't know the concept, you will choose the wrong machine. So what is EPAP, IPAP, and the difference between these two is the pressure support. So that's indirectly called as delta pressure support. So that is what, depending on the compliance. Okay. So for postgraduates, this is one question. So I told you oxygenation is by CPAP and CO2 removal is by ventilation. Okay. So this patient, so EPAP is for PEEP and CPAP. IPAP is for ventilation and CO2 removal. Now tell me, if you have, this is a hypothetical case. If you have this, what's the EPAP or IPAP would you like to change? So here the problem is only oxygenation, yes or not? So this is mainly related to EPAP. Either supplement FiO2 or you increase your EPAP. Now if you have a hypothetical case like this where your PCO2 is higher, your oxygen is correct, what will you choose? What will you change? Sleeping postgraduates. IPAP, very good. So IPAP. Okay. So now I have a patient who's on 1510 and another patient on 12.5. Who will receive the maximum ventilation? Postgraduates, 1510 or 12.5. Why? So you will think that this patient, if you want to improve the ventilation, who will be better ventilated is actually 15 and 10. That's what you will think. But there is another dimension to this. So it is like saying, the wife calls the husband and says, my tire is punctured, but only the bottom part is flat. So it's like saying that this is the concept I have taught you till now, but there is one more dimension to this which I'm going to introduce. That's why I want you to be very clear. So as I told you, oxygenation, ventilation. Now we'll add another dimension to the BiPAP. So these are all advanced BiPAP machines where you start with you have an EPAP here. Okay, I'll tell you in a short while what's the third dimension. So you have a EPAP here, that is the minimal pressure where we start, and then there will be something called as trigger setting. What is a trigger? The trigger is a setting which changes from, see, when you respire, your brain tells you the inspiration is over, go to expiration and things like that. What will happen if you institute a device? So you need to tell the device that this patient at this particular time you should change from EPAP to IPAP. So trigger is something which helps you to change from EPAP to IPAP. So this can be flow, this can be time depending on the machine. So the next thing is there is a rise time. So inspiration, there is a rise time. The time it takes for the device to transition from EPAP to IPAP. And then there is something called the inspiratory time. The patient stays in the inspiratory time, which is called the PI. Stay in the inspiration for a prolonged period of time, or whatever the set time to deliver the set tidal volume and the respiratory rate. So it stays in the inspiratory phase, and then there is a next concept called cycling. So now you need to tell the machine, now inspiration is done, stop the inspiration, go to expiration. So what is that called? That is called cycle. So there are triggers, there are set modes in the machine where you need to set the trigger sensitivity, you need to set the rise time, you need to set the inspiratory time, and you need to set the cycle sensitivity also. So what is the area under this graph? This is the tidal volume. So now if I say I want to improve the ventilation, this patient has CO2 retention, and then I increase the IPAP, I can go up to 15, 20. Remember we are talking about N90. Will the patient tolerate so much of pressure? What will happen? It will leak through the mask, he will have aerophagia, he will get so much problem. So what you need, the third dimension is give that inspiratory time volume, whatever you want to give over a period of time so that the patient is comfortable. So that is why we need to know the basic. With all this, you have to apply to individual patients. Each patient's problem will be different. So that's why we need a trigger. That's why we need a rise time, and that's why we need the cycle sensitivity also. So now this is the rise time. Okay. Suppose I say decrease the rise time. When will you decrease the rise time? If your patient has a COPD overlap syndrome, he won't be able to tolerate so much of pressure suddenly. Suddenly, if you give so much of pressure into him, he will not be able to tolerate. So you need to slowly rise the pressure. So you choose a rise time which is very small. So if you want to increase the time in obesity hypoventilation syndrome, you can increase the rise time so that patient will tolerate increased rise time. So the other thing about the inspiratory time, see, this is the whole inspiratory time. If you have a patient who has an ILD with OSA, the inspiration is a big problem. You need some time. If you have an obese patient, you need the inspiration to take a longer time. And then you will have some patients with COPD where expiration is more important, so you can decrease the rise time. So these are situations where you can apply this rise time into different things. And remember, from this inspiration and expiration also can be calculated. So if you have a normal breathing is 1:2. So if you have a ILD patient, you can give it as 1:2. And if you have a COPD patient, you can give the IE ratio as 1:3. If you adjust the rise time, all this will come. So remember that IE ratio, inspiration can never be more than the expiration. Because why? In normal breathing. Because inspiration is an active process and expiration is a passive process. Remember that. Okay. So now how do I know which sensitivity should I change or which mode should I choose or which sensitivity is this patient is struggling with? So if you pose the question, does the ventilator give you a breath each time you want one? If the patient says no, then it's a problem with the trigger sensitivity. Go and adjust the trigger. If your patient says, I feel a blast of air coming into this, then this is the problem with the rise time. The next one is, do you feel the breath, you're out of breath each time your cycle ends before the expected time and you feel out of breath or it cuts off early, then your problem is with the cycle, the changing from the IPAP to the EPAP. So this, I have just tabulated this, whatever I have said. So the trigger sensitivity is not very useful in all conditions, what we see, but maybe it is very useful for chronic neuromuscular diseases. And the rise time, as I told you, in COPDs, in ILDs, or pure OSA or obesity hypoventilation. And I also told you about this IE ratio. You can take a screenshot of this, all the postgraduates go back and read the concepts. Okay, so this, if you have a BiPAP, which is BiPAP, is correct term is BPAP anyway, for because I've got used to this, it's coming like that. It's okay, it's the same as BPAP. Okay, so BPAP with the spontaneous mode, this patient is breathing. If you have a BiPAP with the ST mode, then you're timing your breath. And so the intelligent backup rate, say if you have, this is actually the backup rate, okay? So the mode, the device stays out when the patient has a breath, but it acts whenever there is a apnea, and it delivers the set rate of the tidal volume, whatever. So these are all intelligent modes, more sophisticated as we go down. So again, there is another mode called volume assured pressure support. What is this? This is mainly, I will tell you simply, the IPAP. There is a two pressure settings which you can, adopt. You can have IPAP which has a maximum and IPAP which is a minimum. You can give a range. In the same way, EPAP can be a maximum, EPAP can be minimum. There will be a range of settings. So you set the volume and the time and whatever alveolar ventilation you need, you calculate it, and then pressure support can be varied. So it's like a roof and a bottom. The roof also moves and adjusts, the bottom also moves, the floor also moves to give you the adequate space and what you need. That is volume assured pressure support ventilation. So what mode to choose? So this is actually, this indication is actually the pathophysiology. This is also an important concept, just as I told you. This BiPAP S and BiPAP ST is actually, it is printing the airway, it is helping you in oxygenation, it is helping you predominantly in ventilation. So choose it for the right patient. So as you go down, these are all advanced, sophisticated models which will help you to overcome whatever you want. A bit about all those. So So this is adaptive servo ventilation, which is the next mode. Briefly into this, it has a EPAP which will take care of your sleep apnea. It has got a pressure support when the breath is very less. When you're remember central sleep apnea, you have no. Dr. Shivani showed you there is no breath, there is no air flowing. It is totally so. And so in complex sleep apneas, all this advanced mode of ventilation is used when you see a central sleep apnea or a complex sleep apnea. But now this adaptive servo ventilation is one which can fix your breathing pattern itself. It is mainly used in patients who have chain strokes breathing, secondary to cardiac or whatever. So whenever it maintains an EPAP for OSA, and then it also whenever there is a chain strokes breathing is crescendo, decrescendo breathing. When the breathing is totally down, it senses it and takes over and delivers the pressure support. And next, when you have when the breath is delivered by the patient and hyperventilating, it stays back and gets to the minimum and allows the patient to breathe. And then all this combined together along with the respiratory rate. If there is an apnea, it will step in and give a respiration. If the patient is breathing well, it will step down. If the patient is got only a mild effort, it will support the breath. So it will help you in various ways to normalize the breathing pattern and also to deliver the set rate or minute ventilation, whatever you want. This is called adaptive servo ventilation. So remember there is one contraindication for this. Remember, if you have a EF which is less than 45% and you have a congestive cardiac failure, stay away from this mode. It is mainly for very few cases like your complex sleep apnea. So why do you go on with so many modes? It depends on your patient's condition and on the what associate. No patient will directly walk out from the book saying I'm having AHI of 14 and 15, give me CPAP and I'll be fine. That's not what we see every day in our practice. So if patient cannot tolerate one breath, the pressure from this mode, you need to adjust so that you achieve this treatment. All the postgraduates take a screenshot of this. This is my entire whatever I said. You need to know these building blocks before giving PAP therapy. So the same thing in advanced mode will be the invasive ventilation. So in this I have summed up everything so you can take a screenshot. So these are the indications. I think we have gone through this. So obviously there is no one size fits all. As I told you, put all the conditions, phenotype the patient, select the device correctly. So there is one word about this complex sleep apnea which emerges after your CPAP therapy or your BiPAP therapy. You can have central sleep apneas. In literature, if you go and read the book, there will be as though there is separately central sleep apnea and separately obstructive sleep apnea. In real life, it doesn't happen. If you see a patient, they will have both central as well as obstructive sleep apnea. So in this condition, there are only two modes which can help you. That is, one is ASV, that is autoservo ventilation. The other is volume assured pressure support rate. Okay. So this is another thing. You can take a screenshot of this also. This is also a fantastic summary. So if you see a graph which has a dip like this, that means that's the patient's breath. If you don't see a dip like this, then that is the device delivered breath. As I told you, increasing the rise time, inspiratory time, and then getting from one phase to the another, cycle sensitivity, trigger sensitivity, everything has some implications. Remember, everything has an implication. If you read up, there will be small adjustments which you need to help the patient to breathe. So knowing about these boxes also are important. I think during the workshop they will tell you, but one important thing which I want to tell you is all these are devices which are respiratory assist devices. Now you get ventilators which look home ventilators which look similar to this. There are certain differences because this has no battery, no alarm. Suppose the patient gets disconnected from this, there will be no alarm. Remember that. So if your answer to the question you ask, if your answer to the question is, like say you ask yourself, is this patient going to die if I remove this BiPAP or CPAP? Then don't choose these respiratory assist devices. You have to go for ventilatory modes of CPAP, BiPAP and other things. So this is actually having only one limb. It has not got double limb like the ventilators. So for inspiration and expiration, it's the same thing. And there will be an expiratory port on the mask. Sometimes patients will cover that. So CO2 will accumulate and they will not tolerate the mask. All these small things you need to remember. Again, BiPAP titration, I'm not going into the detail. I think in the workshop we'll explain this clearly. So the next thing is, I cannot tell you anything, I cannot overstress the fact that whatever you have learned your building blocks, you know the pathophysiology, you have phenotyped the patient, you have done everything, but all this goes straight out of the window if you do not include the proper interface. So don't try to compromise on the mask fitting. So suppose there is a mask leak, whatever titration study you do, whatever however you improvise on your scientific aspects, you are not going to achieve success. So the next thing is keeping a BiPAP, keeping a CPAP doesn't assure that the patient will use it only for that. They will have that under the bed and they will do all sorts of things. So remember to ask this question also, just to keep you away. Yeah. Okay. So the next thing is, I will suggest all of you to go and read up these guidelines. So this is American Academy of Sleep Medicine. Postgraduates, please note, read thoroughly this paper. It has got everything. For want of time, I'm not going into detail. This slide has been shown by Dr. Jayaraman. Why I put this is, as I told you, there are so many need. You have instituted CPAP, you have instituted BiPAP, patient comes back. It doesn't prevent them from having a new cardiac failure, new onset hypertension. You need to address the comorbidities. You need to treat the patient as a whole. And that's why I put this. So how many animals at a time can you see in this phase? You will see as many. Next time you look at it, you will have so many. So each time you evaluate a patient, evaluate it wholly. And the next thing is, this is just a spectrum of the same disease. You start with primary soaring, and then you go to upper airway resistance syndrome. You go to OSA. There are certain differences in all this. Please read up as postgraduate. You should know this thoroughly. So primary snoring is only snoring, but when you have upper airway resistance syndrome, it's associated with arousals. If you have OSA, there is a problem with hypoxia and alveolar and oxygenation. And if you have hypoventilation, you have a ventilatory problem. So if you can identify and correct the disease early, I think you can stop the process early. So everywhere we are living in the era of phenotyping and endotyping, be it sepsis, be it shock, be it asthma, be it COPD, be it anything. You are not supposed, the guidelines is only a major thing. You have to work in detail to phenotype the patient, endotype the patient, and then you get into so many non-CPAP therapies are available which you can get into that. So that's the whole thing. I think choose wisely, choose the right patient for the right patient, and we are not anywhere going to end this. So sleep apnea is going to be there with us, and then please read up the entire spectrum of sleep apnea, not only looking at AHI and things like that. So thank you for your patient listening.
I would say we thank Professor Jayaraman and his team for conducting the sleep study for the sake of postgraduates and also for the public and also for the doctors. As someone said, there are about 104 million people who are suffering from this disease in 2023. So all of us should be aware of such patients who come across for treatment purpose. At least we have to diagnose and learn the comorbidities happening because of that. So it's a good thing Dr. Jayaraman and his team has done. I think that Professor Tilakari has given a very good presentation regarding the basics and what is to be read and what are the points to be taken. I think all the postgraduates would have noted all the slides which she has put, and also what she said, you have to read it in detail. I think you would have taken a screenshot. Thank you, Professor Tilakari. Has anybody got any doubts? Can you suppose
Request Dr. Jayaraman sir to hand over the water to Dr. Tilakari, please.
PCO2. How do you do that? Using your transcutaneous monitors. And if it is going to increase more than 55 millimeters of mercury for more than 10 minutes during your sleep study, or if there is between your previous night before the start of sleep study, you measure the PCO2. Next day morning, you measure it. If there is more than 10 millimeters of mercury, then it is diagnostic. And what are the conditions which can have sleep hypoventilation? One is OHS, others can be medications, and underlying pulmonary or neuromuscular disorders. So coming on to the epidemiology, a lot of us were telling like around 10 crore people are having. So if India's population is 140 crores, of which we have 5% of obese patients, and look at the percentage of OHS, OSA in this obese population, it is around 9 to 20%. So 10 crore is still a huge number that we have to address. So what happens in obesity hyperventilation? There are 4 possibilities that are being given. One is the changes in the respiratory system, especially when these are obese patients. So there's going to be a lot of fat around your chest wall. So that is going to interfere or interlace with your muscles, and thereby it will weaken the system, and you're going to have a lot of atelectasis. So second thing is the hypoventilation in OHS. Normally there should be a respiratory drive. When you're breathing at a lesser rate, if it's going to go in for apnea, you should have a response is going to be an increase in the respiratory. Now that is blunted in case of in OHS, especially during your REM phase sleep. Why you are mentioning REM phase sleep is normally there is a hypotonia which occurs during REM naturally, right? You're not supposed to run away because you're going to have nightmares and dreams. At that time, your muscle tone is going to be lesser. During that time, if your hyperventilation is also there, then the muscles do not respond, and the carbon dioxide retention is going to be there. The third is going to be there is a sleep disorder breathing, which is going to be an inherent part of your OHS. Especially there is a fat deposition or the tongue is going back and obstructing your upper airway. And fourth is presence of comorbidities such as your hypertension and your other cardiometabolic comorbidities. So coming on to the respiratory mechanics, the maximum inspiratory pressures and the expiratory pressures are all reduced because the patient's ability, this is a restrictive lung disorder that we are going to see. And the hypercapnia normally should induce a hyperventilation, and it should increase the transdiaphragmatic pressures. Now that is going to be blunted in case of OHS. When you look at your pump and handle mechanism, especially in your PFT, there is a reduction in the tidal volume. The breath rate, the tidal volume is going to reduce, and there's a slight increase in the respiratory rate. And your dead space is going to increase. That is because it is not going to contribute in the breathing. Like there's a lot of alveolar collapse, but the circulation is going on. So there's going to be a VQ mismatch and a hypoxemia. And the most important component is your expiratory reserve volume, which is getting reduced. Now, if you look at the previous one, you have an obese patient on the right side, and there is a lean person on the left side. So the major difference, there isn't a reduction in the total lung capacity, but the major contribution is by your expiratory reserve volume. And third, why is the drive lost in OHS? So they are suggesting it could be leptin, or it could be genetic, or as ma'am was telling, precision medicine, genetics genes can play a place, or is it because of your sleep disorder breathing? So what is leptin? Leptin is a peptide which usually regulates your appetite and stimulates ventilation. But in obese people, there seems to be a higher resistance for this leptin receptors. And the fifth mechanism is the underlying OSA, which can be there. So 90% of these patients will have a AHI more than 5. So this is very important because you don't have to have a very high AHI and you can still have an OHS. So that's why the level 1 sleep study is being advocated. And 70% of the people will have a AHI more than 30. So there is a cessation of ventilation during apnea, and there is a disrupted alveolar ventilation which is happening, and there is a reduction in the bicarbonate clearance. So this will further blunt your ventilatory response. So these are the mechanisms which are postulated in OHS. So in an obese person, there's an increased work of breathing and increased demand to augment minute ventilation to maintain adequate alveolar ventilation. That's the most important key concept. If the patient is able to maintain it, there will be a normal ventilation which will happen, and it can be either simple obesity or it can be pure OSA. Whereas if the patient is not able to increase the ventilatory drive, then there will be hypoventilation which will ensue. And of this, 90% of these patients will have OSA with OHS. Only 10% will have a pure OHS. So why are they not able to augment is what we looked at, whether it can be leptin resistance or a decreased muscle performance or reduced arousal, or it can be blunted ventilative response. So how do we identify history and physical? It's going to be very classical of OSA and dyspnea. And if you look at the physical examination, there can be increased neck circumference, crowded oropharynx, prominent P2 and a pedal edema. In this slide, the diagnosis is mainly that of exclusion. So if you have 100 people with obesity, the second one, 79% is that of OSA. I wrongly labeled it. Out of these, 22% will have OHS. I'm sorry, I have labeled it wrongly. And the differentials for OHS is going to be an obstructive airway disease like COPD or a restrictive lung disease or a neuromuscular disease. So what are the predictors? So somebody comes in obese. Now you do not know whether this is cardiac or COPD or OSA or what it is. So first thing is look at their saturation. If their saturation is less than 91, it's a predictor. And look at their PCO2 by BMI. So if the PCO2 is going up more than the BMI, then it will be, if the BMI is also more, the ratio is less than 1.5, it's a predictor of OHS. And most of our patients, as ma'am was telling, they don't walk into the OPD with a diagnosis. Usually they present in the emergency with an acute respiratory failure. And from there, we need to pick it up, and mostly it's in the 5th or 6th decade. So in the blood gas, if you look at it, there will be a hypercapnia, PCO2 more than 45, and there's a hypoxemia. And hematocrit is, erased hematocrit is common because of chronic hypoxemia. And the serum bicarbonate, this is more important. Serum bicarbonate of more than 25 is important. So there was a study which looked at obese people are there. Okay, so many people are coming into the hospital for multiple visits. So if you look at the black line indicates patients with OHS. So before the time period, the arrow marks the time period where the study is starting. So if you look at retrospectively, the number of visits is more in an OHS patient when compared to general population or obese patients. So they have multiple visits for different reasons. They won't tell us that they have OHS. So you're doing a blood gas with a PCO2 of more than 45, a BMI is increased, and hypoventilation is not due to any other lung conditions, then you will think of OHS. So this is a polysomnography of a obstructive sleep apnea patient where you will have to look at the flow. Whenever there is an absence, there is going to be a CO2 retention. So if you have a CO2 retention, the normal response is you should increase your respiratory rate and wash it out. So if you have a blunted ventilatory response, then they will not be able to wash out your carbon dioxide, and that is when they will start having diurnal hypoventilation. This is a classical patient with the OHS. So look at the flow. The patient has a regular breathing, and then there is an increased breathing which is happening, and then slowly it is blunting. So if you look at the time where, especially this phase is called the REM phase, right? So in your REM, whenever there is going to be a drop in your SpO2, you will correspondingly, if you look at it, if your transcutaneous PCO2 is there, you look at it, you can have an increase in your carbon dioxide. So this is a proposed staging for OHS, stage 1, 2, 3, 4, 5. This can come up possibly in future. So all of them will have a BMI more than 30. 0 is they are at risk, but there is no hypercapnia. 1 is there is an obesity associated hypoventilation, and the bicarb is now at less than 27. In stage 2, the bicarb is going above 27, and there is an intermittent hypercapnia. Stage 3, there is a sustained daytime hypercapnia, and stage 5 is sustained daytime hypercapnia along with cardiometabolic abnormalities. So what are the comorbidities? These patients can have mostly cardiac comorbidity. So it can be because of your hormone and your metabolic issues. It can be because of cardiovascular, or it can be respiratory, or it can be a low-grade inflammation. These are the impairments which it produces. And when you look at disability, they have exercise intolerance. They will not be able to do their daily activity, excessive daytime sleepiness, and decreased daytime activity. And they will have recurrent hospitalization, increased utilization of money, economy, high risk of death, and lack of social participation. So what are the consequences? Most important of obesity hypertension is death. because they sleep they die during the sleep. So we need to be very, very vigilant about it. Chronic heart failure, pulmonary hypertension, and recurrent hospitalization due to chronic respiratory failure. So this slide demonstrates the amount of mortality which can be there. The dotted lines in the end. The third one is untreated obesity hyperventilation syndrome. So they stand a little lesser chance when compared to obese people. If the patient is eucapnic morbid obesity, which is a simple OSA, then at least they have a slightly better chance than these people with OHS, but still lesser than those who are treated. So what is the treatment? First is lifestyle changing, weight loss and dietary measures, rehabilitation programs, PAP therapy, and bariatric surgery. So this is a single slide which tells us in a glance in hypoventilation syndromes, how do you go about it? So look at the underlying cause. Is it obesity? Is it neuromuscular, COPD, ILD? Because this can be coexisting in your patients. If that is so, then you treat that with a bariatric surgery or a diet or treat the neuromuscular or treat your OAD, reduce your opiates, diaphragmatic pacing, all those. If there is a daytime gas exchange, daytime hypoxia, hypercapnia, then oxygen supplementation, but we have to be very, very careful with oxygen supplementation or respiratory stimulants can be given. If it is sleep disordered breathing, which is non-obstructive or obstructive with the hypoxia and hypercapnia, then you will look at the various modalities. Ma'am has told in detail on all the therapies that is available for treatment. So I will go through it in a quick glance. So when you're using a CPAP, it's a set pressure. Now the difference between on the left hand side you have CPAP, right hand side you have BiPAP is the amount of tidal volume that is getting delivered. Because it's a single pressure, the tidal volume will not change. It's going to be a set pressure that is going to be there. Whereas when you give a BiPAP, because of the I and E difference, the delta, the tidal volume is going to be a little better. So your alveolar ventilation is going to be better in a BiPAP. Now you need to choose your patients who needs a CPAP and who needs a BiPAP. Now if your patient requires BiPAP, there was a study which considered whether NIV or CPAP, which in a patient who is having predominantly a OSA type, which is better, because in our country the cost is very, very important. CPAP is at 60,000 for an automatic CPAP. Otherwise, manual is going to be 35, whereas a BiPAP is going to start at 1 lakh. So, does every patient with OHS require a BiPAP? The point is, if they have a concomitant severe obstructive sleep apnea, then actually an NIV is equivalent to that of a CPAP. So they looked at the PCO2 during 3 years and the PaO2. So there was not much of a difference. The upper one is your low PaCO2 and the low one is your high PaCO2. And the other fancy model is your AVAPS, which is volume assured pressure support, where as your tidal volume starts decreasing, look at the arrows, then the pressure delivered will start increasing. So here it is reducing, and then the pressure following that starts increasing. So what is the major goal behind it? You need to maintain your alveolar ventilation because of the obesity, there's going to be a atelectasis. So to improve that, AVAPs will help. So again, ma'am had mentioned on ASV, the crescendo and decrescendo. So whenever the increased breathing happens at this crescendo, the pressure starts coming down. And whenever the decrescendo happens, then the pressure starts increasing. So the machine synchronizes with the patient and gives it. And as she had mentioned, there will be IPAP also, there is a 2 pressures. EPAP also, there are 2 pressures to help. So somebody comes to you with an OHS, you have identified it. Now you're looking at the sleep study. You're having a AHI of less than 30. What do you go about? So if you're having less than 30, but obstructive obesity hyperventilation, you will directly go for a non-invasive ventilation. Because here there is no need to split your upper airway or there is no need to increase anything. So for these people, the alveolar hyperventilation is the issue. So you'll go with an NIV. If your AHI is more than 30, then you will start with a CPAP because there can be a concomitant OSA. Now if they respond well, like adequate clinical and arterial blood gas control, no hospital admissions and patients are doing well, then you will maintain on the CPAP. But if the patient is not responding, and if this symptomatic or if the PCO2 starts going up, or there's a recurrent admission, then you consider a NIV. they come with acute decompensation most of the time. So at that time, how do you start therapy? So you will put them initially whenever they're in their emergency or in the ICU, you will start with an NID. The EPAP titration should start at 6 centimeters and then stand by the patient. That's very, very important. Stand for at least an hour. See whether the patient is comfortable, whether the episodes of apnea are getting obliterated and they stop snoring, and the saturation should start improving. And IPAP, you'll start with 60. Again, you'll increase it by 2 centimeters. Observe for the chest wall expansions. Now, oxygen, you're treating, but still if the patient is hypoxic, only then you will start on supplemental oxygen. So how will you follow up these patients? You will take a periodic ABGs. You will have to look mainly into your PCO2 and your bicarbonate, whether it is getting corrected. And when will you do a repeat polysomnography or put somebody on CPAP? How many of us are going to repeat the sleep study? So they are on it for endlessly, right? So in OHS, if the patients are persisting symptoms are there, then you will again repeat the first best thing is relook into your sleep study. And if it is persistent, then do a repeat sleep study. And if you want to readjust your PAP device, if the patient is symptomatic, then you will look into it. And for factors contributing to severity of OHS, you will look into it. Now coming on to oxygen therapy, so we have started somebody on CPAP to obliterate your obstructive apnea episodes. If the oxygen is remaining at less than 90, then you will switch from CPAP to a BiPAP. First thing is that, and if see whether the saturation is maintained. If it is still not maintaining, then you will add the oxygen therapy. Because the study on the left hand side shows the dark ones are patients who are controlled. This is the obese patient, obesity hypertension syndrome. So if you're giving oxygen, this is at 28% and that is at 50%. What happens is in patients with OHS, they tend to retain more CO2. So the supplemental oxygen addition in OHS should be, stepwise, so that we don't do more harm to the patient. So what are your goals? You will normalize your arterial carbon dioxide tension. You will prevent desaturation. You will prevent erythrocytosis and relief of hypersomnia and altered medication. So what are the long-term effects? So as I had initially shown you, the ERV, which is the white one, which is in the middle, starts improving significantly with your NID. But there will not be any improvement in your AA grade. When do you do tracheostomy? In a life-saving process, like if a patient comes in with an acute chronic respiratory failure, it's a life-saving procedure. And if the patient fails all forms of therapy, then ideally consider a tracheostomy. And what are the stimulants we know of? We can have progestins, acetazolamide, but the point is that these are all last resorts of treatment and does not, it helps only in very select set of patients. And weight reduction, it does help, but after reducing weight, is the patient off the BiPAP or the CPAP? Any of our patients, are we taking them off? In OHS, it is very, very difficult. So even after removing it, they might still be on PAP therapy. And alcohol is a big no. Definitely, it suppresses the drive. There was already no drive. It suppresses it even further. The last but not the least, rehabilitation is one of the possibilities in an obese patient to help them to get on with their day-to-day life. So we at Medway Institute of Pulmonology specialize more into pulmonary rehab and get them back to at least to do their day-to-day, simple goals of life. So conclusions. OHS is chronic daytime hypoventilation, and the criteria will be increased PaCO2, your PMA should be high and no other cause, and look into your bicarb, very, very important. PAP therapy, BiPAP is the modality of choice. CPAP, if there is a major OSA component which is persisting. And OHS patient who usually require a BiPAP may switch to a CPAP at a later date based on their improvement. And alternative methods are your AVAPs, bariatric surgery or tracheostomy can be considered in a refractory patient.
Thank you, Dr. Supraja, for this wonderful talk on obesity hypoventilation syndrome. Just a couple of points for the audience. One is whenever you see obesity patients in your clinic, if you can actually do a serum bicarbonate level as a marker. Like if the serum bicarbonate is more than 25, you can suspect OHS in those patients. Second is weight reduction is the prime goal. Like only weight reduction is going to help you for the therapy. And third is my personal experience. AVAPS has been an amazing tool in OHS patients. So I just want to take that.
The only thing I think AVAPS actually has been discontinued by the company itself.
Yeah, but there are other newer.
Which is actually the IVAPS. There's a
Yeah,
slight
IVAPS,
change in technology. So AVAPS delivers. As IVAPS delivers in a short minute ventilation.
But it's equally good in cases of obesity.
So I would rather go with the algorithm that Dr. Supraja has said, that ideally you should first titrate them on a CPAP. Only if they're not titrated, if they still continue to have a higher PaCO2, that is when you will switch to the non-invasive.
Correct. But all obesity hypoventilation patient definitely needs to have a manual titration before choosing.
Absolutely.
Yeah, so I don't know how far manual titration is being done across the centers, because there are less experienced people to do a manual titration. So it becomes really difficult in most part of this country to actually choose devices depending on titration preference.
So ideally, most patients, at least in our scenario, would actually come to us in an acute exacerbation instead of actually with for a diagnosis of OHS. They practically land up in the ICU. So we initially manage them on an NIV and then give them some time, and it is at least after a few weeks to a month that we should actually be doing the sleep study, and that is when we should make the attempt at titration with the CPAP first.
So what exactly do you use for what titration kit do you actually use for manual titration?
So anyway, we do manual titration, and what we have been using is the OmniLab, which is the titration device.
So OmniLab is one which is from Respironics. Right?
Yeah. Even that actually will be discontinued now.
Not very soon. So I don't know what else is available to do a titration.
So I think ResMed is coming up with the titration device as well. So that is another thing.
Do we have manual titration demonstration?
Yeah.
Thank you.
But nowadays, OHS are common in pediatric children. How to proceed? The same way, ma'am, or whether we have to refer them to sleep lab, or we have to do serum bicarb. Many children, 5 years, 7 years, even 2 years old with obesity.
My experience with pediatrics is zero, so I think sleep is good.
Although I also do not practice pediatric sleep medicine, it's a totally different ballgame. I have not been practicing. However, having said that, that degree of obesity in pediatrics also needs to be looked at by an endocrinologist, because they might even be suffering from some hormonal disorders.
Everything is well, ma'am. Then
there are pediatric sleep physicians. I think initially you can start with an ENT evaluation and go about it. Start with an ENT evaluation, look at the adenoids, the ductals, and
sometimes advice translectomy, otherwise they
then of obstruction, or because your presentation is only right. So then
well child, otherwise well child, mother
obese as well.
Obesity and snoring.
There are exclusive pediatric sleep.
Chennai, sir.
Yeah, one of them was with Vijaya. I don't know whether ma'am said it was
Not there.
No, I think children mostly adenoid starts with only
Everything rule out, ma'am. Everything is.
I do agree we are moving into a pandemic of obesity. You can ask, there are sleep studies, why don't you do an assessment?
Children, 2 years, for children, whether there is any different lab, different parameters.
Thank you, ma'am. Thank you so much for the session. May I request Dr. Jayaraman sir to hand over the moment to Dr. Supraja, please.
Second, I just request all the PTs to assemble in the atrium right now.
Dr. Jayaraman to hand over the moment to Dr. Gayatri, please. Dr. Jayaraman sir to hand over the moment to Dr. Kaushik Gujrati, please. Jayaraman sir to hand over the motion to Dr. Shanmugam. Next. In Chennai, Dr. Hari. Department of Radiated Surgery and Healthcare, Dr. Abhilash Vaskoran, Senior Consultant, Oral Maxillofacial Surgeon. Please start. Thank you everybody for still being here, and we are going to hold it for some more time. And this is the last session before lunch, and usually before lunch is the time that people are usually very awake and alert. So I think this is the best time to do this. So thankfully we have very experienced try to cover things which have not been covered in the talks so far, make things simpler. So I like to although Jaraman sir had briefly touched upon how sleep disorders are classified. Would you want to go through it again and add something? Sir has already given a detailed classification of the sleep disorders, that is the international classification for sleep disorder. It's a revised 2023 in which it is classified into 7 categories, and various sleep disorders are there, and according to like class 1 will be insomnia, it might be short term or long term insomnia, class 2 will be sleep related diseases, all those base hypertension, and central pulse of apnea will come under category. Category 3 will be circadian rhythm related sleep disorders, sleep awake disorders like sleep wake, early waking up or late waking up, or all other sleep wake disorders will be covered under this category. And grade 3 will be central disorders of hypersomnolence. Like even sleeping more is also a problem, not only sleeping less. So hypersomnolence due to some drugs or some medical conditions and also will be covered under this category. And there is a fifth category in which it will be sleep related movements, periodic movements like restless leg syndrome and all will be covered in this category. So other sleep disorders will be the last classification. This is how sleep disorders will be classified. Thank you. And I think also further, like you said, insomnia will be classified into sleep initiation and sleep maintenance. Going on to Dr. Haripriya, we've actually been talking about snoring in sleep apnea, and I'm sure everybody has this question. Are all snorers have sleep apnea, and vice versa? What is your take on it as the ENT expert?
Not necessarily. Snoring can be an independent phenomenon. It can be manifested along with the obstructive sleep apnea. There is primary snoring, that's also known as simple snoring. When it comes to there will be snoring, but there won't be any arousal or oxygen desaturation or respiratory failure in this. It occurs when the air passage is so it can occur in patients with allergic rhinitis and sinusitis patients who are recurrent tonsillitis. And there can be occasional snorers also. So when it happens in patients who are excessively tired or who is taking alcohol or some sedative drugs, occasional snoring can occur. Coming to the second part of the question, like snoring in obstructive sleep apnea, it may be a symptom. It is not necessarily like it is a pathognomic sign or symptom. When it comes along with the excessive daytime sleepiness or other symptoms, then we have to give medication administration and factor that approach.
Yeah, absolutely. I think I would agree. And also many times even a lot of sleep apnea patients also may not have snoring, especially women. But do you think all snoring is pathological? Does all snoring need evaluation?
If it is associated with the other symptoms, then it needs. Otherwise, we can treat the patients, I think, under follow-up.
Thank you. Going on to Dr. Anirudh. So, you know, we have talked about, Dr. Suraj also talked about OHS and how BMI is extremely important. So, how do you think BMI and the other lifestyle habits that we have are related to sleep disorder? And do you see any difference between males and females per se?
So definitely there is a correlation between the metabolic syndrome and sleep disorders. We've been continuously seeing this in patients. All obese patients, the basic problem that they face is excess deposits of fat in the parapharyngeal and chest area. This is the basic thing to start off with sleep disorder, provided we ruled out other anatomical causes of, airway diseases and stuff. That's why this bariatric surgery itself is like a multidisciplinary thing. We just don't treat bariatric, the obesity part of bariatric, but we also try to attest to the metabolic syndrome, which also one of the component is the sleep disorders. That's why we involve ENT surgeons, pulmonologists, everyone in optimizing. There is a direct correlation between BMI and sleep disorders. In fact, there have been cases which present just with snoring. They don't even get bothered about the other metabolic disorders the patient is suffering from. Spouses, in fact, bring the patients to OPD to attest the snoring. That's their awareness, and then we give them more awareness about what else can be wrong, and that's how we explain it to the patients. Definitely, I feel there is a male predominance in cases of sleep disorders and obesity. I find more male patients have these sleep disorders than females.
Right. So, do you think also females maybe don't present so much, because we have studies which have shown that women don't really, when they present to a doctor, most of the times they are not accompanied by the vet partner or the makeup partner. So maybe the history given is actually not very accurate. Also, women tend to ignore their health or health issues for a very, very long time. So there are studies which have actually even said that maybe even that is a possible reason. Do you think that would be true?
Maybe true, ma'am. Maybe. Like you said, they don't give attention to their own health, and the presentation might be
correct. So, coming to Dr. Abhilash, since Dr. Anirudh was talking about multiple specialty approach, and I think that is where medicine today is headed, that there has to be a multidisciplinary approach to most diseases. So, where do you think a dentist fits into this role when it comes to patients with sleep apnea?
The dentist role is definitely significant when it comes to identifying patients with obstructive sleep apnea. Dentists look into the mouth day in and day out, and it's their area of expertise. So if you look very closely, there are a number of signs and symptoms that can be picked up in the dental clinic or the dental chair. For example, generally people who walk into dental clinic are very anxious and apprehensive. But if you imagine, I'm going to tell a patient, well, I'm going to take out your wisdom tooth, or I'm going to use drill, and he says, okay, carry on, no problem. Gets into a chair and starts sleeping. Then I know there is something wrong. So it starts from there, and many a times we lower the backrest of the chair for dental treatment, and if patients feel very uncomfortable with it, that's another sign to pick up. Asking for frequent breaks during treatment is another sign. In addition to that, looking at the patient's facial profile, micrognathia, small maxilla, small mandible, or macroglossia, big tongue, scalloped tongue, when the tongue is very big and there is indentation of the teeth. Many of them are bruxers. You can see that the signs on the teeth. Dry mouth, very poor oral hygiene. These are all signs, symptoms to be picked up in the dental clinic that should indicate the dentist that there is something wrong. So predominantly the whole goal of the dentist would be to identify the patient, inform the patient if he is not aware of it, and then refer on to the sleep physicians for further treatment.
I think that's extremely well said. And of course, these are things that maybe sometimes even we tend to miss, that, a patient dozing off in the waiting room is somebody that we should actually have a high threshold of suspecting sleep apnea for. So very well said, Dr. Amita. And with that, since we're talking about multidisciplinary approach, I think it will be incomplete if we do not involve the psychological aspect. I think in today's day and age, when the stress is so much and the awareness being so low about sleep disorders, the moment you break it to somebody, I'm sure there is a lot of anxiety and all of it. However, also sleep deprivation, the chronic deprivation itself may lead to some psychological manifestations. What really are these manifestations, and are they any different in men and women? And what is your way to deal with it? What do you recommend to the patients or maybe educators, doctors? Dr. Ramya, please.
Of course, psychological manifestations can vary presentation, and in some cases, unless we ask for their psychological functionality, they may not open up. Like, they are reporting only snoring, but they may have a whole lot of other psychological issues as well. So, whatever be the context, among men, commonly substance abuse, especially when we ask somebody, why are you abusing alcohol? Many times the answer would be like, my sleep is not so great, and I try to have a regular intake of alcohol to actually improvise my sleep. So actually, it's a myth. Alcohol can worsen apnea, it can make the situation even more worse. But then that is one common complaint. And in many, lot of times we get some difficult, like apart from direct snoring, erectile dysfunctions are very commonly reported. So if you really understand the sleep quality, their functionality, their energy levels, or do you really feel fresh when you get up in the morning? So many times it would be very unrefreshing. They are drained out at the start of the day itself. So for men, these are common presentations like substance abuse, decreased functionality, sexual dysfunctions. For women, many times I come across somatoform complaints like headaches, low functionality. So I've seen women presenting with, I always feel like lying down. So only must to do activities, I just get up and manage somehow. So a lot of memory impairment, I feel a lot of inattention, that I tend to forget on a lot of things. So these are very common clinical presentations that we come across in men and women. So of course, a holistic assessment is what is required. So we need to really understand the symptomatology from various perspectives. They can also present with a lot of night scary dreams, nightmares kind of symptoms, and they can also have a lot of associated anxiety. So this anxiety and depression symptoms are very common associated symptoms when somebody is having a chronic sleep disturbance.
Right, correctly said. And do you, at least I think I see a lot of patients also presenting with sleep talking. The bed partner would say that they mumble in their sleep, or they're talking in their sleep, or they have a restless sleep. And eventually, when we do the sleep study, actually those are apneic spells and arousals. Apneic spells arousals, which are actually those spells. And once we treat the sleep apnea, they actually get cured of their sleep talking as well. So, do you also, anybody sees that kind of presentation in their practice?
Sleepwalking, ma'am.
Sleepwalking is a different disorder, ma'am. It's not sleep. It may not be related to the sleep-related breathing disorder. It was the classification that certain also talked about sleep. Different behavioral disorder.
Restless legs and symptoms are frequent fragmented sleep. So it's very common. Many times they abuse drugs also. So they may take some over-the-counter sedatives or some cough syrups to just deepen their sleep quality. As we specifically ask for that.
I think also patients who are refractory to antidepressants or on multiple antidepressants also may actually be having sleep apnea as well. Do you screen those patients as well?
Many times we don't really go for a very sedative
primary antidepressant, the SSRI, serotonin, reuptake inhibitors, many of them are weight neutral. They are not really having sedation as a part, except a few drugs. So really, they may not worsen the OSA as such, but if OSA is presenting as a psychopathology, then of course we have to identify that and independently treat it.
So, going back to Dr. Shubha, since we're talking about the various types and various presentations, we'd like to highlight the various types and the endotypes of sleep apnea again.
எல்லாமே பயங்கர வேலை இங்க வேலை இப்போ வீட்டுல தான் வேலை உனக்குப்பா வெள்ள வேலையும் நல்ல வேலையும் பாரு தண்ணி கட்டு பரப்சீரு பரப்சீரு ஏன் அது தாயாவோட சூழல் தெரியுது உனக்கு
Any of the endotype reasons, many of the pathophysiology which is involving in endotypes like airway, pharyngeal airway disorders, loop gain, or because of the upper airway collapsibility and all should be ruled out in case of severe phenotypes, severe AHI in phenotypes, to not to miss any of the upper airway collapsible. These always we need to differentiate endotype and phenotype in clinical practice.
அவன்
So, going to Dr. Haripriya, since we're talking about endotypes and phenotypes, is there any specific investigation that you subject your patients to assess whether they are for surgical intervention or for CPAP therapy?
அநியாயத்துக்கு உப்பு எதுவுமே போட இருந்துச்சாமா சுத்தமா உப்பு இல்லை ஒன்னா பருதுன்னு கேட்டா அதை போட வேண்டாம் அப்ப நீங்க வேற இன்னும் பாவக்கா குழம்பு போட்டு புளியும் போலியாது சுத்தமா கிடையாது நான் ஒரு ரெண்டு போடவே பார்த்தேன் அப்ப இருக்க மாட்டேது கேட்டேன் நான் போய் பயப்பட்டு வந்தேன் ஒரு மணி தான் பழையமா பண்றது அப்படின்னு அது மூச்சு முதல்ல பேசிக்கிட்டு இருப்பல இருக்கு அது சத்தம் போடுறது நம்ம குருவன் உட்காந்துருக்கு ரொம்ப அம்மா குரு பண்ணிட்டு இருக்கு கேள்விப்பட்டேன் சரி கோபுரம் சார்
Evaluation of upper airway. We can know the collapsibility of the upper airway. Then we have other investigation like DICE, that is drug-induced sleep endoscopy, in which we are in like natural behavior of the sleep is induced with the medications like dexmedetomidine, propofol, etc. So there in DICE also we have scoring system, that is both scoring system, that is level of obstruction, whether it is partial obstruction, complete obstruction or no obstruction at the level of pilopharyngeal, oropharynx level and base or epiglottis. And when coming to imaging studies, especially in kids, we used to do X-rays of tissue neck lateral view to know the degree of adenoids, how much percentage of obstruction is there. And we can do CTPL paranasal sinuses to know the about the bony framework or any sinus disease or immediate turbinate hypertrophy, DNS, etc. Then dynamic MRI is there, like similar to DICE, we can know the collapsibility at each level. That is whether it is in the nasopharyngeal level, retropalatal level, retroglossal level, epiglotic level, etc. And classify accordingly. And decision making depends on the evaluation of the airway.
Right. So I think the one thing that maybe the first thing is the DICE, or maybe in case of X-ray, I think is what you would begin with, and then maybe
it's actually a big stage.
So with that, Dr. Anirudh, what is your other recommendation for bariatric surgery? Who are these patients we should really consider doing the bariatric surgery? And are there any pre-surgical evaluation or management that is indicated?
Pediatric surgery is usually they present with obesity and metabolic syndrome. Usually patients with sleep disorders most of the time gets referred to us after being diagnosed with sleep disorders and after being evaluated, usually with the other physicians. So anyone with metabolic syndrome and a reversible sleep disorder is a candidate for bariatric surgery. Of course, we do other parameters like BMI. There are a lot of evaluations that goes into bariatric surgery investigations, but patients with sleep disorders and obesity, definitely a sleep study at least is a mandatory before we choose the patient for surgery, apart from the other investigations.
Is there a BMI criteria? Is there a separate Indian criteria vis-a-vis the international criteria?
I don't see any difference in the criteria between India and the West, but definitely. But sleep disorders, even with the BMI of 27, I see patients with metabolic syndrome. So even though the BMI is not alarmingly high, even for a BMI of 27 with metabolic disorder and a sleep disorder, we do suggest bariatric surgery.
So when you
Is there any specific parameters that you consider at like the waist circumference or the neck circumference or any such thing? You find any correlation?
We don't correlate it. We go based on BMI and a diagnosed sleep study.
And so of course there is a huge battery of tests for a patient to be able to understand. But other than that, and definitely patient have had a polysomnography, but other than that, is there anything else?
Of course, we definitely do an endoscopy. Pathologists in the stomach before we operate on the stomach. And also the basic mandatory test is to do a venous Doppler of the lower limbs, because sometimes there is occult DVTs which do not cause complete thrombosis and we miss it out, and that can get aggravated post surgery, and there will be grave consequences even of a pulmonary embolism. Even though we put them on antithrombotic measures, but still we get a Doppler preoperatively to ensure that there is no medical leak.
At least as far as I know, also these patients optimization with that therapy for at least a 2 weeks prior to surgery. Is that correct?
Yes, we always involve the pulmonologist, the sleep physician, as well as anesthetist. They evaluate the patient, and once they deem him fit, that's when we plan on surgery. Because bariatric is not an emergency; it's a very planned elective procedure. There is no reason to hurry up without optimizing the patient.
In that sense, we've talked about surgery, and we are moving back to Dr. Abhilash. I mean, it's very enlightening for us the way you assess your sleep apnea patients. You're able to pick up quite a few, I'm sure. So, what are the surgical interventions that as a magnification surgery might be able to offer?
Maxillofacial surgery comes as a last resort. We should reserve it as a final treatment option for all the patients who have failed with all other treatment modalities such as CPAPs or medications or all other kinds of surgeries. Initially, this surgery, that is the maxillomandibular advancement, was designed as a cosmetic procedure for correction of facial deformity. Somebody who's got a very retrographic or a very underdeveloped maxilla or underdeveloped mandible, change their facial appearance. The maxilla or the mandible is cut forward, placed in a new position and plated with plates and screws. But later on, they started realizing it's got some benefit with the breathing and
அனுமதி வெளியில் அறிவிக்கப்படுவதற்கு கோமாவட்டம் பூண்டியும் வெளியீடுமலைத்தோடு அறிவிக்கப்பட்டது. ஒவ்வொரு ஆண்டும் பிப்ரவரி மாதம் தொடங்கி மே ஜூன் மாதம் வரை பொதுமக்கள் மற்றும் பக்தர்கள் வெளியீடுமடைவதற்கு அனுமதிக்கப்படுவார்கள். பொதுமக்கள் மற்றும் பக்தர்கள் வெளியீடுமடைவதற்கு அனுமதிக்கப்படுவார்கள். ஒவ்வொரு ஆண்டும் பிப்ரவரி மாதம் தொடங்கி மே ஜூன் மாதம் வரை பொதுமக்கள் மற்றும் பக்தர்கள் வெளியீடுமடைவதற்கு அனுமதிக்கப்படுவார்கள். முதல் முறையான வெள்ளி விநாயகர் மலை, இரண்டாவது முறையான பாம்பாட்டி மலை, துணை வழுக்குப்பாறை மலை, மூன்றாவது முறை கைதட்டி மலை, நான்காவதாக ஒட்டர் சமாதி மலை, ஐந்தாவதாக பீமன் கரிமுருண்டை மலை, ஆண்டி துணை மலை ஆகிய 6 பேரை தாண்டி கடவுளுக்கு மேல் 6000 அடி உயரத்தில் 7வது மலையான கிரிமலையில் வெள்ளியகிரி ஆண்டவர் சந்திரலிங்கேஸ்வராக எழுந்தருளி உள்ளார். வெள்ளியகிரி மலைக்கு கடந்த 100 ஆண்டுகளுக்கு முன்பே பக்தர்கள் சென்று வருகின்றனர். ஊட்டி கோவிலும் பல ஆண்டுகள் பழமையானது. எனவே இம்மலை ஏற அனுமதி வழங்கப்பட உள்ளது.
Most importantly, the patient need to be counseled that there is going to be significant changes to the facial appearance, which many of people may not be able to accept it. not only facial, nowadays even the nose can be changed. I mean, the appearance of the nose can be changed. So it should be judiciously used, but it can be quite effective in treatment of patients with the obstructive sleep apnea.
And any role of mandibular advancement devices, do you advise those as well, especially in kids?
Yes, in kids, I guess in kids, the pathology is slightly different. More obesity is there, but then loss of airway space, small maxilla or a small mandible is a primary problem. And there are functional devices which are used to expand the maxilla, the circumference of the maxilla, which can improve the airway space, and also devices to bring the mandible forward, myofunctional devices called as twin block and things like that, which will bring the mandible forward, also instigate some kind of growth, so that can relieve the what we call the condition at the back of the throat.
I think also studies have shown that if corrected in kids, these kids are actually less likely to have sleep apnea as adults.
I agree with that.
With that, Dr. Ramya, we'll come back to you. So we talk about multidisciplinary and of course holistic approach and the diseases holistic approach. So are there any other modalities from your end that we can use, maybe treat or as an adjunct to the therapies that are available?
0 to 55
Followed by all patients.
under a second.
What all the presentations. So one thing that we commonly say as a part of sleep hygiene is they should mandatorily do some 30 minutes of whatever physical activity they like, at least in sunlight. So many times we see patients hitting the gym at very
through dense forest with unparalleled agility. Yet even she can be outmaneuvered. Other much smaller creatures here possess astonishing abilities that can defeat
very physically or psychologically exerting tasks. Also, we also say that avoid anything that disturbs your sleep post 4 p.m. or during the second half of the day. So, caffeinated drinks. So, because of their many times people at OSA may have impact functionality during the day, they may try to Red Bull or something like that, they just take to just sustain their concentration and attention, which might be counterproductive towards their sleep. So avoid any kind of caffeinated drinks, carbonated beverages post 4 p.m. to improvise their sleep patterns. And definitely we all know how glued are we to our gadgets. So maybe we are using it as the last thing at night. So at least a couple of hours before your tentative bedtime, we need to really wind up our gadgets so that our brain gets a cue. So mind is only a function of brain. So the brain gets a cue from the circumstance that it is time to unwind or rest, and only then it will start synthesizing melatonin, which is the sleep hormone which will promote or deepen our sleep. So they can follow a very systematic bedtime routine, have an early dinner, or take at least half an hour to really read something, some book offline. So don't do any other activities in bed like working with your systems on, sitting in your bed. So avoid such activities. So having a consistent bedtime routine may cue your brain or may train your brain to actually synthesize your melatonin in a more effective way. So gadget restriction couple of hours before bedtime, physical activity in the day, avoiding stimulants in the evening. So these are some general recommendations, but definitely weight reduction and avoiding a very late dinner. So these things can also improvise their sleep patterns. So all these things are collectively called as sleep hygiene. So these things work for most patients because they may actually follow a very unhealthy lifestyle otherwise.
So I think also to add on to that, also keep a dark and a soundproof bedroom so that you are able to. So like Dr. Ramya said, keep your gadgets away. Definitely, I think with that. And when we have worsened or whatever. With that, I move to Dr. Haripriya. I at least hear about a lot of these energy devices that are used in ENT surgeries, and I am absolutely unaware of that. Could you please enlighten us?
These are energy devices like we have micromotor system degrader, laser, ablation, radio frequency bands we are using in our surgery. So these instruments that can surgery, like there are some like difficult to access areas. If we are doing with the traditional methods, like tongue-based, epiglottic medium, and difficult to access. So in that cases, with the help of the device, we can access the desired area, and blood loss during the surgery less, and and post-operative complications also with the use of these devices. This micro degrader, we have shaving blade system. It rotates 360 degrees so as to degrade the enlarged tissues. Maybe we are using in B-section for inferior turbulent hypertrophy, then adenoids, constant surgeries, etc. Then ablation. Ablation is a radiofrequency band, and there is a conductive medium. Usually we use isotonic saline. So what happens is this radiofrequency current, when it passes through that medium, it breaks the molecular bond of the saline, and charged particles are created. These charged particles helps in reduction of the tissues, volumetric reduction of the tissues, like maybe adenoid surgeries, tonsil surgeries, tongue-based reduction. Then nowadays there are like minimally invasive surgeries are there. So like channeling, radiofrequency band channeling, ablation channeling, so that the soft tissues are stripped and stabilizes. Patients, I'm very curious to know. I don't really see a lot of post-bariatric patients. The pre-bariatric definitely, but post-bariatric somehow they are usually lost to follow-up. So, what is your experience with the terms of following up these post-bariatric patients, and how do you think they fare in terms of their sleep-related issues?
Definitely, there is an improvement which goes hand in hand with the percentage of body weight percentile that they shed post bariatric surgery. Once the obesity component comes down, their sleep disorders also seem to resolve. In fact, we have seen like few patients who have been on CPAP even preoperatively for optimization, their ventilation, slowly getting weaned off CPAP. They are less dependent on devices for oxygenation, and their natural sleep pattern seems to
லீவு உட்காந்துட்டு நைட் டியூட்டி தெரியும்
patient to patient variability is there, but definitely there's an improvement.
And the weight loss is
Yes, so for the first 1 year, the simplest procedure in surgical bariatrics is sleeve gastrectomy. Definitely they'll lose close to 25 to 30% of their excess body weight, not the body weight. Definitely they will shed, and that seems to improve their metabolic disorders like diabetes and everything. For patients who are extremes of ages, that is young and too old, sleeve gastrectomy seems to be adequate and beneficial. For this middle age group with predominance of metabolic disorders, that is uncontrolled diabetes, uncontrolled hypertension, and these things, we do bypass surgeries, which is more malabsorptive.
I think that would be actually a great result to have, and I'm sure that makes your patients very happy as well. So with that, we've talked about sleep apnea. We've been talking about sleep apnea, but I have one question, because I think like Sir has stated, and it also stated that insomnia actually remains the most
எப்படி மார்க்கா பாதுகள் கௌரி லட்சுமி மேடம் ஆனா அவங்களாம் என்ன பண்ணாங்க
take it as a prescription drug or might abuse அவங்க நடந்து to improvise on their sleep. One recent add-on to the list of drugs that improve sleep is wakefulness inhibitors. So traditionally, we are all very aware about sleeping pills, the benzodiazepine concoction like lorazepam, alprazolam, and the non-benzodiazepine or the drugs like zolpidem, or which will actually result in improved sleep. They are the sedative hypnotics. So the other group of drugs that are very recent and very promising is wakefulness inhibitors. So basically, like wakefulness inhibitors don't work on the GABAergic pathways. They work on the orexin receptors. So in hypothalamus, the orexin receptors are there, which actually promote wakefulness. So by inhibiting the orexin receptors, the wakefulness level is brought down. So one drug that is recently there in the market for the past 2 years or so is naproxen. So it's the only one brand is available. It is called Davigo, DMAPAG, Davigo. So it is not a benzodiazepine class. It is not a sleeping pill. It's a wakefulness inhibitor which does not have any weight gain or daytime sedation or any other addiction potential or abuse potential that comes associated with a traditional sleeping dose. So, and the results even we use for any context of insomnia, especially OAC where we don't want to sedate the patient. So that is very good.
Insomnia. And they present to you the first time. What is your first drug of choice? If at all you have to give them a drug, because the patient comes and says, I have several for weeks and I need to sleep. Doctor, please give me a pill. What do you do?
So we give currently this wakefulness inhibitors only. We educate them on the sleep hygiene and we give only these wakefulness inhibitors. We reassure and say that it is not going to cause any addiction or abuse potential. There will not be any hangover effects in the day. So this is what we do. If at all we want to choose from the other group, we will choose only non-benzodiazepine hypnotics like zolpidem. We will never use drugs like lorazepam or alprazolam.
That's not for insomnia, ma'am. That's for shift work disorder actually. For sleep phase disorder.
If the patient is having an altered sleep-wake cycle, it does help. If the patient is going to follow a very good sleep hygiene and prompting a healthy natural melatonin synthesis, as Madam mentioned, ensuring that your environment and other circumstances are ideal for your setting your sleep on, then melatonin as a standalone might not help much in the context of insomnia.
What is the product, ma'am? Melatonin is available in headache tablet. They are taking melatonin.
Yeah, melatonin is not a restricted drug. It is available over the counter. Gummies, chewable formulations, nasal sprays of melatonin are also available.
That's one last question, after which I'll conclude the panel discussion to Dr. Singh. I'm sure you know at least we get all these patients on with the smartwatch data or the smartphone data that doctor, I've not been sleeping well, I've not had enough REM sleep. See, I have actually had low oxygen while sleeping. How accurate is this data? That the smartwatches is giving us every day. In this gadget era, everyone is so fascinating for a lot of new gadgets, and the social media marketing also gives a lot of ads. We assess your sleep in the watch. You wear this watch in the night. We will let you know the quality of light what you are having. All these watches have come up in the market. These watches usually how they assess the sleep is they assess the sleep by artigraphy. That is mainly because of the acceleration. When you move your hand, it usually assess depending on the movement of the hand or the wrist, usually assess the sleep quality. And they say some watches say even they assess the NREM, REM sleep at all, but how far it is true, it's only based on the wrist movement. And accuracy in these watches will be around 60 to 70%. And these watches sleep whatever is screened can be only for screening purpose, maybe not for a diagnostic purpose, or it cannot be taken into consideration as a diagnostic thing for assessing the OSA severity or anything. And these watches usually they assess the quality of sleep, they assess the duration of sleep, and they assess the atmosphere where they're sleeping, whether it is well lighted area or it's a dark. Depending on that, also it will assess their movement of sleep. Sometimes it might show wrong data where
பத்து நிமிஷம் தான்
for
போயிடும்
a few pages.
பர்மசி போயிடும் இங்கெல்லாம் யாரும்
Sleep for a shorter duration like half an hour, 45 minutes also, it might not record or read. And few cases where the wristwatch might be loose or tight also, the proper way of assessment cannot be done. So we cannot rely on this watches for screening of sleep disorders. So, but I think there was recently, I think, and if I'm right, it is the Samsung watch which actually came up with the, it also gives the oxygen levels. And at least as a screening, it was, approved by the European Union drug authorities. At least for a screening tool, they said that the data was quality. Apple watches has saturation for a long time, 4-5 years they are having saturation. No, with the sleep. I mean, not while walking. I'm talking about sleep. Yeah. And ECG is also recorded in few of the watches along with sleep. Fitbit has the saturation and heart rate. What is the therapy for sleepwalker? Sleepwalking, ma'am, usually is a complicated disorder. Usually, like most disorders today, it would need a multidisciplinary approach. So I think a sleep practitioner and sometimes even a neurologist will have to be taken into. Sometimes even a psychiatrist might have to be involved. So I think the primary person to refer to be a sleep practitioner.
யாரும் பண்ணி முடியாது நல்லா வாரம் பிடிக்கிறேன் நான்வெஜ்
sleepwalking can be normal. They can it's a growing brain 6 to 8 years or lesser than that. They don't intentionally or they may not neglect the event. The idea is you only tell the child shouldn't fall or there shouldn't be any harm to injury to the child or the other people. Sleepwalking usually settles as the brain grows. So otherwise it can also manifest in an elderly population. REM sleep behavior disorders can be there where they are sometimes acting out in their sleep or acting as if their muscle tension may still be there, but they are actually enacting a sleep and actively reacting to it in a real-time scenario. So they may be totally unaware of it. So REM sleep behavior disorders in an elderly, you have to rule out some neurological conditions, as Madam rightly pointed out. It can be a manifestation of a underlying neurological condition also.
Children may can allow up to 8 years.
Yeah, up to 8 years. Yeah, otherwise if there is no issue, we can wait.
Thank you, everybody. I think we should maybe move to lunch and anybody has any questions, reach out to the faculty during the lunch. After which we will workstations. Thank you. Thank you extremely. Thank the panelists for such precise and clear answers. Thank you very much.
Thank you so much, ma'am.
அவுட்டிங் ஒரு மணி நேரம் தான் நீ கேட்போம் என்னன்னா அவளுக்கு இன்னும் பெர்மிஷன் இந்த டைம்ல தான் அவளுக்கு ஃப்ரீ ஆகுது காலையில வாடகை வேற நீ வந்துட்டு செக்யூரிட்டியை பார்க்க சொல்லிட்டு போயிட்டு வா ஃபுல் டே செக்யூரிட்டி சுடுதனியா அந்த இதுக்குள்ள போட்டு அதுதான் நல்லா இருந்தேன்
has been a great part of the organizing committee as well.
12:30
ஆக்சுவலி 1:30 எழுந்திரிச்சேன். கால் இடிக்கிற செத்து வலி தாங்க முடியல, அதனால முடிச்சேன். அப்புறம் 1 மணி வரைக்கும் எந்திரிக்க முடியல, காலை இப்படி தேய்ச்சிக்கிட்டே நல்லா இருக்கு. வாங்கிட்டு இருந்தேன் வச்சு பார்த்தோம். அது எப்படி இருக்குன்னு மேம் சரிவா சரி இது எடுத்த ஆனா அது எனக்கு பிடிச்சிருந்தது. ஆனா அது வந்துட்டு மேம் சொன்னாங்க இது வந்துட்டு இது மாதிரிதான் கட்டுறாங்க.
இது கொஞ்சம் சூப்பரா இருக்கு மாதிரி இருந்துச்சு. இது கொஞ்சம் வித்தியாசமா இருக்கு, டிஃபரெண்டா புதுசா இருக்கு,
சொன்னாங்க.
நியூவா இருக்கு. ஒரு ரோடு மாதிரி கொஞ்சம் நல்லா பளிச்சுன்னு எடுத்து கொடுக்கும். இது எடுத்து கொடுக்காது, நல்லாதான் ஆனா இதுதான் நல்லா இருக்கு. ஸ்டுடியோல தானே
போகணும்னு நினைச்சேன். கேளுங்க நைட் டியூட்டி முடிச்சுட்டு
அதனால பிராக்டிஸ் எல்லாம் பண்ண தெரியுமா? இருக்கு பிராக்டிஸ் பண்ணி காலெல்லாம் இருக்கு. காலைல 5 மணி இருந்து 6 மணி வரைக்கும்
எதுக்கு எதுக்கு
அது மேல
ஓடுவீங்களா?
போனேன்.
என்ன
எங்க
வெளியில வெளியில இருந்து ஆள் இருக்கு அது
அப்படிதான் நினைக்கிறேன்.
நீ காட்டு காட்டு போனது காட்டுக்கு போய்
என்னோட சார்ஜ் ஆயிட்டு இருக்கு. சும்மா பாக்குறேன்.
Mic audible first of all. Class partition. Put the partition. Partition go to class. Partition go to class. Okay. Moving this case. Something. On the housekeeping. Where is Sarayu? Sanjay, live. Sanjay. Battery மாத்திடலாம்டா.
All of you. So this is on the how do you hook up a patient onto a level 1 sleep lab, and how do you start recording, and at the same time how do you identify what is apnea, what is hypoapnea, when is desaturation happening, and how the EEG leads are happening. Okay. So basic instructions. First things foremost, the patient doesn't know what they're coming in for. Okay. And at the end of it, when you look at him, you will understand it's so difficult that you are put on to 32 leads. Okay. And you will look a little scary. I think some of them are posted on YouTube how I looked on the sleep study. It is very scary for the patient, but you need to tell them that is how it is going to be recorded. And they can take all the medications, whichever they are taking, sleep medications, BP medications. If they are rate controllers, everything they have to continue. They should not skip any medication. And they should be wearing loose clothes as much as possible. The trouble with female patients. Okay, so what happens what is the difference between level 1 and level 2? Level 1, that's the video recording that is happening. Level 2 is everything happens except the video recording. So you need to tell your patients upfront that there is going to be a video recording and that they need not be worried about it. Because female patients and we have a male technician, usually there is a issue. So you need to tell them upfront, and they can have their dinner somewhere around 8:39. Now, there are certain challenges where we have the patients will be on shift workers and they sleep only during the day and they're obese and we want to do. So in those patients, whatever is their sleeping time, that is the time that we ask them to go ahead with the sleep study. Otherwise, if you make them do a sleep study on them over the night, they will be fully awake. You won't get any leads as such. Right? And can they use a restroom? Yes, they can use. And how many many hours are they expected to sleep? We tell them as long as they start falling asleep, it's okay. Usually we start recording by 10 o'clock and we stop by 6 o'clock. So if it is going to be a split night study, it will be first 4 hours you will analyze and then second 4 hours you will connect the titration. Okay, but ideally it's better to do the 8 hours and then the titration of the next day. So initially now we will be seeing how we are going to connect all the leads. Okay. Now for EEG, how many leads are there? So there are three things that we connect. One is the frontal, one is the occipital, and your parietal. We'll connect. Sir, if they're already on it for a longer period of time, he continues. Sir, somebody is on Zol fresh. They sleep only with Zol fresh. On the day of sleep study, they come to stop it. So, the problem with level 1 is also there's a glass. The technician sits on one side. The patient is on the other end. If you have a video camera, you are monitoring. The glass will be closed. But if it is video the technician sees if there is any lead disconnect or anything. If you're removing and there's a light coming in, patient will be. There are people who are very light sleepers. So whatever medicine they are taking, continue. Start with the EEG leads. You have one control and then 3 sets of monitoring machine happen. We will be monitoring that. What is recommended?
down பண்ணு.
So this initiation
நான் என்ன பண்ண போறேன் கையெல்லாம் கனெக்ட் பண்ணுவாங்க. ஃபுல்லாவே இருக்கு.
So how we are going to do is we wanted to show it live when we connect how the monitoring is happening. How he's an awake patient. So how the waveforms are coming in, alpha forms are coming in. Okay, we'll start with EEG leads. Okay, so Murthy wants to go with the respiratory part. And this is the small, see this device, there are two level 1 devices. This is called the somnomedics device. Okay, so this is simple. It is similar to your Holter, so you will connect and it will be lying on the patient's chest. Whereas if it was Philips, then it is a big device like your CPU. It will be standing at the side. And it is very easy because you will have, so it will have markings as to where each lead has to go. It's very, very simple. And this is not having. You can put it anywhere inside. But usually you have a guidance as to where the chest leads are going and where the thermistor, where the nasal flow, everything is going. In fact, now all of us are doing studies with the somnomedics. It's easy to connect. It's portable. So if you want to do a level 2, so you will have EEG with all the respiratory cardiac parameters. You can do it in the bedside as well. This will be, if it is monitored, it's level 1, sir. If it's not monitored, it's level 2. Please will be the same. So if you have a EEG, then it is level 2 and 1. If you minus the EEG, if you have respiratory and the pulse and saturation, then it is level 3. Yes. So if the provider gives you, then you can. Very few people ask for an EEG and this. Yes, you can. But one is better to be done under monitoring. In a leads, if it disconnects at home, patient will not even know. There are so many leads, so you will, when the study is happening, we'll keep monitoring the system. So we will connect. If it is disconnecting, we will connect. Now you will understand the complexity once they start connecting. There are so many leads. Once I did it for my ex-chairman. We took all the pens, we connected, and the technician was asked to wait outside. Next day morning, 6 o'clock, he goes, everything is on the bedside. Okay. they are uncomfortable, they will remove it. So the study happened for half an hour. So, chairman, you can't question also. So So that's the chest and abdomen and chest. Okay. So that's the pulse oximeter we are connecting. It is, yes, ideally you have to relate, but once they are disagreeing, they'll again disagree. So it is, that is why the first step is convincing them, telling them, but you can't show this picture. If you show this picture, nobody will come for speech study. But you have to tell them you'll be connected to multiple leads. It is going to be a little discomfort, but you will still fall asleep. You have to tell them. And they will always say, after the end of 6 hours or 8 hours, they'll say nothing. Then we show them the whole 8-hour study and we show this was wake, this was N1, N2, N3, REM. So you've stepped through it. In fact, those who complain actually sleep well. So in somnography, you also have the opportunity to check the blood pressure variations as well. That's another advantage they have. So you will measure it at the beginning, in middle, and then at the end, and then you will calibrate whether there is a fluctuation in the blood pressures. So now they are connecting onto the checkbox. Okay, nasal thermistor. How many of you have connected EG, I mean the leads in a sleep level 1? Now what do you use the Philips? PLM. So PLM is for the muscle thing. So here we are actually checking the neuro, respiratory, cardiac and muscle. So for muscle we generally use the legs. The shin of the leg, the inner part we are going to do, the lower 1/3 we will be connecting. If it is female and they are not very comfortable, then you can connect it onto the dorsum of the foot. Yes, sir. Yes, sir. Level 3, sir. Yes. Level 3 la PLM varada, EEG varada. Only cardiorespiratory will come. Adanaala adula vandu it will have AHI, RBI, saturation mathram it will not have EEG. So we won't go there.
This is almost we are connected only respiratory.
We have connected only respiratory. So you'll have a nasal thermistor. You are having a chest band. You are having an abdominal band and pulse oximeter. So this is level 3.
That's body position.
Body position. Whether they are in supine or Dr. Kilamati said some of our PGs wanted us to also show you how do you score it manually. So a few shots of those also we will take where what are the case methods and what are the complexes and all. And apnea and neck apnea we will show. Also on interpreting a level 1. So once always ensure that it is scored manually. And also how do you interpret a level 1 thing. So the report also we will show.
So report the ECG. We want to put the ECG.
ECG also. Yes. The first is connecting, sir. Connecting, then we will run it. Then we will ask him to hold the breath so the and then a pre-recorded study of the patient we will also show.
Yeah. You can show some interpretation, PSC interpretation, all of it.
That is also correct. In a patient with no comorbidities, yes, you can. You can ideally do, but it will miss central sleep apnea. EEG, REM phase disorders, sleep, central sleep apnea. That is why they always say any comorbidity, especially cardiac, renal. In fact, a lot of renal patients will have OSC. Why? They may not be obese, but they will have why? Simple yes. Anything else? What happens in CKD? There's a fluid overload. So what happens when you're sleeping? There will be a rostral shift of fluid. So whatever was there as a penile edema, when you lie down, obviously, so when you're sitting, your fluid is in the leg. When you're lying down, it will come to the sacrum. It will also come to the chest. It will come to the neck. So along the neck, so it need not be just fat which is producing the increased neck circumference. It can also be fluid. So we did a study for sleep. We were planning to do for sleep study prior to dialysis and post dialysis and see what was the difference. So there are papers which show that there are this will also help. But ideally, if you increase the fluid removal, that's the first time that we are supposed to do. No, but it cannot be. You should have a high degree of because there are so many reasons in a CKD why they don't sleep. If you identify a OSA, then you need to correct it. That will also help if their mechanisms, their pressures and sugars will also come. So I had the opportunity to work in a cardiac hospital for 10 years, in which a lot of patients who had rhythm disturbances were referred for sleep study. So what are we connecting? EG. Finished? EG is over. ECG is over. Okay. Next, what are you connecting? EEG. So EEG, they will start with the ground, and then they will start with all the three. So a lot of patients with rhythm abnormalities, if you see that they'll be having voice. If you put them on CPAP, the rhythm abnormality will start coming from. Again, heart failure. That's what. So what we were telling about with OHS and OSA, the presenting symptom will be actually a cardiac event or a respiratory event because they'll have otherwise a CAD or a COPD. So you will keep missing. So if you identify it, if your patient first time if you identify, good for the patient. If you have missed it, if the patient gets recurrent admissions, please think of OSA, identify, diagnose, and treat the patients. They will be fine. Connect all the uncomfortable. So you will have the mastoid as the reference point. So from the mastoid, you will draw an imaginary line up. Okay, that will be the center line, and from there, 20% in front will be your frontal, 20% lateral will be your parietal, 20% back will be your occipital, and front will be your ground. See, the next one will be your oculogram. Oculogram will be right upper and left lower. Right upper will be above your eyebrow, and left lower will be.
Tell about the one touch. What is one touch? What is epoch? Just yeah.
So this is the screen which I was studying for the previous screen. So on the sonomatic screen, you will be able to see the PLM-R right, PLM-L will be your left. The effort, the sound, the flow, the EXG or the ECG, it will be easy to connect all the leads. It's very, very simple. And the EEG part also, you can see the diagram and then connect it. So head box we can choose what all we wanted, and it's better that you choose the frontal occipital, the parietal, and your EOG and your muscle or this is how we look at it. So the F3, F4 is your frontal, C3, C4 is your parietal, and O1, O2 is your occipital. M1, M2 is your mastoid for reference, and E1, E2 is your EOG. Just go to here and check on F3, and then you can click it on to M. See contacts in between. Here also you can see sites in the wall. This will be the reference channel which will come when you are starting the page by page when you do online recording. Choose different text when you are showing the same thing we can create everything in the process. So this is the EEG neurology says about the banana vortex, double banana vortex. This everything can be created. Polysomnography we are not using for 32 channel of EEG. To understand all the stages and the arousals, we will use only 8 EEGs. Frontal to central to occipital. That's two. I think we are not doing because polysomnography we are sufficient for the same. As per the ASSM protocol, it is one is a factor. This one limit scale is a factor for other limits. If you want to see the F3 with the F2, suppose F3 to F2 is the signal is not good, then you can check with the F2 F2. This is a factor. So all polysomnography means it will have a lot of artifacts. So we cannot avoid the artifacts. That's why the ASSM guidance has been given one by one. One channel is one channel for the factor. That's why we use for the nasal, we will use for the thermistor as well as nasal cannula. So one is factor. Yes, ma'am. It's very important. We have to instruct the patient to have a shampoo because it should not be more oily. It is oily, it will not even stick. And you're going to sleep with it soon. And then you will have a skin submental area that they will be fixing. Chin links. And you'll have scoop. Correction, arms. Very good. The patient date of birth, the treatment, right, if you given it, then you can put the preliminary decision. you should at least give a glimpse of how this is to the patient. And this is how they're going to sleep. Another 2 more to be added, cannula and the
patient. Next time start.
So as sir was asking epoch, so you at the end of the thing, 8 hours you can wholly look how the stages have been, what all stages the patient has come. That will be the first one. Second thing you look at what was the total sleep time. So total sleep time and total time that you are connected. So both are different because from the time you hook on everything, okay, and then till you disconnect, that is your so total sleep time will be from the time the patient starts lights off to lights on. That is your total sleep time. Efficiency is when the patient goes into N1 and then finally wakes up. That will be your total efficiency, how the patient is. Sometimes you look at it that the study was done for 8 hours, but the patient has slept only for 6 hours. So what is the efficiency? 6/8. Okay, so that is only 80% of good therapy. So anything above efficiency is when the patient goes into N1 and then finally wakes up. That will be your total efficiency, how the patient is. Sometimes you look at it that the study was done for 8 hours, but the patient has slept only for 4 hours. What is the efficiency? So that is only 80% of good therapy. So anything above efficiency.
Left and right.
So now you will start seeing the recordings which are coming. So based on this, you will then decide if it is too much of an artifact, you will connect it and fix it properly. So this is a wake phase. Wake phase, what waves are going to be seen? Alpha waves are going to be seen. And what is the hertz that you are going to be having for alpha waves? More than 13 hertz is for alpha waves. So if you there are various views in which you can see on the top, it will be the final data. I mean, now we have started. So how the patient is now. This is on an alpha wave which is going on. If you look on the left, you will have E2, E1, C3, C4, O2, O1. And the option is all data. Now we have started. Left is
Right.
So SpO2, it is monitoring. So it is now continuously. So this is how it is. Your flow is now flat. Your pressure flow as the patient is. So the doctor breathe and without another breathe and without. So if they do too much of a breathe and without, so it is not continuously, then there will be too much of a fluctuation. Okay. So why is it showing us hyperapnea on the left? Any guess? Patient is awake, is breathing, but it shows hyperapnea. Why? How will you diagnose hyperapnea? More than 30% of drop, right? And so it compares the previous and the post breaths. Based on that, it will adjust. So what is the reference value for hyperapnea? 30% of what? So whatever breath. So he took a wide breath. So from that, it will take that it is reduced and it will measure hyperapnea more than 30% of drop. And the RIP is thorax, RIP abdomen is the abdominal effort, and SATS is SATS is at 96. So it will take some time, but it will continuously record.
നമസ്കാരം, ഞാൻ നിതിൻ നിരവത്ത്. ഇന്ന് ഞാൻ നിങ്ങളോട് സംസാരിക്കാൻ പോകുന്ന സബ്ജക്റ്റ് ഇത്തിരി പ്രാധാന്യമുള്ളതാണ്. അതുകൊണ്ട് തന്നെ ഒരു ശകലം സമയം എനിക്ക് വേണ്ടി നിങ്ങളൊന്ന് മാറ്റിവെക്കണം. ഇടപ്പള്ളിയില് ഒരു പ്രയർ വീടുണ്ട്. കേട്ടപ്പോൾ നിങ്ങൾ എത്തി കാണും. ഈ നടന്ന സംഭവം ഞാൻ താമസിക്കുന്ന വീടിന്റെ തൊട്ടു മുൻപിലാണ്. ഞാൻ താമസിക്കുന്ന വീടിന്റെ നേരെ ഓപ്പോസിറ്റ് ഒരു ഫാമിലി താമസിക്കുന്നുണ്ട്. എറണാകുളം ആയതുകൊണ്ട് എറണാകുളത്തിന്റെ ഒരു ഭൂമിശാസ്ത്രവും അവിടുത്തെ ഒരു ജീവിത രീതിയും ഒക്കെ ഏകദേശം ആളുകൾക്ക് അറിയാം. ഒരു വഴി ഉണ്ടാവും, ആ വഴിക്ക് അപ്പുറവും ഇപ്പുറവും വീടുകളാണ്. എല്ലാ വീടുകളും തമ്മിൽ അങ്ങോട്ടും ഇങ്ങോട്ടും വലിയ ക്രയവിക്രയങ്ങളോ സംസാരങ്ങളോ ഒന്നും ഉണ്ടാവണമെന്നില്ല. കാരണം എല്ലാവരും ബിസി ഷെഡ്യൂളുകൾ അങ്ങോട്ടും ഇങ്ങോട്ടും പോകുന്നു. ചിലപ്പോൾ ഞാൻ അവരെ കാണാറില്ല, അവർ എന്നെ കാണാറില്ല. സമയം കിട്ടിയാൽ അവരോട് സംസാരിക്കും. നമ്മൾ ഞായറാഴ്ചകളിലൊക്കെ ഉള്ള ദിവസങ്ങളിൽ അവരുണ്ടെങ്കിൽ ഒരു ഹായ് കൂയൊക്കെ പറയും. അതിനപ്പുറത്തേക്ക് എല്ലാവരും ജോലി തിരക്കിൽ പോകുന്നവരാണ്. അതുകൊണ്ട് തന്നെ എപ്പോഴും അവരെ കാണാറില്ല. ഒരു ദിവസം വീട്ടില് ഇരിക്കുന്ന സമയത്ത് ഇങ്ങനെ ബെല്ലടിക്കുന്ന സൗണ്ട് കേട്ടു, മണിനാഥം കേട്ടു. അപ്പൊ ഞാൻ ഇങ്ങനെ ഈ മണിനാഥം എന്താണെന്ന് അറിഞ്ഞ എന്റെ ജനലിലൂടെ ഉള്ളിലേക്ക് നോക്കുന്ന സമയത്ത് അവിടെ എന്തോ പൂജ നടക്കുക. അപ്പൊ കുറെ നേരമായിട്ട് അതുണ്ട്, നമ്മളത് കുറച്ചു നേരം കേട്ടു. പിറ്റേന്നും ഇതേപോലെ തന്നെ അവിടെ ഒരു 3-4 ദിവസത്തേന് അവിടെ പൂജകൾ നടക്കുന്നു. നമുക്ക് എന്തോ വലിയ പ്രാർത്ഥനക്കാരാണ് അവര്, ഇനി എന്താ ഇങ്ങനെ പെട്ടെന്ന് അതിലേക്ക് ഒരു മാറ്റമൊക്കെ വന്നിരിക്കുന്ന ഒരു ചിന്തയായി. ഏതായാലും എനിക്കത് ചോദിക്കണമെന്നുണ്ട്, പക്ഷെ എനിക്ക് സാഹചര്യങ്ങൾ അനുസരിച്ച് ചോദിക്കാനുള്ളൊരു അവസ്ഥ ഒത്തിട്ടില്ല. കുറച്ച് ദിവസങ്ങൾ കഴിഞ്ഞപ്പോ 2 പുരോഹിതന്മാരും വേറൊരു സഹായിയായ ഒരാളും കൂടെ ഒരു കാറിന് അവിടെ വന്നിട്ട് ഈ വീട്ടിലേക്ക് കയറി പോകുന്ന കണ്ടു. തിരിച്ച് ഇറങ്ങി ഒരു 1.5 മണിക്കൂർ കഴിഞ്ഞ് തിരിച്ചിറങ്ങി പോകുന്ന സമയത്ത് ഈ ജനലയിലും അതേപോലെ തന്നെ ഗേറ്റിലും ഒരു കൊന്ത കെട്ടിയിട്ടിട്ട് പോകുന്ന കണ്ടു. അപ്പോഴും ഞാൻ നോക്കിയാൽ എന്തോ സംതിങ് പന്തികേടാണല്ലോ. ഇന്നലെ വന്നത് ഒരു ഹിന്ദു മതവിശ്വാസവുമായി ബന്ധപ്പെട്ടുള്ള ഒരു പൂജകളോ മന്ത്രവാദങ്ങളോ അങ്ങനത്തെ ചെയ്യുന്ന ഒരാള്, ഇന്ന് വന്നിരിക്കുന്ന ഒരു പുരോഹിതനാണ്, അതൊരു ക്രിസ്ത്യൻ പുരോഹിതനാണ്. എന്തായാലും കാര്യത്തിന്റെ നിജസ്ഥിതി ഒന്ന് മനസ്സിലാക്കുന്നതിന് വേണ്ടി അദ്ദേഹത്തോട് സംസാരിക്കാൻ ഇരിക്കുമ്പോൾ അദ്ദേഹം എന്റെ ഗേറ്റിൽ വന്ന് മുട്ടി. അതെ, നിതിനോട് എനിക്കൊരു കാര്യം പറയാനുണ്ട്, നിങ്ങളോട് പറഞ്ഞാൽ മാത്രമേ ഇത് മനസ്സിലാവുള്ളൂ. ഈ രാത്രിയില് എനിക്കിവിടെ ഉറങ്ങാൻ പറ്റണില്ല. എന്റെ വീടിനകത്ത് ആരോ ഉണ്ട് രാത്രിയില്. അത് വരുന്ന ആരാന്നൊക്കെ എനിക്ക് വ്യക്തമായിട്ട് മനസ്സിലായി. രാത്രി വന്ന് എന്റെ കഴുത്തെ പിടിക്കും. പിന്നെ ഭയങ്കര അലർച്ചയാണ്. എന്റെ ചെവി വന്നിട്ട് ഇങ്ങനെ മൂടും. ഞാൻ ഏത് രീതി തപ്പിയാൽ അയാളെ കണ്ടെത്താൻ പറ്റൂല. ഈ വീട്ടിൽ ഒരു ആത്മഹത്യ നടത്തിയിട്ടുണ്ടല്ലേ, ഇവര് അറിയാമായിരിക്കും അല്ലേ ചോദിച്ചു. ഞാൻ പറഞ്ഞു എനിക്കറിയാം. നിങ്ങൾ എന്താ ഇതൊന്നും പറയാൻ? ഞങ്ങൾ ഇവിടെ വാടകയ്ക്ക് താമസിക്കാൻ വേണ്ടി വന്നതാണ്, നിങ്ങൾ ഇതൊന്നും പറഞ്ഞില്ലല്ലോ എന്ന് പറഞ്ഞു. ഞാൻ പറഞ്ഞു എത്ര 6-7 വർഷങ്ങൾക്ക് മുമ്പ് ഒരാള്, അത് വെച്ചാൽ ഈ വീടിന്റെ ഹൗസ് ഓണർ തന്നെ, അദ്ദേഹത്തിന് രോഗാവസ്ഥ ഉണ്ടായിരുന്നു. അപ്പം അദ്ദേഹത്തിന്റെ രോഗം ക്യാൻസർ ആയതുകൊണ്ടും ഇനി ഒരുപാട് കാലം ജീവിച്ചിരിക്കില്ല എന്നുള്ള ഒരു ഡോക്ടറിന്റെ സംഭാഷണമൊക്കെ അദ്ദേഹത്തിനെ ഭയങ്കരമായി ഡിപ്രസ്ഡ് ആക്കി. അദ്ദേഹം നേരെ കൊണ്ടുവന്ന് ആത്മഹത്യ ചെയ്തു. അത് കഴിഞ്ഞ് അദ്ദേഹത്തെ അടക്കമൊക്കെ ചെയ്തതാണ്. അതിനിപ്പം അത് കഴിഞ്ഞ് ഇവിടെ ഒരു ഫാമിലി താമസിച്ചിരുന്നു, ഒരു നല്ലൊരു ജോലിയൊക്കെ കിട്ടി, ഒരു വിദേശത്തേക്കൊക്കെ പോയി. പിന്നീട് നിങ്ങളാണ് ഇവിടെ താമസിക്കാനായിട്ട് വന്നിരിക്കുന്നത് അതൊക്കെ ഞാൻ പറഞ്ഞു. എന്നാലും നിങ്ങളത് പറഞ്ഞില്ലല്ലോ എന്ന് ചോദിച്ചു. ഞാൻ പറഞ്ഞു അത് പറയേണ്ട ഒരു ആവശ്യമൊന്നും ഇല്ലല്ലോ, കാരണം മരണപ്പെട്ട വീടിന് അത്ര ഒരു മോശപ്പെട്ട അവസ്ഥയൊന്നും ഇല്ലല്ലോ. അത് ലോകത്ത് എല്ലാവരും മരിക്കുന്നതല്ലേ, അത് നല്ല മരണം ഉണ്ടാവും മോശം മരണം എന്നൊക്കെ മനുഷ്യൻ ക്ലാസ്സിഫൈ ചെയ്യുന്നതല്ലേ എന്നൊക്കെ പറയും. എന്താണ് യഥാർത്ഥ പ്രശ്നം? ഇവിടെ പ്രേതമാണ്. പ്രേതം. അപ്പോ ഈ പ്രേതമുണ്ട് എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അതിനുള്ള ഒരുപാട് കാര്യങ്ങൾ. ഇപ്പം എന്റെ വൈഫ് ഇറങ്ങി വന്നു, അതേ ഈ മനുഷ്യൻ രാത്രി ഉറക്കമില്ല, ലൈറ്റ് ഇട്ടാണ് ഇപ്പൊ കിടക്കുന്നത്, ഞങ്ങൾക്ക് ഉറങ്ങാൻ പറ്റുന്നില്ല. രാത്രി ഇയാളുടെ കഴുത്തെ കയറി പിടിക്കുന്നു, കട്ടിലിനടിയിൽ പാമ്പ് കണ്ടെന്ന് പറഞ്ഞു. ഇന്നലെ രാത്രി ഭയങ്കര പ്രശ്നമായിരുന്നു. ഏതാണ്ടൊക്കെ തേള ജീവികളൊക്കെ പെരയ്ക്കകത്തുണ്ട്. വെള്ള നിറത്തിലുള്ള ഒരു വസ്ത്രം ഇട്ട ഒരാൾ ഇവിടെ ഉണ്ട്. ആകെപ്പാടെ ഡിസ്റ്റർബൻസ് ആണ്, ഒരു രക്ഷയുമില്ല ഈ വീട്ടിനകത്ത് ഭയങ്കര. അതുകൊണ്ട് ഞങ്ങൾ പൂജയാണ്. കടമറ്റത്തുനിന്ന് ഒരു അച്ഛനെയും ഒക്കെ കൊണ്ടുവന്നിട്ടുണ്ടായിരുന്നു. ഈ കടമറ്റത്ത് കത്താറുടെ പിന്തുടർമറക്കാരായിട്ടുള്ള ഏതോ അച്ഛന്മാരും ഒക്കെ വന്നിരുന്നു ഇവിടെ വെഞ്ചരിക്കുകയും പ്രാർത്ഥിക്കുകയും പൂജകൾ നടത്തുകയും ഒക്കെ ചെയ്തിട്ടുണ്ട്. പൂജാരികൾ വന്നു, മന്ത്രവാദികൾ വന്നു, ഒരുപാട് പൈസ ഞങ്ങൾ ചെലവാക്കി. ഞങ്ങൾ ചിലപ്പോൾ ഈ വീട് മാറും എന്നൊക്കെ എന്നോട് പറഞ്ഞു. ഞാൻ പറഞ്ഞു ചേട്ടാ, ആത്മാക്കളും ഭൂതങ്ങളും പ്രേതങ്ങളും ഒക്കെ മനുഷ്യന്റെ ഹാലൂസിനേഷൻസ് ആണ്. അല്ലാതെ അങ്ങനെ ആത്മാക്കളും ഭൂതങ്ങളും പ്രേതങ്ങളും ഉണ്ടെങ്കിൽ ദൂരെ ആത്മാക്കൾ നമ്മൾ ജീവിച്ചിരിക്കുന്ന ആൾക്കാരെക്കാൾ കൂടുതൽ ആത്മാക്കളല്ലേ ഈ ലോകത്തുണ്ടാവേണ്ടത്. അതൊരു മിത്താണ്, അല്ലെങ്കിൽ ആളുകൾ ഒരു കാലത്ത് അറിവില്ലായ്മയുടെ പുറത്ത് പടച്ചുവിട്ട ചില കഥകൾ മാത്രമാണ്. അത് നിങ്ങൾക്ക് അനുഭവിച്ചിട്ടില്ലാത്തതുകൊണ്ട് നിങ്ങൾ പറയുന്നതാണ്. നിങ്ങൾക്ക് അനുഭവം വരുമ്പോൾ നിങ്ങൾ എന്നെ കളിയാക്കുന്ന പോലെ തോന്നുന്നു. ഞാൻ ചേട്ടാ അങ്ങനല്ല എന്നൊക്കെ പറയാതെ സമാധാനിപ്പിക്കാൻ പറ്റുന്ന രീതിയിൽ, എനിക്ക് പറ്റുന്ന രീതിയിൽ ഞാൻ നോളജ് ചെയ്തു കൊടുത്തു. പക്ഷെ അദ്ദേഹത്തിന്റെ ആ ഒരു സ്റ്റാൻഡ് ഉറച്ചു നിൽക്കുകയാണ്. ഏതായാലും ഒരു 1 വീക്കിനുള്ളിൽ അയാൾ ആ വീട് വിട്ടുപോയി. ഇന്ന് ആ വീട്ടില് ഒരു പുതിയ ഫാമിലി വളരെ ഹാപ്പി ആയിട്ട് ജീവിക്കുന്നു. എനിക്കിനി നിങ്ങളോട് പറയാനുള്ള കാര്യം, ആത്മാക്കളും ഭൂതവുമുള്ള ഈ എടപ്പള്ളിയിലെ വീട്ടില് എന്താണ് യഥാർത്ഥത്തിൽ സംഭവിച്ചത്? ഒരു ക്യൂരിയോസിറ്റി ഉണ്ടാവില്ലേ നിങ്ങൾക്ക്? പറയാം. അമിത മദ്യപാനിയായ ഈ മനുഷ്യൻ, റെഗുലറായി അളവിൽ കൂടുതൽ മദ്യം കഴിക്കുന്ന ഈ മനുഷ്യന് ഡെലീറിയം ട്രെമൻസ് എന്ന് പറയുന്ന ഒരു സ്റ്റേറ്റിലേക്ക് ആയിരുന്നു. അതായത് ഒരുതരം ഹാലൂസിനേഷൻ, കാണാത്ത കാഴ്ചകൾ കാണുക, കേൾക്കാത്ത ശബ്ദങ്ങൾ കേട്ടു എന്ന് പറയുക. കാലങ്ങളിൽ രൂപങ്ങൾ പ്രത്യക്ഷപ്പെടുന്നത് തോന്നുക. അതായത് മദ്യം കഴിച്ചു കഴിഞ്ഞാൽ നമ്മളൊരു ഡ്രൗസി ഫീലിലേക്ക് പോകും, നമ്മുടെ ബ്രെയിൻ കൺഫ്യൂസ്ഡ് ആവും. ഈ സമയത്താണ് നമ്മൾ വൊമിറ്റ് ചെയ്യുക, അതുപോലെ തന്നെ നമ്മുടെ കാലുകൾ നിലത്ത് ഉറയ്ക്കാത്ത കണ്ടീഷൻ. സ്ഥിരമായി ഇത് ചെയ്തു കഴിഞ്ഞാൽ നമ്മുടെ ബ്രെയിൻ ഭയങ്കരമായിട്ട് ഡാമേജ് ആവും. ആ സമയത്ത് നമ്മുടെ സ്ലീപ്പിംഗ് സൈക്കിളുകൾ തെറ്റും, നമ്മുടെ ഓർമ്മശക്തി നഷ്ടപ്പെട്ടു തുടങ്ങും. അതായത് ഇന്നലെ നടന്ന കാര്യം പോലും ഇന്ന് ഓർമ്മയുണ്ടാവില്ല. നൈറ്റ് വാക്കിങ്സ് ഉണ്ടാവും, സ്ലീപ്പ് ഡിസ്റ്റർബൻസ് ഉണ്ടാവും, ഒരുപാട് ഉറക്കവുമായി ബന്ധപ്പെട്ട് അയാളുടെ ബ്രെയിൻ കെമിക്കൽസുമായി ബന്ധപ്പെട്ട് ഒരുപാട് ബ്രെയിൻ ഡാമേജുകൾ ഉണ്ടാകും. കാരണം ഈ മദ്യപിക്കുന്ന ആളുകൾ ഒരു പരിധിയിൽ കൂടുതൽ മദ്യപിച്ചാൽ പലപ്പോഴും ഇവർക്ക് താഴെ വീഴാറുണ്ട്. നമുക്കറിയാം, ഈ സഡേറ്റീവ് ആയിട്ടുള്ള ഒരു കണ്ടീഷൻ അല്ലെങ്കിൽ ഡ്രൗസി ആയിട്ടുള്ള ഒരു കണ്ടീഷനിൽ ഒരാള് വീണ് കഴിഞ്ഞാൽ, തല ചെന്നിടിച്ചു കഴിഞ്ഞാലും ആ തലയുടെ ഇടിയുടെ ആഘാതവും അതിന്റെ വേദനയൊന്നും അപ്പം അറിയില്ല. അപ്പൊ അത് ഒരു സിമ്പിൾ കാര്യമായിട്ട് എടുക്കാം. നമ്മൾ നോർമൽ കണ്ടീഷനിൽ പറഞ്ഞു വേണം പെട്ടെന്ന് നമുക്ക് വേദനിക്കുകയും, പക്ഷേ ബ്രെയിൻ ആ സിഗ്നലുകളെല്ലാം കൺഫ്യൂഷൻ സ്റ്റേറ്റിൽ കിടക്കുന്നുണ്ട് കൃത്യമായി ഉണ്ട്. പക്ഷെ ആ ക്ഷതമൊക്കെ ബ്രെയിനെ കാര്യമായ രീതിയിൽ ബാധിക്കും. ഇങ്ങനെ ബാധിക്കുന്ന ഒരു കണ്ടീഷനിൽ ആൾക്കാരിൽ ഉണ്ടാകുന്ന ഒരു പ്രവർത്തനമാണ് ഈ പ്രേതമുണ്ടെന്നും ഭൂതമുണ്ടെന്നും. അവരുടെ ചിന്തകൾ ഭയങ്കര ഇറിറ്റേറ്റഡ് ആയിരിക്കും. അവരോട് സംസാരിച്ചാൽ വഴക്കുണ്ടാക്കാതെ നമുക്ക് അവരിൽ നിന്ന് പിന്തിരിയാൻ പറ്റാത്ത കണ്ടീഷൻ വരും. എനിക്ക് പറയാനുള്ളത് ഇതാണ്: വീട്ടിൽ ആത്മാക്കളുണ്ട്, പ്രേതങ്ങളുണ്ട്, ഭൂതങ്ങളുണ്ട് എന്ന് പറഞ്ഞ് നടക്കുന്നത് കുറച്ചുകൂടെ ബുദ്ധിയുടെ, ലോജിക്കിന്റെ, യുക്തിയുടെ തലത്തിൽ നിന്ന് ചിന്തിച്ചാൽ മന്ത്രവാദികളെയും മാന്ത്രിക പ്രീസ്റ്റുമാരെയും ഒക്കെ കൊണ്ടുവന്ന് 25,000, 30,000, 50,000 ലക്ഷക്കണക്കിന് രൂപയെ നടത്തി പൂജകൾ നടക്കുന്നതിനേക്കാട്ടിൽ എത്രയോ സാമ്പത്തിക ചിലവ് കുറവുള്ള കാര്യമാണ് ഒരു സൈക്യാട്രിസ്റ്റിനെ കാണുക, ഒരു ക്ലിനിക്കൽ സൈക്കോളജിസ്റ്റിനെ കാണുക, തെറാപ്പിയും മെഡിക്കേഷനും ഒക്കെ ആയിട്ട് കാര്യങ്ങൾ മുന്നോട്ട് കൊണ്ടുപോകുക. അല്ലാതെ ആ വീടിനകത്ത് ഒരു ആത്മാവുമില്ല, ഒരു പ്രേതവുമില്ല. അവരുടെ ഹാലൂസിനേഷൻസ് അല്ലെങ്കിൽ ബയോകെമിക്കൽ ചേഞ്ചസുമായിട്ട്
that will be what happened. This is your final thing, right? This is where you are looking at the sleep profile. So where is the patient awake, and then how they are going into N1, okay, N2. This is N2, and the lower one is N3, okay. And where is your REM here? Which one is the REM? What color is the REM? So this is your REM phase. And how, ideally, theoretically speaking, how often should REM come? Once in every 90 minutes. So 15 minutes it should be there. But for this lady, how like she started sleeping at 24 hours. And when is the REM phase coming for her? It's coming at around 1:45 AM. Okay. Okay. And she's having again another REM phase that she's getting. So this is important because when you're looking at hyperapnea, overall you're looking at it, right? So you will, if it's an obese lady, I'm suspecting OHS, then I'll go to the REM phase, I will look whether there is a hyperapnea or apnea which is happening, whether there is a desaturation. Okay. And so you will look at what are the sleep profile, and based on that you will start looking into it. And then now you are going into raw data, right? So this is the raw data. The patient is in wake phase. If you want to reduce the size here, you will start reducing it so that it's not too cluttered. And the most important thing is you can check here how many second interval you want to look at. So what I have chosen was a 5-minute interval. I am choosing a 30-second epoch. Epoch is nothing but a single viewing screen. Is that how it is? So once you do that, what is this one? What is EMG here? Where is the EMG? It is on the chin. So what is that? That's a snore. And this is the ECG which is happening. So now I will keep moving. Okay. So the patient is still in the wake phase. You are having alpha waves. So I had reduced the size of the waves. So okay. And her baseline saturation, look at it. It is at around 93 and 94 for this patient. Right? And look at her abdominal breathing which is happening here. Right now the thorax is actually not getting connected. So that is why it's a flapping. should understand that. So if you want to have a, if you're having a doubt, then increase the size and see. If it is not increasing, then it is patient is not the lead is disconnected. This is how you identify. Connect பண்ணி மட்டும் விட்டுற முடியாது. So you're looking at the PNM, which is here. This is the thoracic movement. This is your pressure flow, which is happening. That is the line which is seen. Slightly reduce it. So the patient is breathing continuously. This is the thorax, and the thorax is connected. So in this patient, the thorax is not the lead is actually disconnected. Now going on to increase the echo so that it will be easy. So sometimes you will see she's starting to go into a good sleep and her saturation is starting to drop. Okay. Now here the pressure flow is what is happening here? This one. Please. What is happening there? Look at the previous breathing. Look at the breathing here. What is the size of the amplitude? What is happening here? Is it same? Okay, it is decreasing. It's decreasing by what? Is it completely decreasing or is it decreasing by half? So it is decreasing by half, and there is a saturation which is dropping. How much was the baseline saturation? It was 93, 94. Now it is coming down to 89. And what is the duration that it is happening here? Now I am in a 10-minute echo. So what is the duration that she is having this? So definitely it is more than 10 seconds. So that will be classified as a hypoapnea. Okay. And we didn't have a snore episode after the hypoapnea. Keep moving forward. So what is happening here? Again, so she is breathing fine, and then there is a hypoapnea, but the duration is not more than 10 seconds, right? So it is not classified as a hypoapnea then. And there is a rapid breathing which is happening here, and your okay, the snoring episodes are happening. Again, there is another episode of hypoapnea which is happening here. So let's go into the REM phase. So this lady, so far what we have seen, she has not had a apnea. She's only having a hyperapnea. So in females, we were telling, right, apnea is not that very common. They have more of hyperapneas. So now what I do, I take this one, I go to the phase where there is a REM phase, and then I now go into raw data. So yeah, ideally you should look at a 30-second epoch and then identify it. So, what is happening to the saturation now? In the REM phase, it is dropping. Okay, and flow is also reducing. And this is the thorax, which is abdomen, which is moving. What is happening here? There is a opposite movement of your abdomen and your thorax, which is happening there, right? And then after some time, they will start synchronizing. So this is your REM phase sleep, where there will be complete hypotonia of your muscles, which will be there, right? And look at this phase. So she is having a significant desaturation, and there is a opposite movement of your thorax and your abdomen, which is happening. Okay, and so how do you identify a REM phase? The theoretical part. There will be hypotonia, right? There will be complete hypotonia. So your muscles and everything will become this will be coming to a flat line, or it will reduce. The amplitude will start reducing. So this is how you will go through it epoch after epoch. You will identify whether that was a hypoxia or what is happening. There is an arousal where the patient wakes up, the amplitude increases, and then she goes back into a sleep phase. Now, coming on to the reporting. So this is how the report is generated. What is the patient's name and what is the time and bed. I'm sorry, TST and time and bed. Time and bed is when the lights and then you will start looking at there will be multiple analysis. What is the respiratory analysis? How many were obstructive, how many were mixed, how many were central, and what is the AHI is what we are going to look into. And again, you will define it into apneas in the REM phase, non-REM phase, and sleep. So even if you are having a AHI which is very less, in the REM phase, what happened is very, very important. And whether there were arousals that happened during your hypoxia. So this value, the respiratory event related arousals is very important for you to, even if your AHI is less, if the RARAs are there, then you put them on a C. Then you are looking at the RDI. RDI is the respiratory index, and this is very beautiful because how much was it in supine, how much was it in non-supine. So if it is on the right or left, so if the patient is snoring more on the left hand side, what do you do? Raise the head and lie down on the right hand side. That's a very simple advice which you give. Okay. And then you are looking at the saturation profile. So what was the number of desaturation indexes that is happening? So how many times did it drop more than 3%? And what was the baseline? So her average baseline itself is 90 only. And how many times it desaturated less than 90, less than 80? And this is important because if the desaturation is around 65%, the possibility of a cardiac event is very, very high. And then you look at snore. Which area they are snoring more, whether they are supine, right, left, where they are snoring more, and body position. So they have finished it here, but ideally you will also get a with the ECG, because we are having the ECG, will also get the rhythm changes. And sometimes if you look at it, the heart rate will go to 200 to 50 mm. So that time you will realize it is a apnea, sleep apnea, which is causing the arrhythmias. Okay, and as I said, they can also measure the blood pressure. So blood pressure variations can also be checked. So for ultimately this is, so when you get a report, the first thing that you have to look into is the still unit. So what I showed you, right, the 8-hour complete picture, the sleep quality that you will be looking into. Sleep efficiency is what I'm trying to tell is what was the sleep time, what was the sleep efficiency, all those also we have to look into. And on top there will be one single sleep study, whole sleep study in 8 hours. So that you have to look into. How many hours did the patient actually sleep? And if they come to the wake phase, so that is the indication of an arousal that is happening. So if it is more, if the patient is sleeping from N2 N3 again N2 N3, then that's good. But if they keep coming back to wake phase or N1 and then go back, then it's a very disturbed and multiple arousals are happening. So that's okay. So we'll wind it up now. Thank you all.
Zoom 35 போயிடாது எடுத்து விட்டேன். அதை எடுத்து
all sit together. Only these many people for this function. It'd be nice please. So,
லென்ஸ் மாத்துங்க லென்ஸ் லென்ஸ் மட்டும் நான்
Has everybody come in? Asthma center. Okay, okay. So come in front, sir. Okay, so now we are going to see as to how we are going to connect the patient onto.
We don't have.
Small group, I think I can. So we will see as to how we are going to connect a patient, and then when we are doing the come in front. When we are looking at the recordings, whether it is continuous or not. So basic instructions. First things first, when you're going to tell somebody for a come in for a sleep study, you need to tell them what they're expected to do. Okay, they have to continue all the medications that they will take. In terms of if they are on a sleeping pill, if they are on a beta blocker, if they are on any inhalers, everything they have to take. And we have to reassure them that it's going to be as good as sleep as they are going to sleep. And they have to come with comfortable clothes because they're going to have a lot of leaves.
யாரு யாரு நீ எந்திரிச்சு உன் வேலைய பாட்டி போயிட்டே இரு.
We will help you to sleep along. Now there are multiple leads that we are going to connect with the patient. So if you look at it, this is a somnomedics level 1 sleep study which is happening. Now all of you have seen Holter, right? Now this device is the final recording device. Now this is going to transmit everything through a Wi-Fi onto your system. Okay, and then if it is a level 1, as I said, there will be a camera recorder which is going to be there, and that device will be connected to your system so that you will be seeing the patient sleeping. So if they are tossing and everything, you will be able to see. All this instruction you have to tell the patient that they are going to have a video recording and they don't have to buy it. And if the attendant wants to come, they can do it. And any sleep lab will have a partition. The technician will sit on the other side and they will keep recording. Okay, and the patient will be sleeping. Now, why that is important? Because there are so many leads, it's very high chance that anything can get disconnected. So if it is getting disconnected, I will show you how the thorax was actually initially disconnected. So how the recording will not happen. That means the technician should reconnect it. Now how many leads are going to be there? So you're going to check into the EEG. When you're connecting EEG, you should have a good hand wash and it should be free of oil. Okay, so EEG, you are going to have the mastoid. Mastoid is going to be the ground. Okay, from the mastoid, you will examine, imagine an imaginary line from here till here. So 20% in front will be your frontal, 20% lateral will be your central EEGs, and 20% back will be your occipital EEGs, and mastoid will be your reference. And there will be a ground which will be there. So for any electrical activity, always you should have a ground, right? So that it is utilizing the electrical activity. Now somebody can ask whether this will produce electricity, whether you will get a shock. Answer is no. This just picks up whatever is the normal EEG that is happening in the brain. And then you will have the nasal thermistor, and then you will have a nasal cannula. So cannula will detect your flow. Okay, how much of air is going in and coming out. And this is your chin. Chin is your EMG. Okay, and there is a snoring. So they have this nasal cannula. So that's a snow sensor. So this many leads the person is going to wear and he is going to sleep. Okay, and you have to reassure them that he is going to still sleep. So in a snow sensor, it will identify the vibrations that is happening. Okay, and then this is your chest band and this is your abdominal band. This is your and for the your muscular thing, this will be your right PLN. Okay, and will be your left arm. You will connect it on the left hand, the inner part of the shin. So if it's a female, if you're not comfortable, you will connect it on the dorsal. But ideally on the shin is better. And can they turn to the sides? Yes, they can. Only thing, you should secure it so well that it should not come over. Now, this person, we have connected the leads and it is running now. Now, right now, he's in a big phase of sleep, right? So, you will, when you are doing the sleep study, you will have the recordings which are coming on the left hand side. So, that will be M1, M2, your E, and then there is something called the electrooculogram. Okay, eye movements, because that is important in your REM sleep. So right upper and left lower, these are the places where you want to connect the leads. And ECG. ECG, you will connect the, you will get only lead 2. So when you lead 2 leads on the right and on the B6 will be having a lead. Now apart from that, somnomedics also has a BP measuring possibility. So they will, we'll have to check the blood pressure at the beginning, middle and the end. And we'll be able to get the tracings of it, whether the pressure was shooting up or how it is through that as well. Leads
where will you connect that snoring?
Connect the snoring. Yeah, we'll show it up. And we can ask him to snore.
Snore.
So,
I'm not good.
So, actually I was asking. So on the left top corner, you are able to see that there's a red line and a wake, right? So like that, it will keep monitoring it through the thing, and then you will identify which phase of sleep they are on. Tabi, can you snore? So can you see the changes in the snore, the green color? Okay, he's increasing the size of the yeah. Tabi, basic of the so you will be able to see the snore pattern.
Hello.
Okay, now you take that nice deep breath you take. Now all of you look at the pressure flow. Okay. So can you see the coming?
Hello.
The blue line.
Hello.
One second. So breathe in and breathe out. So you will be able to see the pressure flow. Thorax and abdomen correct. Increase பண்ணுங்க. So you have something called as a vortex K, right? So this is your K complex which is coming here. So that will indicate your N2 sleep. And then you will have spindles. Spindles will be it will happen. So those are the spindles. And now here the patient's flow is coming down. Here. So whatever she was breathing. So hyperapnea என்ன சொல்லிருக்கோம்? Whatever was the previous amplitude, if it is reducing by 50%, and if there is a drop in saturation, and if it is more than 10 seconds, then you will mark it as a hyperapnea. So this is how you will start scoring. So apnea irukku, and there is a 10 seconds irukku, and there is a drop in flow, and there is a drop in saturation. Then you will mark it as 1. So in the money we will keep recording. So what is your AHI? Index 9. So time and bed calculate பண்ணனுமா the total sleep time calculate. So yeah, so per hour is how many hours the patient has slept. So sometimes time and bed is a total time from the patient is on the bed, right? From the time you lights off to lights on, and sleep time is when the patient starts going into the phases of sleep. So the total sleep time in the patient was the time and bed was 8 hours, time the total sleep time was also 8 hours. So the 8 hours, how many episodes of apnea happened, how many episodes of hyperapnea happened, divided by the number of okay, that's what the index that will do. Now, the same patient, I'm going to look into the report. So, this is what I said, recorded timing exam. Okay. And what is the total time in bed that the patient is having? Okay. And you will look into the respiratory analysis. So, it will give you again the sleep efficiency and all it will be. Whether it was good efficiency. Anything more than 80% is a good sleep efficiency. And the patient has slept well. And then it will give you the respiratory analysis, whether it was obstructive, it was a mixed or it was a central. Whatever is central, the pressure will be there. Pressure will stop. The flow will stop. The abdominal effort and the thoracic effort, both will stop. So how many efforts or episodes have happened? That will be. The most important in females is you may not have AHI, but the RERAs will be there. Arousals will be more. So that's what I said when you're looking into that sleep full 8 hours of study. How many times the patient has come into wake state is very important. Sometimes you will see if they are in end-to-end, it's very good. If they keep coming up to the wake state, that means they are having a very disturbed sleep. And then you will look into positions. Okay. Okay. Here again, you will look into what is apnea in REM and in non-REM. So REM mein nadakkalana, the study is normal. If you are getting a sleep one study, a level 1 study, and if the REM is 000, that means the study is wrong. You need to repeat the study. And how many apneas or hyperapneas? This is a significant thing because hyperapneas are more in REM. For females, that is what will happen. Hyperapneas are more common than apneas. Okay. And what was the AHI and what is the RDA? RDA is respiratory distress index. So that is also high. And also we will look into which positions, whether it was supine, right, left, home, which position the AHI is happening and where the RERAs are happening more. So for this lady, it is happening more on the right. Right. Number of desaturations are more on the right. Hyperapneas are more on the right. So you will tell this lady to lie down more on the left side. And then you look into the oxygen. So oxygen, what is the baseline saturation? What is the most minimal one? What is the baseline? Okay, and what is the desaturation maximum that is happening? Why this is important? Deepest desaturation. Anything that is 65% and below is it will have a very high correlation with cardiac arrest. And this is your snore and absolute snore and snore episodic. So snore index, where it is more. This lady is a female, don't snore much, right? So if in a male, if it is more, but the AHI is less, you're not having much of thing. Then we tell no sleep hygiene, which side they should lie down, how much of elevation they should have, all that we can tell. The other thing which they have left out here is the heart rate. So sometimes you will look at during a hyperapnea, the heart rate will go. So arrhythmias are very, very common. Arrhythmia index can come. What is the maximum heart rate, minimum heart rate? What is the blood pressure variations also they can show it. So the last slide will be like this, but usually you can't figure out anything from this. Normally,
Good afternoon, everyone. So we now come to the part of the event that all the PDs have been waiting for. We're now going to announce the winners or finalists for the quiz. 4 teams have been selected. So Dr. Deepika will announce the winners.
So the team that scored the maximum was Dr. Andrew Chevadurai and Dr. T.R. Are you guys here? Alright, you guys not here. So first team that comes on will be Dr. Khadija Seba and Dr. Final round. Alright, so the second round. The second team will be Dr. M. Annapurni and Nivedita. And Shri Balaji Mandura. Okay. And the third team will be from the Lower Medical College, Dr. Vignesh and Dr. Mahesh.
So the third team will be Dr. Ibrahim and Dr. Ram Prashant. The next team will be Dr. Idayatullah and Dr. Raghavina. You guys available here? Dr. Prashanti and Dr. Yamini. Dr. Varsha and Dr. Niranjan. All right, again from MGM Healthcare, Dr. Ansia and Dr. Dharani. I think we have PGs from MGM itself, 2 teams from MGM itself.
Raisa.
Dr. Khadija Zaba, ENT from MGM. Tell us your name. And Dr. Anupami from Psychiatric Medical. Dr. Videta from Sri Balaji Medical College. Team 3 is Kavya.
Dr. Ramprasad from ESA Medical College.
Is Kavya. Team 4. Both of you.
Alright, split night study is acceptable if the AHI is moderate to severe for more than 2 hours of study and minimum 2 hours of PA titration. The AHI is moderate to severe for more than 3 hours of sleep study and the minimum 3 hours of back titration. The AHI is moderate to severe for more than 2 hours of study with minimum 3 hours of back titration. It is not recommended over full night diagnostic and second night back titration. Good job, guys. 5 points to you. Pass on? Yes. All right, fine. So the next question. Technical team. Finish. One second. All right. Hello. Pass on. I'm sorry. Wait, I'm sorry. I'm really sorry. That was right. That was the right answer. Sorry. Yeah. All right, you guys get 5 points. Yeah. All right, team 1. This is the last round of the mix it up round. All right. All right. At what age do infants achieve nocturnal sleep consolidation? That's abolition to sleep through the night. 6 to 9 months, 9 to 12 months, 12 to 15 months, 15 to 18 months. Pass on. Sorry. The correct answer is the first one, 6 to 9 months. Okay. None of you get points. So the next question goes to you. Compared with wakefulness, NREM sleep is characterized by which of the following? Increase in sympathetic tone, decrease on blood pressure but no changes in heart rate, vasoconstriction, decrease in parasympathetic tone. Wrong answer. Pass on. D. Decrease in parasympathetic. Sorry, wrong answer. So the right answer is vasoconstriction. So none of you get points for this round. The next question goes to team 3. Which specific nucleus within the hypothalamus is primarily responsible for promoting wakefulness and suppressing sleep? Alright, suprachiasmatic nucleus, ventrolateral preoptic nucleus, dorsomedial hypothalamic nucleus, paraventricular nucleus. somebody like to tell me, please. Great job. 5 points. All right, so this is the last question of this particular round. Team 4, are you guys ready? In the evaluation of insomnia, what role does the actigraphy play and how does it complement traditional polysomnography? It assesses the circadian rhythm disturbances, complements PSG by focusing on sleep architecture, measures sleep latency, complements PSG by providing information on sleep-wake patterns. It records brainwave activity, complements PSG by assessing periodic limb movements. It monitors physical activity and light exposure, complements the PSG by offering objective data on sleep-wake cycles. What's it? DD. Good job. 5 points, you guys. Okay, at the end of the first round, we have team 1 at 11 points, team 2 at 16 points, team 3 at 15 points, team 4 at 10 points. Good job, guys. Hardly a little bit of a difference. You still have another 4 rounds, so I think you guys can make it up. All right, so the next round, all right, it's called syndromes. All right, in this, you just have 1 question per team. That's all in this round. Is team 1 ready? What is the name of the syndrome for kyphoscoliosis with sleep apnea? Osler-Weber-Retto syndrome, Gerstmann syndrome, Quasimodo syndrome, Pfeiffer syndrome, or Hanhart syndrome? Just guess it. It's okay. You're not going to lose anything. Or you might have -1. All right, fine. You don't pass it. Good job. 2 points. All right. Question to team 2. Which rare sleep disorder is characterized by a sudden and irresistible urge to sleep, often leading to unplanned and abrupt episodes of deep sleep throughout the day? Klein-Levin syndrome, fatal familial insomnia, exploding head syndrome, advanced sleep phase syndrome. Klein-Levin. Good job. 5 points to you guys. All right, team 3, are you guys ready for your syndrome question? What characterizes the sensory experience in exploding head syndrome? Auditory hallucinations during sleep onset or awakening, vivid and frightening nightmares, excessive daytime sleepiness, sleep-related panic attacks. Sorry, wrong answer.
Sleep-related panic attacks.
I'm sorry, wrong answer. The correct answer is auditory hallucinations during sleep onset or awakening. Right? So team 4, I think it's your question. Yeah. Which of the following is a common feature shared by many parasomnia syndromes? Increased sleep duration, impaired cognitive function, episodes occurring during specific sleep stages, absence of motor activity during sleep.
3.
Good job, guys. Episodes occurring during specific sleep stages. Correct answer. 5 points to them. All right, so that comes to the end of round of syndromes. We will not be announcing the scores for this round because it just had 1 question each. Coming to the next round. It's called transmit, another term for transmitters, neurotransmitters, all right? Even in this round, each team gets 1 question, all right? So team 1, yeah, ready? All right. What is the primary neurotransmitter responsible for promoting slow wave sleep or deep sleep? Norepinephrine, serotonin, adenosine, or histamine? Good job, guys. 2 points to team 2. All right. Which neurotransmitter is associated with the initiation and maintenance of REM sleep? Acetylcholine, serotonin, norepinephrine, dopamine. Oh, sorry, wrong answer.
Acetylcholine.
points to team 3. Alright, team 3. Which neurotransmitter is primarily released by the neurons in the hypothalamus contributing to wakefulness? GABA, acetylcholine, hypocretin, dopamine. Good job. Also known as? Great job. 5 points to that. How does adenosine influence sleep-wake cycles? Promotes wakefulness by inhibiting GABA, enhances REM sleep duration, suppresses arousal by inhibiting neurotransmitter release, stimulates orexin release during sleep. 2. Sorry, wrong answer. I'm sorry, wrong answer. So the correct answer is suppresses arousal by inhibiting neurotransmitter release. Okay, fine. Alright. So that comes to the end of our transmitter round. So the next round, it's called dose off, as in the dose for drugs. So it's about drugs. Alright. Okay. Which medication is used in the treatment of REM sleep behavior disorder? Lamotrigine, diphenhydramine, clonazepam, or zolpidem? Sorry, wrong answer. The correct answer is clonazepam. Alright. So team 2, your question on drugs. What is the primary mechanism of action of zolpidem in the treatment of insomnia? Activation of dopamine receptors, inhibition of serotonin reuptake, positive allosteric modulation of GABA A receptors, antagonism of orexin receptors. Sorry, wrong answer.
Option C.
Good job. Alright, 2 points. So, team 3, your question on drugs. Which of the following can decrease REM sleep latency? Amphetamines, barbiturates, Respirin, and selective serotonin reuptake inhibitors.
Barbiturates?
No, I'm sorry, wrong answer. Next one. Next team.
Amphetamines.
I'm sorry, wrong answer. The correct answer is Reserpine. Alright. Yeah, sure. Done. Treatment for narcolepsy type 2 are all except modafinil, methylphenidate, dextroamphetamine, venlafaxine.
Venlafaxine.
Good job. 5 points in this. Alright, so that comes to the end of our next round, that's goes off. Now, this is a really interesting round. Alright, it's a pictorial round. So solve the puzzle. Each frame will have few pictures. Alright. Some of them will be self-explanatory, some of them they'll have captions on them. But there'll be one answer which is common to all the pictures. Alright. So not multiple answers, mostly it's just one answer. Alright. So there'll be like 2 questions per team, but we'll again do like 1 to 4 and then 1 to 4. Alright, ready guys? So we have this topic through the day today. What should we do? That's an overall thing. Can you narrow it down? That's a very broad term of explaining. It's a syndrome. I can give you a clue. It's a syndrome. Time of presence. Sorry. What is it? What do you see? Good job. All right. Can you complete it? Yeah, you got it. Okay, all right, I'll give it to you guys. Anyways, obesity hypoventilation syndrome, also known as, good job, Pickwick syndrome, Sir Charles Dickens, and those were his tales called the Pickwick Papers, and that's your polysomnograph, where you have a drop in saturation. All right, I'll give it to you guys 5 points. Team 2, your question. All right, so these were 2 Salvador Dali pics in the British Sleep Society, which depict a certain sleep disorder. And this graph is very classical of that disorder. You want to name the disease. Time's up, very sorry. Next team. You don't get additional time. Please just tell me the answer if you know it. Minus if it's yeah, -1. Yeah. All right. Pass on. We don't pass on further. The answer is narcolepsy. All right. So team 3, your pictorial round. All right. So this is the statue of a water nymph. All right. She had a particular quality which she removed all automatic functions from her mortal husband. Inability of automatic breathing during sleep. All right. So this is a statue by Michael von Schwanker. This is part of a movie or a docu-series which won the Oscar, where there's a really small kid connected to a ventilator. Yeah, the disease. What is it? We had this topic through the day. Apnea? What apnea? I'm talking about one disease. What apnea? Good job. I'll give it to you guys. Good job. Central sleep apnea, that's correct. So it's also called as the Ondine's curse. Back in the, I think, 16th or 17th century, there was a Greek figure where she cursed her husband saying, if you leave me, I will take away your power of breathing or doing anything by yourself. Alright, so it's called the Ondine's curse or central hypoventilation syndrome. So coming to the 4th team, your pictorial round. Alright, this is a particular figure. And one of our speakers also put his photo on the PowerPoint. He's also the founder of ResMed. What is this gentleman famous for? He's created something, guys. He's also the founder of ResMed. Your time's up, by the way. Sorry. Pass on. Good job. Wow. Good job. Full name by any chance? Full name? All right. She said Sullivan. That's part of the answer. Also, what did he find? Good job. Great job, guys. So they get 2 points. All right. So the next question, again, this is the second round of the pictorial question goes to each one. Right? So this is a part of the PSG, the polysomnogram, right? So you can see that there are multiple leads. So you have the thorax lead, the abdomen lead, the saturation. Now, this epoch shows central sleep apnea with OSA, Biot's breathing, Cheyne-Stokes breathing. Good job, guys. 5 points to you guys. But can I know how did you come to Cheyne-Stokes breathing? There is. All right, fine. But the classical thing is it has a crescendo, decrescendo type of curve. All right, fine. Good job. 5 points to you guys. Team 2. So this is our very own Indian person, Sheshadri Rao. He was born in 1941, graduated in 1968, 1971. He was in the US. 1983, he published a letter to the editor of the Canadian Anesthesia Societies. 2017, retired from medical practice. What is the full name of this person and what did he publish? Of course, if you just get the name, you will know the answer of the other one. Any idea? No? One clue? Anesthetists are very famously like what's involved with this. Thanks, Abhay. You guys. So he is Mr. Sheshadri Rao Mallampati. He's the one who's classified as Mallampati. Alright, so team 3. So this arrow indicates what? I think Supraja ma'am took this topic 15 minutes before, and whatever, 20 minutes back. You guys concentrated on the polysomnograph. Along with that, what did she say? Good job. 5 points to you guys. Alright. Next team ready? This is the last question of the pictorial round. So this cartoon depicts patient information for a certain test. What is this? So you can see this individual, he wakes up, they connect leads, goes to sleep. Again wakes up, goes to sleep. He eats in between, he breaks for lunch, again goes to sleep, and then he leaves home. It's a patient who undergoes all this. So this is a particular test. What is it called? You will know it. I mean, it's part of the kind of sleep testing. Alright, thanks a bit. Sorry. Good job, guys. ENT is on a roll today. 2 points to you guys. Alright, so you can pass on the mic then. We have come to the end of the pictorial now. So we have, just the final round right now. It's called the Gen Z round because it's recent advances. So in this round, you have 1 question. Each team gets 1 question. So team 1. Artificial intelligent algorithms in sleep-related data analysis are primarily focused on assessing sleep architecture, predicting dream content, detecting circadian disruptions, monitoring heart rate variability. Surprise, but yeah, tell me. You have not answered. I'm sorry. Pass on. Good job, guys. 2 points for team 2. Alright, you guys ready for your question? What emerging technology or device has shown promise in treating insomnia by using non-invasive electrical stimulation to synchronize neural activity and improve sleep quality? Transcranial magnetic stimulation, cranial electrotherapy stimulation, optogenetic sleep modulator, neural resonance entrainment. Transcranial. I'm sorry. No. Good job, guys. 2 points to you guys. Alright, so team 3, are you guys ready for your answer? Question. In the realm of circadian rhythm disorders, what recent pharmaceutical advancement involves the use of a dual melatonin receptor agonist to regulate sleep-wake cycles in blind individuals with non-24-hour sleep-wake disorder? Lamiltion, dasimiltion, agomelatine, and melatonin extended release. Good job, guys. Nice. 5 points to team 3. So the last question of this entire quiz. You guys ready? Alright. What novel therapy involves the targeted delivery of low intensity focused ultrasound to specific brain regions implicated in various sleep disorders, aiming to modulate neural activity and improve sleep? Ultrasound sleep modulation, neuro-focused acoustic stimulation, transcranial ultrasound therapy, and sonic sleep enhancement. Sorry, wrong answer. Team A. Please. Pass on the mic. Want to take a shot? Good job, guys. 2 points to team 1. All right. Fine. By the time we have our scorers come up with the scores, I have some questions for the audience of whoever is remaining. So you can feel free to answer. Just put your hands up in the air. Don't scream it out loud. I'm sorry I don't have any prizes for you guys, but it's just for fun. Oh, we do? All right, great. Oh, nice. All right. So we have 4 questions, but we have only 2 gifts. So the first and the second people get the prizes. All right. The first person to answer the first question and the first person to answer the second question. All right, guys. So sorry, I'm going to scratch it off. The audience question might happen after this question, so we need a tiebreaker. All right. So team 1 and team 2 have tied at a particular score. All right. So I'll pick up the next question. All right. Whoever takes it, I think whoever raises their hand first. It'll be like a rapid fire round. Whoever raises their hand first, all right, will be made to answer. Okay. That's okay. You can hold the mic. Make sure that you raise your hand, please. All right. Are you guys ready? All right. Which specific brainwave pattern dominates the EEG during non? All right. What is it, guys? Good job, guys. All right. All right. So we have a prize for the third person also. All right. So I will answer I will call out the winners. Before that, we have 3 more questions for the audience, and you have 2 prizes. So you guys can feel free to answer. In idiopathic hypersomnia, the main differentiator from narcolepsy with long sleep time is sleep onset REM periods, sleep inertia, sleep efficiency, hypnagogic hallucinations. Please lift your hands. Do not answer out loud. We have a taker there. Your good name? Yeah, please answer. I'm sorry. Yes. Good job, Muthu. Fine. Our very own resident. Full disclosure, I didn't tell him the questions. Alright, so he gets the prize. Alright. Yeah, you can give it to him. Good job. Alright, fine. So we have one more question. Iron supplementation is effective in restless leg syndrome due to its role in dopamine receptor modulation, reducing central sensitization, alleviating peripheral neuropathy, enhancing GABAergic transmission. Please answer, ma'am. D. No, ma'am, I'm sorry. I said raise your hands, please. Document. No, I'm sorry. Yeah, no, sorry. No, that's not the right answer. Alright, scratch it off. Ma'am, only 2 answers. Alright, fine. The last question, for which we still have a prize left. EPAP, expiratory positive airway pressure, contributes to the treatment of OSA by reducing upper airway resistance, maintaining airway patency during exhalation. No, these people can't answer. Enhancing oxygen saturation, mimicking the natural respiratory cycle. Good job. Please answer. C. Good job. All right, you're good. Narini, good job. Can you just hand over the prize? All right, fine, done. All right, fine. Good job, guys. All right, I think we have the scores have come down with the prizes. I mean, with the finalists. All right. So, any guesses? The first place, and can someone take pictures, please? Yes. And Jairam sir, can you come over the stage? Sir. Monty sir. All right, we can have both of them. Both of our favorite consultants from MGM.
And both having the same color.
Same, yeah. The color, very great. All right, so our first prize winners with the cash prize of 7,000 rupees goes to Ram Prasad and Ibrahim. Okay. So the second prize winners are of cash prize of 5,000 are Nivedita and Annapurna. And our third prize winners, give it up for the ENT team. Good job. Radisha and Aroma. Thank you, sir. Thank you all for. Yeah, Muttarsan and Dharani. Yes. Yes, that's Dharani. Thank you, sir. Thank you all for staying back so late. I hope you guys had a nice time. Have a nice weekend further and see you guys again soon. Thank you. Sir, Jan, sir, a few words. Well, thanks.
Thank you for this wonderful quiz program. Thank you very much. A lot of very interesting questions and all. So very nice. So this is a wonderful program we had. So a lot of take-home points from the sleep medicine, sleep surgery aspect. So congratulations for all the winners. Thank you, Professor Mohan sir, for this wonderful person from morning to evening for full available. I know you are so academic, passionate about all. I know very well. You are the role model. Thank you all, guys. So we'll meet again in another session, another 3-4 months later. So if between anything, I will update you. So thank you very much. Thank you all.
Okay. There is no clinical practice without academics. That has to be integrated very nice and easy within our general practice that we do. Wherever you are, in a clinic or medical college or hospital and all that. So it's just for the youngsters, but just embarking on some kind of footage in clinical practice. Never lose touch with academics as well as these sort of programs. Today, when I said, I think Aroma and Zava, you can mull over it later. I mean, there's something which I wanted, it will be useful for you all also. See, even after 30 years of active practice, even when Deepika was a student in SRMC, I can tell you very clearly, today I sat through the day, I learned at least whatever little, I thought I knew quite a bit. But from all the lectures, including the questions in the quiz that she gave, at least my knowledge has enhanced at least 20% more. So these activities will definitely help. Doesn't matter if you lose your little tea coffee breaks here and there, but I'm sure this will invigorate your energy process to do little better for patients. If you understand the clinical problems of a patient with all these new gadgetry requirements, I think we can give better outcomes. Yes, it costs lost a little, but I think with good teamwork that we have and Dr. Jaraman and all, with at least our team, it's been, Deepika, you know, like the last 4 years, we've been up and down with so many common patients. We've done well for the patients.
I think we share mutual, like, patients at a huge level. I can't agree more with what Mohanty sir just said right now. Yes, conferences are fun where you get to meet your colleagues. You will have meetings of people who you're studied with and people who work along with you in other hospitals and all that. But along with that, even as postgraduates, yes, it might be like an academic session, but after you pass out also, right? Consultants, me, Mohanty sir, Jairam sir, they attending a conference through the day. They attend so many conferences. That's because at the end of the day, you will have at least 5 to 10 take-home points. All right, you might not be able to listen to all the lectures 100%, but there might be at least 5 to 10 take-home points, which might be a learning curve, which you might have probably forgotten, or probably you might have not known. So I think it's important that we attend these kind of academic sessions to enhance our knowledge further also.
And the only regret was Zaba had to use her delpad little quick to answer the last question. So, thank you very much for all that.
Thank you all, guys. Thank you, our NGM team of all the respective PGs and other thank you very much. Wonderful. I thank you, the technical team of our audiovisual mic and the floor people, everything. So thank you all. Have a nice day. God bless you. Thank you very much. Bye. Thank you. Tea, coffee. Ladies can have a coffee. Thanks.
Thank you.